not be cost effective in India. And now coming how to decrease the hospital cost. So by decreasing the hospital stay and by decreasing the complication rate. So studies have shown that if you compare robotic versus open, definitely the hospital stay is lesser. But versus robot versus lab, hospital stay is similar. So there is no advantage of lab or robotics. But the complication rate definitely is lesser than robotics as compared to open lab. So this study, as you can see, the hospital stay is comparable in lab and robotic radical prostatectomy, but open it is higher. Now, last part is the indirect cost. Patient convalescence, ergonomic benefits, and wider use in difficult cases. Look at that slide, that we know if he has a faster recovery of the patients, that will transforms into lesser hospital stay, number one, and a lesser cost burden on the patient. So this will translate into cost effectiveness of the surgery, number one. Ergonomics again, because lab costs a lot of ergonomic load on the surgeon, so that means converted into a lot of back pain, the surgeon will become less effective, less number of cases in a year, and eventually it will be less cost effective. So robotic has advantage over lab in this aspect. And then robotics can also be used for IVC thrombectomy and RPLND, which are very difficult cases, and these are indirect advantages, but cost cannot be evaluated. But these are some advantages of robot over lab, where we should talk about that these are indirect benefits, cannot be evaluated in the financial aspects. And therefore this study shows in European urology that any surgery we can make cost effective by making it more effective and by decreasing the cost of consumables. And last but not the least, the lack of industry competition. I think we know there is a monopoly of one industry right now, but we are expecting many more players are now in the market. That will decrease, number one, the number of instrument per case, per instrument can be increased, number one. Number two, the installation case will be decreased. Number three, they can have an older version of robot like we have right now, and we can use that as a cheaper alternative. And this is the last slide. I think this summarizes the whole suggestions. Number one, the cases should be judicially selected. Tier 4 cases should be avoided, as I said. Improved efficacy using a multidisciplinary approach by multiple disciplines, effective OR time use, and reducing hospital stay. And the complication can be decreased, then only we can make it cost effective. Reduce instrument protocol as per our SOPs. These are just suggestions, and more suggestions are welcome from your side because you are also very expert surgeons. Disposable, as I said, we are aiming that company will come up with a protocol of more cases per instrument. We have already forced bipolar, so we can use for 15 cases, and in the future we'll have more such instruments. But I think the basic thing still remained unquestioned is robot acquisition and maintenance cost. And that will be answered by more companies coming into the market, number one, which are cost effective and quality wise is good. And number two is, I think, they issue a scheme for developing countries, third world countries, and cheaper models like subsidized rates of robots should be introduced. Right now there is no such scheme. They have to introduce it. Only then it will be cost viable in a country like India. So thank you very much for inviting me here. And I want to invite all of you to our next masterclass. It is international international workshop in Delhi, 17-18 September, Hotel Lalit, and we thank you that you have given so much support for last 5 consecutive workshops, and we will be welcoming you there, and all the stalwarts sitting here across the world, they will be there, and we want to welcome you there. Thank you very much, sir.
Thank you, Anup. I think a lot of information in 10 minutes. I think it's quite a lot of information given into it. Let us come to one point for discussion. Rest all the things are quite common for everybody understands that. You said about the number of cases which will be the reason how you can get down the costs. At the same time, the lesser the number of cases, the costs are going to be more. The second point you said is about instrumentation usage, so judicious selection of instruments. If I say something saying that the initial starting of the career, everybody will be very judicious in their instrument usage so that their operative time is more, the cost should not go up. But you'll see all the senior surgeons at this point of time, they really look at how many instruments have they used. They are not. Do anybody disagree on this? Because their operative costs have come down, because their times have come down, they don't care about another additional cost because it makes them much easier and faster. So I don't think these two things go together. They don't go together at any point of time. As they become senior, the duration comes down, instrument usages are not looked into at all. So ultimately what matters is used by many people, as many surgeons as possible, increase the number of cases. It's the only way to cut down the cost by decreasing the maintenance cost and distributing among all the patients, and even the capex cost which gets distributed among the patients. So increase. The point what need to be done is you need to identify the centers in the place where can have a robotic program, where everything comes into and those things. With the existing competitive world in India, will it be possible is a biggest question mark. I think the topic is open for discussion. We have few minutes. We can have any questions on this, please.
So I just wanted to make one comment that I agree with Dr. Mallikarjun that number of instruments might not be in the mind of many of the surgeons, but still I will say many of our top surgeons who are the robotics using robotic technology, they definitely are using lesser number of instruments what they were using in the initial phase, and most of them are sitting here. They used to use more instruments in the initial learning curve. Absolutely. But now they've decreased to bare minimum instrument. Like I said, 1 needle driver, nobody is using 2 needle driver in any of the case. That is number one. Nobody using the harmonic and the muscle spheres in all the patient. Air seal again, very limited. So I think this comes by experience and automatically we imbibe in our practice.
Both the things. Actually, see, one point of the mind you'll feel that to save money. At one point of mind, your experience teaches you how to get out of the situation with the least possible existing facility. So both things.
It's a balance. It's a
balancing equation.
Balance between two. Yes.
Yeah, it's on.
To discuss regarding the forced bipolar, wonderful instrument, has a better grip. But sir, one experience that I had with forced bipolar, whenever you are running the ultrasound probe with the forced bipolar, it is not as smooth as it would have been with the ProGrasp or the fenestrated bipolar. So that is a challenge that you face, that you are actually reducing one of these two instruments, and when it comes to holding the your ultrasound probe with the forced bipolar, it is not as smooth as a device. So that is I wanted to share that experience.
So
I think one more factor which can reduce the cost is the acquisition cost. Like with the availability of many robots now, I think probably that can also reduce the cost.
Yeah, I think that's the answer in the future. We have more competitive companies with the same quality. Like we have already 4 players now in the country.
Anup, I doubt with this. I don't foresee any reduction in prices of robots in near future to come. You're addicted to it. Try to understand this point. You're addicted to it. They maintain a little variation of a 20% to just to see your patients. No technology comes very easily unless it has become old. So when it's new, it's new. Meditronics came with a company. If somebody is there in Meditronics, I asked them, why are your company who are just nascent into your field, why is it expensive than Da Vinci? Don't even know whether you have tested it beforehand, whether it's going to be effective or not. But still, it is evolving, they say, and still it is expensive. So don't believe this statement that they are going to become cheaper as the time passes by. The same statement is heard in the last 10 years, nothing changed.
So one, I just want to make comment that some companies intuitive like they have come with the concept of lease, and I think that has decreased the cost of acquisition. And this is the future, going to be future. They are going to lease you robot for many years. They will take care of everything. You will have to just pay per patient case some money, and that will take care of all the problems. So this is one thing which is coming.
I tell you, that's exactly an hope. I got all the things which are there in practice, which is possible by them. Try to understand your end point at the end of 10 years, what you pay out of your pocket is same.
Same.
So it is a trap.
So one way of
It's a way. How do you?
Competition brings the best out of us. We all know. You know, the more laparoscopic surgeons have come into the picture over time, the laparoscopy cost has gone down when we started. Now the point is, how do we negotiate with the robotic people? You know, we are the end users. Now going into detail, I am very, very confident. See, when I was a postgraduate, the Ciplox tablet, the Cifran, which came, it was rupees 50 per tablet. Same Cifran after 30 years is being sold at the cost of 2 rupee now.
Yeah, exactly. Even Da Vinci will sell it at 2 crores after 30 years.
In my
but it will not exist at that time. It will have something else.
I'll tell you. In my own institution, the new robo which is there, it can cost as low as 80,000 rupees extra to the patient including whatever number of instruments you use, whatever the facility is there at present. It is 8 plus the
This
laparoscopy.
is all relativity. This is what we are talking about is, say, the cost of 80,000 to 1 lakh or 1,20,000 rupees is a relativity. We are discussing about a possible. Is it expensive or
That's
not?
what I am
That's all.
coming to you, quote unquote. Now, as far as I was discussing with Da Vinci people for good 4 years, they were not ready to bring down cost even 1% to me. No discount in the total cost, hardly any discount in the maintenance cost. The day they realized that I am about to order the other platform, they came to me and offered me so many things. So many things. You will not believe me. Free conferences, free everything, low cost,
exactly what-
no maintenance
So
fee.
I
See,
think
but the
let's-
robotic
let's-
cost remains the same, right?
no,
This is
no,
exactly.
But now we are getting lot of.
Let us not do this. Let us not do this. Let us not do this.
Sorry, right now-
Let us see. These are all two things. Acquisition costs are different. Marketing costs are different. We don't club. Our mind says both together into one sector. It's not true.
I am saying capital cost will also come down by 50%.
I think we should respect time also along with money. So let's move on to the next session at this moment. Really sorry to interrupt this. Thank you very much, Dr. Anup, and wonderful discussion. I think we are moving to the next talk. That's a point and counterpoint. In 2022, does a robotic console surgeon need to have a laparoscopic background? Dr. Anup has already mentioned that which case has to be done by robotic and what to be done by laparoscopy. So let's see what Dr. Mallikarjun Reddy has to say about it.
Good morning, chairpersons, seniors and friends. And thanks Arvind for this. Actually you gave me a talk after I realized that ye Arvind kya diya yaar mere ko. When I went on to look at the data of what it is, because what we think does not come into the data. So I just looked at this data and then looked at what's actually what people are looking at and how people are looking at the training modules. So I got a good insight into what it is. But there is something also apart from the insight where we need to look at how we all operate on these particular patients. I have no disclosures to make. What is a robotic console? All of you know, but one thing I would like to say, it's the camera without a brain. So if you look at a laparoscopy, the camera has a brain. As a person who is holding the camera, he or she will follow you, or probably go away, come close, do whatever without you asking. But here the camera doesn't have a brain. It is you have to control the camera. You have to keep the camera there and you have to work where what the camera is showing. So that is one other thing. The second thing which I felt from transitioning from laparoscopy to robotics, you need to adjust to the magnification. It takes a little while in areas to adjust to the magnification. And you also need to adjust to the loss of the surrounding anatomy. In laparoscopy, we all look at a little panoramic view, and robotic, you really go close so you don't know what you are doing by the side. So, then why this discussion at all? The big issue is the robotic surgeons and the manufacturers promote direct promotion of the console from the open platform. And I will read out this. One of the assertions by the purveyors of robotic technology is what robotics represents enabling technology, whereby you enable a person to do minimal access surgery without a proper full training in laparoscopic surgery. Now, it's possible that the same phenomenon experienced with lap cholecystectomy may befall early patients exposed to robotic surgery. Now, people who just get on to the robotic surgery, the complication rates would be much higher. And the general surgical guidelines would be a problem, and you'll have to credentialize someone. But the biggest problem when you have more complication rates when you start is it will bring down your morale. And that should not happen for someone who is embarking on the next surgical platform. Now, what are the advantages of a laparoscopic training? First thing, you need to know how to put a port and where to put a port. And this comes from laparoscopy. Robotics, they would like to have do a Viris and then put in the port so that it doesn't leak. You can still do an open technique, but you need to know how to do an open technique. Otherwise, you will not be able to put a port which snugly fits and then does not leak. The additions, if you have a previous surgery, then you need to put a port in a place where you can probably access the abdomen, look inside, get the additions off, maybe with a single port, and then you need to put the ports appropriately. In laparoscopy, if you don't put a port appropriately, it is still easier to put one other port somewhere and then do it. But in robotics, your port is haywire, you are gone. Your instruments clash inside, your instruments clash outside, the robot does not move, everything is going haywire. So you need to be careful. That's where the laparoscopy comes into place. And by chance, if you have a problem, or if you're not progressing, or if there is a instrument malfunction, where do you fall back? You fall back on your laparoscopic skills. And the other important thing is the robotic also needs a good assistant along with the console surgeon, and he or she should know good laparoscopy. Otherwise, you tell some instrument, they'll pick up some other instrument. They need to go into those narrow angles. They need to, because the camera is not moving, it cannot show the instrument. They have to go exactly right to the place and then help you out. So you need a person with laparoscopic experience in robotics. Now let me get to the little studies that Gomez investigated whether the laparoscopic training benefits in completion of a basic robotic surgical task. And they had trainees who were new to both laparoscopy and robotics, and after a month-long course in laparoscopic training, and found that laparoscopic training improved robotic task performance, and extensive laparoscopic training but with no further exposure to robot whatsoever. Now when Kanitra et al. Looked at the transference of skills in robotic versus laparoscopic simulation, and they had 40 students, and then were ultimately concluded that when they trained on the laparoscopic surgical models, the robotic scores significantly improve. But if someone has trained on the robotic model, they cannot be a good laparoscopic surgeons. So the reverse is not true. So these lines represent here that the lower line which says that people with laparoscopic experience have a much better learning curve in robotics. So there are other people, Marcelo, who looked at significant differences in the performance of simulated robotic surgical tasks. These guys only looked at a simulation in laparoscopy and robotics. They looked at a peg transfer, they looked at sponge cutting, and these basic exercises, they said that there is no need for any laparoscopic training to do it. But urology is not just basic peg transfer. We'll also come to another thing. So there another Lucian who looked at, they analyzed 14 medical students and surgical residents with laparoscopic experience on simulators. The tasks were peg transfer, circle cutting and intracorporeal suturing. For the simple tasks, participants with significant laparoscopic skills were worse with the robot. And it was true with me. I had spoken to Anish sir once when he was starting robotics. We all went for this simulation. We were vexed to do the peg transfers and all. Every time the simulator would probably say 50 out of 100. But however, with the increasing task difficulty in terms of suturing and all, people with laparoscopic skills performed hugely better than the basic skills. So ultimately, can they be aided by laparoscopic training? Yes, the robotic skills, surgical skills can in part divide from the psychomotor skills or developed in laparoscopic trainer, and acquisition of robotic skills may be enhanced by a practice on laparoscopic simulator using the laparoscopic curriculums. Now this was one other study where the first image shows how a person, individual without any training did a cut with a robot. 1 month of laparoscopic training, and that is the cut after 30 days of laparoscopic training. So definitely laparoscopic training improves the robotic outcomes. So to conclude, after all this, unfortunately, if surgeons flock to robotic surgery due to market pressures and patient demands without adequate training in robotic itself, the likelihood of convincing such surgeons of benefits of the need for laparoscopy training before applying to robotics is low. In the same way, the open surgery for some conditions such as ureterolithotomy has become a lost art due to advances in endoscopic technology. Open surgery and even laparoscopic surgery may be increasingly rare as robotics becomes more prevalent and technology continues to advance. For the current practitioners who feel that robotics is a shortcut to minimal invasive surgery, it is doubtful that they can be convinced to take time to learn laparoscopy. And just before I just close off, this is the wound protector which we use to do a robotic transplant. This is 3,500 rupees. We don't need to use a gel pot which is 50,000, you can nicely put it inside, put the kidney and just twist it and then fold it. It just gets you the whole pneumo in. So thank you very much for this opportunity and hearing.
I think we'll have a discussion later on. I think let's call Dr. Mangesh Patel to put his views.
Mangesh is for no need for lab skills, right? You can put a finger and do it. What is there?
Yeah, very good afternoon, chairpersons, seniors, and my friends. As Dr. Mallikarjun sir has already mentioned the use of laparoscopy before robotic surgery, so I'll be talking against his opinion. So whether we need laparoscopic training before robotic surgery. So as everyone knows, robotic surgery has exponentially increased in last decade, and probably the reasons were improved ergonomics, dexterity, safety, ease of the surgery. Now when robotics came in around 2000, initially after the description from the pioneers, many of the established open and laparoscopic surgeon undertook robotic surgery, and it was followed without any standardized validated robotic curriculum. A very important word. But let's see about laparoscopy. Laparoscopy is there since almost now three and a half decades, but still in many of these institutes in US, a lot of urologists are not comfortable with laparoscopy. A large number of urologists don't offer laparoscopy at all. Few studies, like in 2004, when the peak of laparoscopy was going on, almost 80% of nephrectomies were not being done laparoscopically. Many of the urologists still do not do any laparoscopy in their career. Other studies, like 67% of the 600 respondents also revealed that they don't perform laparoscopy. So why is there a reason why people are not opting for laparoscopy? Is probably it's a technically demanding skill, and that's why diffusion of laparoscopic skills lagged behind. There are few limitations of laparoscopy, which include unstable camera platform, the limited motion, two-dimensional view, poor ergonomics, and a very important factor is a need of a very well-trained assistant who can hold camera or instruments. Now all these things were overcome by robot, and that's why probably robot is, it has overcome the technical limitations of vision and manual control of open surgery through minimal invasion. Now laparoscopy also has a little disadvantage, that it is a technically demanding surgery and intensive training is required. However, when the robot came in picture, like around 2000 or 2005, when it became available, most of the surgeons started thinking of opting for robotic surgery rather than going for laparoscopy. But many of them still have a assumption that everyone has to do a laparoscopic training before becoming a robotic surgeon. Now, there are, like when we review the literature about virtual reality and dry labs, the experienced laparoscopic surgeons were compared with new surgeons, and naturally the results are going to be better for laparoscopic surgeon. But construct validity is a term used for the simulation which determines the new surgeon and an experienced surgeon. I'm not saying laparoscopy is not required for robotic surgery. It is definitely required, but not the essential thing. It is used, as Mallikarjun sir said, for the access, for the anesthesiolysis, for multi-quadrant abdominal access, and of course it reduces docking time. But the question still remains, do we need a formal laparoscopic training for robotic to become a very comfortable robotic surgeon? So I have gone through the literature and how the robotic curriculum has evolved over last 20 years. Earlier when it came, everyone thought that laparoscopy and then robotic, that is a step between open laparoscopy and robotic. Now, when we see the curriculum at present, there are three ways we learn the robotic, and it is patient side training, console training, and of course non-technical skills like communication. Now, patient side training definitely as important is in patient positioning, pneumoperitoneum, port placement, and of course basic laparoscopy skill. But console surgery can be trained on dry and wet labs. Now, these basic laparoscopic skills like suction, application of clips, they are essential or required, but they all can be acquired through dry labs and of course robotic dry labs, and they are fine-tuned during the bedside training. Now, console training again is online modules, dry labs, wet labs or animal labs, and of course in the operation theatre. Few of the details about the VR simulators, like I'm sure everyone knows ROS simulator, DV trainer, Da Vinci skill simulator. All these simulators are used for getting comfortable feel on the console, and of course they replace or they can overcome the limitations of laparoscopy. In addition, there are procedure specific components which are now devised like host or maestro or DV trainer. Now, these all things make the console surgeon comfortable, and naturally the need of laparoscopy may be less. In dry labs, surgeon can practice, and it is cost effective. In wet labs on the animal models, we can learn these skills like handling, dissection, excision, and etc. And of course in the operation theatre, most important person will be a mentor for initial 10 to 20 cases. Now, so different team members are like training pathways are led, and which help in getting comfort for the robotic surgery. Now, this is the list, and of course the list is unlimited. Like most of the senior, those who are world leaders like Dr. Menon, Dr. Kulkarni, Dr. Srinivas, Dr. Vipul Patel, most of them are not laparoscopically trained, and they are still world leaders, and I'm sure most of you also, many of you must be not laparoscopically trained. If I review a little bit literature, most of the studies will say the laparoscopy is not required. Like in 2015, laparoscopy experience is not strongly correlated. Inexperienced students can do quicker and fewer errors. That was in 2003. Robotic dexterity was not significantly affected by laparoscopic skills in experience. The skills are transferable. So many more studies. Now, my opponent, Dr. Sir, might say again the access placement of ports is required, but nowadays it is included as a part of robotic surgery curriculum. So we don't need a separate laparoscopy training. And if someone asks me about mechanical failure, it's very rare. And if it happens, yes, the choice is with the surgeon whether to convert into laparoscopy open or give the best results with waiting and doing the robotic surgery later. And let's be a very practical point. Most of the busy urologists can't take time out for laparoscopy training. So we have to have something which can replace formal laparoscopy. So there are trainings between 2 days to 10 weeks, depending on individual, we can do it. And of course, mentor can definitely help, and building a team with the assistant surgeon can replace the need of laparoscopy. Thank you so much.
Wonderful, Mangesh. I think we don't have a rebuttal on this. Let me have one more question for this. I think this is already beyond time. You don't do any laparoscopy at all?
I do it, sir, but I don't, my question...
How do you?
No.
How do you do it now?
Sir, I'll honestly tell you, I was not at all laparoscopically trained.
No, I understand. I'm not denying that.
But
I'm not looking at this point what you're discussing. I'm least concerned. No, whether it is necessary or not, I'm not even questioning that. I want two issues which need to be sorted out. The basic point of this talk is entirely different, which we are missing. It's not the initial part of it. It's a later part of it which is more important. You are doing laparoscopy. Whether your learning of robotic skills has changed your laparoscopy? I'll ask this question both of you.
Sir, in fact, doing robotic has made me a better laparoscopist.
Right, how about you? You are a laparoscopy surgeon. Will it make your robotic this thing easier or difficult?
No, it made my robotics much easier.
Okay, both way side. So robotic is making his laparoscopy is easier. I'll come back. and your lap. But the question now is, do you think both are alike? They are absolutely different.
Yes.
Robotic skill is different, laparoscopic skill is different. They are not complementary. If somebody practices laparoscopy alone, it becomes a very difficult thing to do a robotic surgery. If somebody practices robotic surgery alone, it is very difficult. All the top leaders, what you showed, they never did a laparoscopy, nor they will do a laparoscopy. You are doing laparoscopy. So the question now is, how do you retain both the skills?
Yes.
That is what is the most crucial point of the day. It's not how to learn. Both are entirely different, but how do you keep the skills alive? Keep the indications clear. You are doing these cases by laparoscopy, you are doing these cases by robotic surgery. That's all. Your hand movement, your repetition of skill, your skill set will retain with you on both the times. That's the reason why you are still able to do laparoscopy and robotic surgery. You do to do 150 radical prostatectomies and then do a laparoscopic radical prostatectomy. You will find the difficulty then. You cannot be the same at that point. You do 110, 50 donor nephrectomy and do one donor nephrectomy with your robotic. You will not be able to do at that time. So keep the skill set on with a repetition of the same procedure on the same platform. That's going to be the way to retain the skill sets. Thank you very much. We don't have a discussion.
Yeah.
Thank you so much.
No, but the only thing I would just like to say is, if you have learnt your swimming when you are young, today I throw you into a swimming pool, you will still swim. So that is what is laparoscopy.
I understand.
I think
Otherwise also I have a robot to help me out. If I don't know also,
Before we close this, I think let's have an opinion from the audience, because everybody has an opinion on this. So how many people, yeah.
I agree. You have to maintain this one over a period of time. But the question from all the residents, the first question is that should I learn laparoscopy before coming to your fellowship?
Yes, the basic question is, there is nothing like laparoscopy and robotics, but there are basic surgical skills. Have you learned, how do you learn suturing? It's a basic surgical skill. So putting a port, doing a suction has become a basic surgical skill today. Putting a port doesn't mean that you are laparoscopy.
I advise with them is that at least you have a basic training. You know what is laparoscopy.
Yes.
That's all.
I
You need
think
not have an advanced laparoscopic surgeon. If you have a basic skill, that is sufficient to learn.
You need to have a basic skill.
Correct. And second thing, most important question, maybe out of this contest, all of them will ask, sir, should I also learn open surgery? We don't know how to do an open prostatectomy at all.
We have a long discussion on this.
I think let's call it there for this. But I think last opinion from the audience, that how many people in the audience think that laparoscopy is mandatory before robotic surgery? Raise your hands. Not mandatory, but I think it's helping. Let's put it
The problem is the selection. The selection of audience is wrong. Come take that. Everybody has gone through it, so everybody wants to raise their hand.
How many think that it's only robotic which is essential? That you don't have to learn laparoscopy. How many people?
Well, all black hairs will have it. All white hairs will raise their hand.
I think we had a wonderful discussion. Thank you so much. And
Let's go to Gentry.
Good afternoon, everyone. After
You're
that,
talking again on the same thing?
yeah, after that animated
different
discussion.
perspective probably.
Yes, after that animated discussion, my job is no longer easy. So at the outset, I'd like to thank the RUFCON organizing committee, Dr. Sabnis, Dr. Patel, and everyone involved for inviting me to give this talk. My talk is on robotic radical and donor nephrectomy with adult pyeloplasty. Is it an overkill to use the robot? So, I mean, if we talk about robotic surgery per se, I have no disclosures to make. We need to remember that all of these things are based on the shoulders of laparoscopic surgery. Almost 3 decades back, when Clayman did his first lap nephrectomy, that brought minimally invasive surgery to the limelight. Before this, nobody even talked about laparoscopy, nobody discussed doing any laparoscopic urology work. Immediately, it started being utilized for more and more cases. Within 3 years, the first lap pyeloplasty was done by Schussler et al. And a year later, Gill did his landmark study on a porcine model showing that laparoscopy does not affect the outcome of donor nephrectomy. This was a path-breaking paper, following which Ratner did the first human lap donor nephrectomy the very next year in 1995. And all of these 3-4 procedures which I talked about have withstood the test of time. More than 2 or 3 decades later, we still consider them as gold standards. That's not me saying it. That is what all literature and all evidence points towards. All these surgeries have done very, very well in terms of their success rates, in terms of their complications, in terms of being reproducible. So if we talk about changing a gold standard, is it time to change it to robotic surgery? The answer is yes, if the results or the OR time or the cosmesis or the ease of access to everyone here, and last but not the least, the cost is effective. The answer to all of these questions is a big no. So I can't say that robotic surgery is going to become the gold standard for any of these procedures. Especially if you look at literature in terms of evidence, everything which we are going to talk about now, including pyeloplasty, shows exactly the same outcomes, whether you do it with a laparoscope or whether you do it with a robot assistance. In fact, Ebert et al. In their paper finally concluded that those who are adept and skilled at doing good laparoscopic surgery should not feel that they are doing anything inferior by offering laparoscopy to their patients. There is really no need to use the robot if you are already adept at doing these surgeries. If you look at meta-analysis, this is not single paper, one RCT, one center. If you look at meta-analysis, the results are exactly the same. How can you improve upon 95% success rate? The success rate of a lap pyeloplasty is above 95%. Robot is no way going to overtake that, and it is exactly the same. In fact, on the contrary, what they found in the meta-analysis was the OR times were longer with robotics, and in fact it had a higher port site hernia rate in infants and children when a robotic pyeloplasty was done. The reason is very simple. Most of us who do a lap pyeloplasty use small instruments. If you're doing adult pyeloplasty, we use 5 mm instruments. You can go down to 3 mm instruments when you're doing an infant or a pediatric pyeloplasty. With a robot, you are stuck at 8 mm. And in a child with a very lax abdominal tone, you can get port site hernias very common. And the picture itself shows which one would be more cosmetic if it was a small child who's undergoing a pyeloplasty. If we look at the second thing, which is radical nephrectomy, this meta-analysis was the largest multi-center study of lap and robotic radical nephrectomies. It was done by the Rosula group, and it included the who's who of robotic surgery. What they found was that the OR time was in fact longer with robotic surgery, almost an hour more as compared to laparoscopy, which usually took around 2 hours. There was no difference in the blood loss or rate of blood transfusion, and no difference in the complication rate as well. So it begs the question that in the same paper, why is there an increasing trend in the use of robotics for radical nephrectomy and a decreasing trend of laparoscopy? We have heard a lot of speakers in the preceding lectures, and the reason is very, very clear. Once you have bought into the robot, once you have bought into the system, the tendency to do more and more cases is sort of a vicious cycle. So there is going to be an increase in robotic surgery, and I am not going to sit here and counter that. Having said that, we do need to ask ourselves a question. There is absolutely no evidence supporting the use of robot for a standard radical nephrectomy, but still numbers are increasing. Also, there is a massive fear of missing out in patients. We see a lot of patients in tier 1 cities where patients will come to you and ask for a robotic surgery. And this is a real life experience. Yesterday, I won't name the center, a patient who's been on a wait list for a robotic case comes to me and says, I want a robotic partial nephrectomy, but my budget is only 1 lakh. I'm not ready to wait for my other center to give me date, so can you do it in that much? So this is a farmer coming from Madhya Pradesh who's very clear in his mind that he wants a robotic partial. So there is massive fear of missing out in people as well, which is driving the numbers higher and higher. If you look at another recent meta-analysis, even this shows that robotic radical nephrectomy is not superior, whether we consider OR times or any of the other parameters. In no parameter it beats lap radical nephrectomy. In terms of donor nephrectomy results, lap donor nephrectomy in a meta-analysis was shown to have lesser warm ischemia time, lesser blood loss and lesser complications as compared to robotic. And still, some of us may still consider doing a robotic donor nephrectomy. The answer is a clear no. If you look at other parameters like length of hospital stay or serum creatinine in the donor or the recipient or post-op complications in donors, exactly the same whether you do a lap or a robot. So the only differentiator is the cost of the robot, the cost of the disposables and the repair contracts. They are all a huge burden on our system, and really there is no justification for doing these surgeries in a patient. In even more recent meta-analysis, which is actually still under publication, it's not yet published, they found the exact same findings, that all the parameters were equal, and the only thing which was worse was longer warm ischemia time. The logic is very clear. To retrieve the graft robotically, you need to de-dock, redock, do all of those maneuvers to get the graft out, and that increases warm ischemia time. We all know what longer warm ischemia time does to outcome. Some people do use a gel port for retrieval of the graft, but then it adds another level of cost to the surgery itself, which has anyways been the standard of care for the last 2 decades. Why do we need to change that? Also, there is a lack of availability. A lot of single ports were being used 10 years back, and all these were easily available. Now there is a problem in procuring these as well. The most important question which we need to ask ourselves is, what is happening to the cost effectiveness of this procedure? In a paper which was published in the Journal of Urology, there is a clear-cut 30% rise in the cost of the surgery when you use a robot versus doing a simple laparoscopic surgery. And that is the biggest weakness of the robotic platform. There is a huge initial investment of almost $2 million, a high annual maintenance contract of almost ₹1 crore, and a recurrent disposable cost, as pointed out earlier, of about 1.2 to 1.4 lakhs. And to top it all, not all robotic surgeries are covered by insurance. A lot of times we struggle, we keep on writing, we keep on giving data, we keep on writing letters to the insurance companies that this is required for a certain surgery. But again, they are all not covered. Video imaging and system errors have been brought down, but there has been no change in terms of the insulation used on the instruments. So the arcing, which is shown in green, and the broken instruments, which is shown in red, has continued to be high. So that says a lot about a system which has been evolving, no doubt about it, but still there are a lot of malfunctions. And in 10% of these malfunctions, the procedure has to be interrupted. 3% of the times the system needs to be reset. 7% of these malfunctions you need to convert to a procedure. Now what will you convert to? If you did not know laparoscopy, you would end up converting to open. And oftentimes, sometimes you need to reschedule a case as well. There are other practical problems with the robotic platform. There is absolutely no haptic feedback. There is a learning curve. All of us get used to it. You break a lot of sutures when you're starting off robotic surgery, and then by the 10th, 15th, 20th, 30th case, you start getting better at handling tissues and handling sutures. There is also a problem of not being able to turn the camera 30 degrees to the left or right, and also a lot of clashing of instruments, especially with the older SI robot, wherein if you had to do some dissection towards the ureter or some dissection towards the upper pole, then you would have left. All of these are non-tangible sort of advantages. I can't put it in exact words, but these are absolutely priceless in a case where the artery is above the vein, or in a case where there are multiple arteries. So this 30-degree rotation is extremely nice to have when you're doing standard laparoscopy. In terms of learning curve of suturing, this is again a case from last week, a lap pyeloplasty. This is for the juniors in the audience. You don't reach a certain level of adeptness at suturing till you have done your time in your dry and wet lab. I was fortunate to have MPUH as my alma mater, where I spent a huge amount of time in the dry lab and wet lab. So all of these suturing skills which you acquire are not done overnight or over a year or over 5 years. They are over a long period of time, honing your skills, learning from seniors, learning from different techniques to be able to do this sort of a pyeloplasty. And I don't see any reason why I should be doing a robotic pyeloplasty, or for that matter anybody should be doing a robotic pyeloplasty, if they can spend a little time on learning the basic skills, as Dr. Mallikarjun pointed out. In terms of cosmesis, again, there is absolutely no comparison. On the left, you have a laparoscopic standard case where you have 5 and 10 mm trocars. On the right, you have a plethora of ports put in, minimum of 5 to 6 for any robotic case. So there is just no comparison. When a patient asks me to show a picture of what you put as ports, I tend to not show it to them. If you have a residency program, you have to ensure that your residents learn laparoscopy as well. You need a dedicated team, a console surgeon, a bedside surgeon, reliable assistants, people who are interested. There is a high attrition in all of these, and it's very difficult to incentivize robotic surgery. All challenging cases can be done lap, whether it's a renal vein thrombus, the patient, which you can do to your next generation. There are a huge number of patients on wait list. We have to use our resources judiciously, and newer advances will keep on making everything better and better. Last but not the least, this is the last slide. We do have to worry about environmental impact in today's world. We can't just close our eyes. If you look at the biggest garbage dump in the world, called as the Great Pacific Garbage Dump, it can be seen from space. There are more than 2 million tons of garbage, and we are only going to keep on adding to this if we keep on using disposables the way we do in robotics. And it takes 450 years for just a simple plastic bottle to decompose. Now imagine what is going to happen to all the instruments we are throwing away after 10 uses. And on that, I would like to end that we've been using the same instruments for the past 8 years since I went into practice. The same laparoscopic instruments, they have done absolutely well. No loans, no AMIs, no AMCs. I don't understand why we need to do robotic for each and every indication. we have to adopt new tech only and only if it is affordable, accessible and reproducible. And I'd like to end my talk with one important statement, and that is reliance on technology should not compensate for lack of expertise. Thank you.
Wonderful, Jitendra. Actually, you have taken up half of my talk, what was going to come in the next few talks later. Doesn't matter, we'll manage in some other. I wanted to listen carefully so that I cannot pull down onto the same points at that point of time. But one thing, I'll ask you one question before you leave. Suppose, as an empirical scenario, you have both robot and laparoscopy, you offer both the things. The question of difference of this thing happens in the world is different than what you think as an evidence or what you feel as your own feeling is concerned. If a 25-year-old fellow with a PUJ obstruction comes, money is not a problem, give me the best offering what you can give, what will you offer?
So if the patient is keen on getting a robotic procedure done, that would be my only indication. And I'm again saying that's from my experience.
Why so? Why don't you convince him?
Because as I just told you that I would spend more time docking up the robot, getting everything done and...
No, why don't you convince him for laparoscopy?
Pardon, sir?
Why don't you convince him for a laparoscopy?
Yes, I would. That's what I'm saying, that I would convince him for laparoscopy.
For a laparoscopy. How many times it happens?
Almost all. All of these are...
All of never happens. Let us be very practical on it.
sir,
If you have a robot, you have a lap and the guy can pay for a lap. I hardly see anybody, even varicocele is done robotically. Am I right or wrong? It is. That's a practice. Let us say, I'm talking about you. I'm just saying that is the way. Is this whether they use the robot or not. There are many hospitals who build the robot, may not use the robot, but still happens. Unfortunately, we are all part of it. I understand what you said is absolutely true. But the question now is learning that expertise. How many of us or how many of the newer generation have got an opportunity like you to learn that expertise, have got that opportunity of that volume of exposure to learn that expertise, have got that opportunity of volume and their practice to practice their expertise.
I agree.
That's the unfortunate part of the scenario. That's the reason why we are not able to generalize these statements. As per you, a very learned man, a very expert, very well trained, you know the difficulties or the advantages, so you are deciphering it in a threadbare fashion. But when you come to a common urologist standing on the street, it becomes in a different ball game, wherein it is played by his limitations in his expertise, the forces from the community, the forces by the patient, forces by the corporate to use a robot.
I agree.
Thank you very much. I think that's all. I think.
Yeah, I think thanks.
I think we can go ahead with the last one. Robotic training transition from novice to an expert surgeon. Who was the novice? Santosh? I thought you were never a novice, of course.
At the outset, thank you very much, the organizers, RUFCON, for inviting me. Arvind is a very dear friend of mine, and he called me about a week ago. He said, somebody has dropped out, can you just take over this topic? I said, thanks for considering that I'm an expert in this, because you're giving me a topic which says novice to expert. But it should not be novice to expert, it should be novice to infinity, because the moment you think that you are an expert, you're stopped there. So, this is my, I'll try to be very quick because I've got too many slides to show. May I know before we start, how many are really in that stage of novice? How many have, they haven't started doing robotics? So I can see. Good to see that. So, see, in years to come, why we have had enough discussion about robotics, lab and open surgery, and it will happen in the next 2 days as well. But the issue is why robotic training is going to be essential in the near future. The first thing is that the marketing. They are going to infuse the system in no time. Many companies are coming on the horizon, and more robots will be acquired by institutes. So you will be compelled to learn robotic technology. There is no way out. Of course, as Dr. Jagtap said, that the ratio between the robotic equipment and the surgeon is there is a huge gap, but it is going to gradually get better and better. So, can you see yourself in 10 years' time, how many abdominopelvic surgeries will be done in an open way, barring the government institutes? I think most of them, we will be compelled to do them robotically, because that is the way forward. The robotic visualization is so phenomenal. If you have a dual console, and if it can be used as a teaching mode, then you cannot see anatomy any better than even the open surgery or even in cadavers. So I think it is a great learning tool. So most newbie surgeons will have limited exposure to open surgery and laparoscopy in years to come. With improved AI technology, the structured teaching program for robotics is also going to get improved over a period. So that's why I feel that robotic training is going to be essential part. Now when we talk about the stages of learning, one theory which comes, or one classification which comes in our mind is the Patricia Benner, who was a nursing theorist. And she used a model which was, the crux of the theory of her model was experience is not the mere passage of time or longevity. So you have to keep on learning. That was the crux. So we have to modify the stages what she had given. The stages of which is the transition from novice to an expert is divided between novice, then it goes to a beginner stage. I'll explain those stages to you quickly. The advanced beginner, a competent surgeon, proficient, and an expert. So there is one more stage which we miss out, and which starts before the novice stage, is zero to novice stage. Now what is this zero to novice stage? So from going from zero to novice, firstly you have to have passion about your own branch, be it urology, be it gastroenterology, be it colorectal surgery. You have to have passion. You have to have passion about learning minimal invasive surgery, whether it is laparoscopy or robotics. Here we are talking about robotics. You have to self-assess yourself where you will be practicing, whether you will be in a metropole where there will be easy accessibility to robot, or whether you will be in a small town where you are still seeing 10 more years before a robot is purchased. Acquiring knowledge by reading a lot of literature and the techniques which are coming through, and of course watching others either on videos or YouTube, wherever. There is a lot of data available nowadays, and your own videos later on. That is your transition. So the learning curve is exactly like driving a car. When you start driving a car, just try and remember yourself. You have to first get familiarized with the technology, the car, how it works, where is the gear, where is the accelerator. There has to be a mentor who is telling you all those nuances about driving the car. Then you have a dry run. Then you are driving on a plain ground, and later on you start driving on bigger roads, busy roads. Robots is the same thing. There is a initial inquisitiveness, then you start learning, then you start watching, learning about the equipment, dry run, wet run, and then you start actually operating. If you started learning to drive, and if you have a gap of few months, your skills are going to go down gradually, and same thing happens with the robot. Many surgeons, they drop out from the advanced beginner stage. I have overheard some surgeons saying that, senior surgeons saying that doing a robotic prostatectomy is not a piece of cake, because if you don't get enough cases, your skill level is going to go down. So you have to keep on doing consistently. So unless one gets hammered in the right manner, goals will remain non-fathomable. So who is a typical novice? So novice will have no experience. He's extremely focused with his tasks and skills. He follows all the rules. He doesn't want to break any. He's relatively inflexible. And when should we apply? When should we put these novices in the training program? So generally I would say in the first year of urology training program, I'm not talking about the robotic training program, the first year of urology training program, we should start developing this novice population. And that will be in the form of console training, mainly with the simulators. The next level is the beginner. Who are the typical beginners? So they have some experience. The typical beginner will have difficulty in coping with changes and has some anxiety which could affect his performance, his or her performance. The previous experience may be being a bedside assist. That is a classical example which we find nowadays with our bedside assistants. And it should be incorporated at the second year of urology residency. This is our arbitrary. There is no hard and fast rule, but we have to structure a program eventually. It has to be done under mentorship, of course, and the initial robotic surgical steps involved for the beginners would be adhesiolisis or dropping the bladder or reflecting the colon before you embark onto the main procedure. This is the most crucial step, advanced beginner, and most of the surgeons who give away or give up doing robotic surgery at later part is if they fail to cross this level, which is the advanced beginner level. You need at least 1 to 2 years of experience altogether. The time management is extremely important in this step. You have to plan the surgery, you have to be analytical. The critical skills start developing at this level, and this should come in the picture after second year of residency. And what surgeries could be incorporated in this program, which will be lymph node dissection, dissecting hilar structures or the ureter, and maybe DVC suturing once you cross over with the initial step. The next step is going to be competency, or it is also called as sub-expert. Here you have to have at least 3 years of experience. The change is drastic here. From having a fragmented vision, you move on to a holistic visualization instead of parts and pieces. Decision making is no more labored. It is all happening at supraconscious level. You can complete at least 80% of the task. Again, let me remind you, this is done under mentorship, so you cannot do it on your own. One can start identifying the wrong planes, can identify limitations. You know your own limitations, where you should stop or where you should cross your boundaries. Will realize on-table complications, and it should happen post-residency or during your dedicated robotic fellowship program. So RPLNDs, PLNDs, which is a pelvic lymph node dissection, simple nephrectomy. There was a debate about doing simple nephrectomy with robot, but yeah, that should be incorporated. Pyeloplasty and initial part of the prostatectomy. And last level is the proficient before the expert level is reached. So person has achieved 100% competency. I think most of the people who have worked 5 years on robot will be in this stage. They start exploring variations of your procedure, completing the procedure without a mentor or proctor. They can troubleshoot easily, minimal complications, can match standards of their peers. They are well aware of time, blood loss, and how to do minimal tissue handling. And everything is happening again at supraconscious level. Now the expert level is very important. Very few will reach to this level. They are pushing the boundaries all the time. They are devising new techniques, new technologies, new inventions during the procedure or even with the instrumentation. They have their own technique. They develop their own technique. DVC ligation may be in a different way. The division of the DVC, whether you do it or you don't do it, you decide. Periosteal stitch, whether to do it, not to do it, you decide. Seminal vesicle first. Now if you tend to watch Dr. Vipul Patel's original videos, you will see that he never used to divide the vas difference. He used to just pick the seminal vesicles, he used to run it under the vas and pick it up so that it gives a good retraction. That is his own technique, and then later on he changed it. So you start doing next level surgeries, which may be the vena cava surgeries, RPLNDs, and you start proctoring others as well. Now mind you, expert surgeon or expert robotic surgeon doesn't mean that they are good teachers. They may not be good teachers. They can be good surgeons, but not necessarily good teachers. So this was a study where they highlighted, this is Indian plus the study done by Dr. Alavat and Vatikuti. So the successful performance of a task requires 2 types of knowledge: domain knowledge, which is theory-based, and technical knowledge. Now there is a vast difference between novice and expert, which I told you just now in the last 5 minutes. But the striking difference or the drawback of an expert is generally they can potentially compromise new learning, and that is a drawback which everybody should be aware of, that we should not stop learning. So always look for the safety first, your own safety. Case selection is very important. Patient safety, high risk patient should be avoided in the initial stage, and the machine safety. If you don't look after the equipment will not look after you. The skill levels you can see, as I told you, advanced beginner, people generally take a U-turn from that level. If you don't progress beyond that level for whatever reasons, you are not going to achieve to that proficiency or expert level. So why do surgeons give robotic surgery? It may be lack of regular access to the machine or the mentor, lack of adequate influx of cases, longer learning curve, maybe for various reasons. And if you're not being able to deliver the pentafactor, just for example, robotic prostatectomy, we now look at the pentafactor, and if you're not being able to deliver any of these components, you may have to. So average number of cases to learn robotic assisted surgery, which when they cross advanced beginner thing, is the urological surgery will always have little bit of complexity, and it takes at least 45 to 50 cases before you reach to that advanced beginner stage. So the cascade of important steps, I don't need to mention it, there are a few more slides remaining, I will quickly run through. So how one should progress in robotic assisted urological surgery? You can begin with robotic prostatectomy. That is the safest surgery to begin with, because highly unlikely you are going to kill a patient either on the table or later. So that's what they say, you start doing robotic prostatectomies, don't do robotic nephrectomies to begin with. The moment you hit the renal vein or renal artery, potentially there is a you can lose that patient on table. So always start with prostate, then go with simple and radical nephrectomy, pyeloplasty, VVF repair, then partial nephrectomy. But mind you, there is a time constraint for partial nephrectomy, cystectomy, conduit cystectomy, neobladder, RPLNDs and IVC thrombectomies. Renal transplant, I have put it in the last because there are 2 lives involved, and it is a very time sensitive surgery. The methodologies, Dr. Mangesh Patel had touched base earlier, there are different methodologies, dry lab, wet lab, simulators, and they had seen that the Proctor guided group demonstrated decrease in damage to the vital structures and decrease in the number of unnecessary needle piercing as compared to the simulator. But there are studies who have shown, they have contradicted the study which was mentioned earlier. So bottom line is, if you are a keen learner, whether you learn with simulator and then later on with Proctor, or whether you directly go on a Proctor, there is hardly any difference. Dual console, yes, it is a very good tool, very expensive to have it. The only striking thing of dual, or the advantage of dual console, is with the vascular surgery. The second surgeon can take over immediately when there is a need. So when person is doing vascular anastomosis or vascular surgery, dual console comes very handy. So the impact of robotic single or dual console, median number of surgical takeover was higher in dual console. Complication in the dual and single console were similar. No difference were observed in the number of surgical steps performed.
I think we'll have to.
Sorry. So basically, I think the take-home message is: be open, be humble, be consistent, keep patience, don't get bogged down with any complications if they happen. Be teachable, and you should be aware of time, space, and permission to reflect. Thank you very much.
Perfect. I think you have made a lot of material into it, and I think it's if I can summarize 4 stages: unconscious incompetence, conscious incompetence, conscious competence, and unconscious competence. I think the most careful thing should be conscious competence, where everybody fumble, become arrogant, and make more mistakes. You should get involved into that unconscious competence wherein new things evolve without your knowledge. They are not planned inventions. They happen, which is observed by somebody and presented to him, saying that you have done something different, which was not seen by me before. That's what happens. Thank you, Santoshi.
So I have one question. So if you are in a stage of expert beginner and heading towards the expert, and if in your OPD patient asks that how many procedures you have done before this, what you are offering to me, how to come out of this kind of situation? Because you can't tell a lie also that you are expert, you have done 1,000 and 100, and the moment you will tell that I have done 100, I have done 50, or I have done 40, might it be possible that you may lose the patient and patient will not come? Now, it's very common in our center that patient, they come and they ask like, okay, what procedure you are offering to me, how many you have done till now?
It's called credit card.
Yeah.
Everybody should have a credit card, how many procedures and how many complications.
No.
We're great in painting lies in front of us.
We know that we are smart enough to
So the answer to that is very straightforward. See, when you're a beginner, you're obviously doing these cases with a mentor. So you have
I'm talking about expert beginner situation.
expert beginner. So you have to give the clear-cut number that this is a new technology. I have exposed to this in the last whatever months or years, and this is my number. But so far, whatever surgeries I have done, the outcome has been comparable to my peers who have been doing it, if it is a correct figure. And I think you have to be truthful to them, because later on, if there is a medical legal issue, you're safe here. And patients are asking these questions right, left, center. Forget about that. Last week I had a patient, he asked me, "Doctor, do you preserve the wheel of Aphrodite?" This is the question asked by patient's relative, and these questions are going to come.
I think you got the answer. Wheel of Aphrodite, right. Thank you.
Thank you.
Thank you, sir.
I would like to thank all the moderators and speakers of this session for the wonderful session. Now, once we are done with the basics of robotics, let's get ahead towards insurance for robotic surgeries, the current status. May I welcome on stage Mr. Rajveer Bhaskar and Dr. Sanjay Adla for the proceedings.
Now, before we start, I think the working lunch is available downstairs. Those who wish, there is no formal lunch break. Those who wish to have the working lunch and have some light refreshments, please go ahead and eat the lunch downstairs. Thank you.
Thank you so much. So I'll quickly walk you through the current insurance coverage landscape for robot-assisted surgery, and then Dr. Adla would be helping us understand how to address some of the implementation level challenges, especially the rejections, how to handle them and how to respond so that patients can get access to RAS procedures. So before I begin, I wish I had access to voting pads, but if I may ask all of you who are sitting here in this August forum, do you believe RAS is covered by all private health insurers in country? Can I see some hands who believe it's covered by all? Well, that's surprising, very few. So all private health insurers are not covering? Is that the belief? None of them are covering. Well, here is a pleasant surprise for you all. Yeah, as per...
The last thing I had was a fantastic article in the newspaper where IRDA said that robotic surgery has to be covered.
Yes, sir.
But till now, not even once has been covered by none of the insurance companies. What have? I have empaneled with everything other than ICSA, none of them covered it.
Well, sir, here's a pleasant surprise. And
give me a document, I'll sue them all through this.
Yes.
Give me a document, I'll sue them now.
Yes, I'll provide you that necessary document. So if you look at the IRDA circular, in 2019 they issued this guideline and asking all the health insurance companies to provide coverage for all the modern treatment methodologies. And robot-assisted surgery is part of that guideline. And because later on COVID came, so insurance companies had time for 1 year to start implementing this policy. So beginning September 1, 2020, all the health insurance companies in country revised their plans, and now they do provide coverage for robot-assisted surgery. It is procedure agnostic, whether it's benign or malignancy procedure, insurance companies do provide coverage, and moreover it is true for all the existing policies as well as the new policies which these insurers bring to the table. So in a nutshell, they have to provide coverage provided it is medically relevant. And then what IRDA did not specify though was to what extent these companies should be providing coverage. So there is some variation when you look at across industry. There are some companies who understand the value of RAS. They started implementing, including RAS coverage in their policies without any capping. And then there are companies who still they do not believe what additional value RAS brings to the table. So they have capping from 50% of some insured amount to up to 100% of some insured amount. So if we look at insurance companies, there are close to 40 companies as such in the market, but majority of the market, around 80% market is held by 10 companies. Which are those 10 companies? The first segment is stand-alone health insurers. These companies are specialist health insurers. Star Health was one of the first one who started providing Mediclaim policy in country. So what you see here on your left hand side, the first column is the name of these 6 companies. They collectively hold 30% of total market in India. And what you see in subsequent columns is their various health benefit products, and against each of these products you see green ball, dark blue ball and light blue balls. So all the green balls means the RAS is covered up to 100% sum insured amount. There is no capping at all. Some of the dark blue balls which you see against Aditya Birla plans, they did not specify explicitly to what extent they provide coverage. So it depends upon the individual case to case basis. If the proper documentation is provided, these companies do reimburse patient up to some insured amount. The challenge in this entire group, in this standalone health insurer group, is with Star Health, because they have huge variation. If you look at the right hand side lower corner, depending upon the sum insured amount, the coverage varies, but they cannot again say no to RAS. All these payers have to provide coverage. Other 4 companies which largely hold up to 50% of total market are the public sector non-life insurers, the so-called GIPSA companies. So we have New India, Oriental, United. These companies, although there is significant variation, Oriental provides coverage only up to 10% SI, but again they cannot say no. New India has recently came up with new policies where they started providing coverage up to 100% sum insured amount. Similarly, United provides coverage for all the malignancies, but they have capping for benign procedures. So the bottom line is these companies started providing coverage, and this is the first segment, standalone health insurance. These 6 companies provide coverage adequately across all their plans. However, the challenge is still, even after including coverage in the policy, patients struggle to get their claims approved in hospital. So in last like 12 weeks, I was able to visit 23 centers across country. And if you look at the insurance claim rejection rate for RAS procedures, it's more than 50% in these centers, which ideally should not happen given that the kind of coverage these payers anyway provide. So what are some of the excuses which these insurance companies use? Generally, whenever a patient walks into a hospital, the first thing, like once the diagnosis is done and when the procedure is decided, the insurance desk, which is commonly referred as TPA in hospital, they will file the pre-authorization approvals and they submit various claims, and sometimes they do get queries from the health insurance companies. And some of the common queries are, like you can see here, this is from Star Health Insurance. They say because of so and so clause of our policy, it is not covered, which is not the case. In same policy, if you read the document, they have clear-cut defined to what extent they cover RAS. Similarly, given the kind of stand the regulator has taken, can they deny claim citing any clause? No, they cannot. Eventually, all these patients were able to get benefits because TPSL was empowered to, how to handle these queries by insurance companies. This was again by Vidal Health. Now Vidal is a TPA. These are the third-party administrators who just administer claim process for all these insurance companies. This denial was for partial nephrectomy, like robotics is not covered. But which was not the actual case. When the TPA fought back with the proper justification and documentation, patients got the approval. This one is from Star Health. They again asked a query, why do you need robotics over conventional ones? So if you look at the IRDA circular, where they have mandated all the health insurers to provide coverage, they put one word over there, if it is medically relevant. And that's what being questioned by the health insurance company. Is this procedure medically relevant? If you provide a proper clinical justification, if surgeon provides that document, eventually insurance companies do approve the claim. Then there are some who explicitly ask for that document. Now here this one is from ICSA Lombard. They are asking for a letter from the treating surgeon, why do you need RAS for this particular case? So similarly, there are various hospitals and there are various companies who, even though in their policy they have already included coverage for RAS, but still they question why the hospital is, or the particular surgeon is going for robot assisted surgery in that case. And many of these rejections are go undisputed, and that's what results in patients not getting actually benefit of RAS surgery. Now, how to handle some of these challenges? I would like to invite Dr. Sanjay Adla, who would help us assist, help us understand how to address these queries and how to make sure that eventually TPA can get approval for your patients. Thank you. Over to you, Dr. Adla.
Thank you. Just summarizing what you have said. So every insurance company covers robotic surgery, but to variable extent. Is that the summary?
Yes.
Okay. So that's the take home for the last 8 minutes, is that they should be covering, whether they cover 10% or 100%, we got to negotiate and see.
Yeah.
Okay. We have been in this process. When I was in England there is social medicine. So all operations can be done on the NHS, and because of the cancer guidelines, we had to do it within 28 days. And the insurance company would pay the patient £2,000 to have the same cancer surgery. All the investigations are done private. They would pay the patient £2,000 to go and get the surgery done on NHS. So these are practices around the world, and whenever a robot is there, access to robot surgery has to be discussed at the societal level. So that's what we are facing. Compared to what Malik sir has said, in that no insurance company covers, at least for me about 70% of the insurance have been covering. Probably Hyderabad, Apollo, Jubilee Hills. Yes, so around 70% have been covered, and probably the only reason is that every rejection I have written back to them. I have written 2 or 3 letters saying that, okay, this has to be cleared for so and so reason, he's a young patient or whatever the reason, but nobody has at least said zero, we are not going to cover it at all. They have covered to certain extent. So it is our fight to take it to the insurance. The reason why it is our fight is they are covered. We are to make the patients realize that they are covered, and it is a part of our extended job to write a letter of support to the insurance companies and say, okay, where do we stand on this? I'm sure the Intuitive company is discussing with the insurance companies to say, where do we meet somewhere in the middle? Any questions from anywhere? Yes. I'm not that big a person, but people like Mallikarjun sir can write.
No, I'd like to share my experience of Medanta. Last 11 years we are doing robotic surgery, and most of my patients from insurance company, depending upon what value of insurance they have done, that money has to be sufficient actually, And as you said, 50% and all that. So practically 5 lakh rupees in that robotic radical prostatectomy is fully covered actually. So I have quite good number of patients, they got their money from the insurance.
Yeah, so it is similar to my experience.
Yes.
Okay. Yuvraj sir.
Many companies don't provide insurance. Like if you have a package, they reject it. Why it is? If you have a package for robotic surgery, they want the complete itemized bill. So that is one question I want to always ask.
Yes, if you look at the pre-authorization template, by design all the companies, all the hospitals, regardless of which insurance company it is, they have to provide an itemized estimate of the procedure, because the patients, that the company would be scrutinizing that particular claim, and they want to make sure that there are no unnecessary items included in that. But coming to your point about the PPN, once a hospital has an agreement with the insurance company, ideally it should not get disputed. Once you already had an MOU, I mean, it is beyond my comprehension to understand why would a company deny that claim. So far, what I have understood from my field visits to various hospitals, and I have covered some of the leading hospitals and the standalone hospitals, none of them had any agreement with the insurance company. Sometimes these TPAs, the third party administrator, they ask for lower rates, and then they apply those sub-limits on those lower rates, and ideally hospitals should not allow to, allow these TPAs to do that.
I didn't get how does TPA act in between? One is only for helping these patients, right? They also can have some rules.
So it is between the hospital and the insurance company if you talk about package rates. Once you decided that, ideally there should not be any issue.
Okay.
Can I?
No, we have almost 70 to 80% acceptance.
Full reimbursement, so what Mallikarjun is not right. There are patients who have got full reimbursement We have patients in which they have got full reimbursement. It all depends on what type of policy they take.
Yes.
But what he's saying is that none of the companies offering is not correct at all. There are companies who are giving, it is not just recent, they are giving in even in the past also.
Can I just,
Disposables. Now,
that's the thing,
disposables not
actually.
included, or capital cost, if I put it, as a charge for the robotic machine, they won't include that. And they include only the pharma and the OT charges. Why this, difference of in each, each insurance company will get their own way of telling.
Sir, ideally, even if you look at these justifications they have provided, ideally even this should not have been happening. Like, these companies should not have been making these excuses, but still they do, because that's how they try to bring down the cost for the company. But if we dispute that particular reason which is cited by the insurance company, eventually we can manage approval, and that's what we have seen. I cannot name those hospitals, but we have seen that once we interacted with the TPA cell, once we provided these information parameters, once the TPA is empowered to question these rejections and denials, eventually they do manage to get approval.
I think you need to provide the data about the insurance company which are honoring the robotic surgery.
Yeah.
Because what I remember or what I see in my clinic in Delhi is that most of the patient, they actually pay for the bill minus the robotic disposable charges. 150,000 rupees they have to pay from their pocket, and rest the TPAs are paying, whatever insurance company is paying. Except those semi-government type like ONGC, BHEL, IOL, they pay full amount.
Yes.
But I think what you are saying is a news for me, because many of my patients, they say that, sir, give me the certificate for 150,000 so that I can pay from my pocket, and rest the company will give.
Sure,
That's what is happening. I
Yes,
don't
sir.
know the data. You are saying it's a very good picture.
Sure.
But I don't know.
We have done a mapping. Intuitive did a study, conducted a study, and we mapped out all those health insurance companies, their health benefit products, and to what extent they cover RAS. I'll be more than happy to provide that particular support material to whosoever needs it.
Rajveer, sorry, it's just to reiterate, I think both of you are talking the same thing. What he is saying is every insurance company provides the cover to variable extent. The company that you are quoting provides the cover for everything else as a conventional surgery, not the robotic one. Yes. Robotic one. Yes. So they should be able to provide even for that. The second is, if you look at the overall robotic component of any of the insurance companies, it's minuscule. And the third take-home message would be that we have to keep on interacting with the insurance companies so that we are on their radar. Thank you very much.
Yeah, thank you so much. Thank you, everyone.
Just to iterate this, and thanks Dr. Adler, Rajveer, and thanks for the great participation. So just to underline what Rajveer just said, we have the ability to empower the TPA with the right information so that they're able to negotiate for the right contracts and reimbursements. We will be working with you guys, so please do reach out to us, and we will be proactively reaching out to you as well to make sure that you're realizing that benefit at the TPA desk. So I'll just conclude on that. Thank you so much for your time.
Well, thank you, Mr. Bhaskar, for the enlightening talk on insurance in robotic surgeries. Now let's come on to the very important talk of today, which is learning from the legends themselves. May I call upon the stage Professor Ravindra Sabnis, Dr. Keshav Murthy R, Dr. Janak Desai, Dr. Amlesh Seth sir, to chair the session and welcome the speakers and legend themselves. Thank you.
We move on to the next session, Learning from the Legends. The first talk is by Professor N.P. Gupta on Genesis and Evolution of Robotic Surgery in India.
At the outset, I like to thank the organizers of this RUFCON for inviting me, and the scientific committee on deciding this topic, genesis and development of robotic urologic surgery in India. I'm coming to MPUH hospital actually since 1987, and this is a very good comeback here again. Now in this particular lecture, what I'm going to talk is just going to share you the journey, how we acquired the first robotic urology robot in urology actually in India. And this is a personal experience without showing you a lot of data and all these kind of things. So I'd like to give you the background first, that I joined for MCH Urology in 1975 at All India Institute of Medical Science. Then I joined as faculty in 1979 as lecturer, gradually got promotions to become the professor and head of the department in 98. And then I took premature retirement in 2010. So I spent about 35 years at All India Institute of Medical Science. I'd like to give you the preamble first, that in 2002, Dr. Mani Menon popularized robotic radical prostatectomy, and that was the time when just we started hearing about the robotic surgery, radical prostatectomy and its success. In India in 2002, around that time only, there were 3 Da Vinci robots were installed in cardiac surgery. First was by Dr. Naresh Trehan, Escorts Heart Institute in New Delhi. Then Dr. P. Venugopal, he was the director at AIIMS in AIMS, and in Care Hospital, Hyderabad. What we know that JP Abdul Kalam, he was very keen that this robot should be developed in India, and they kept this robot in basement of the Care Hospital. There I have visited that place, and basically to open it up and see how the robot works actually. There is one common thing which I can notice in these 3 persons is their vision, and they always wanted to have something new, something great for the country, for their institutions, wherever they have worked. Other development was 2003, Dr. A.K. Hemel, who was with us as the professor of urology. He took sabbatical leave, and he joined with Dr. Mani Menon in Detroit, USA. And in his center he worked for a period of 2 years. Diwali gift, why I mention here is because in India we have a lot of importance of the festivals, and elders, they normally like to give some gift to their juniors. 2004, at pre-Diwali evening, when I was walking back home at around 6 p.m., I suddenly got a call from my director office. The director wants to meet you. I don't know how many of you know Dr. Venugopal. He used to be very reserved type of person, talks very less. So I got scared. I don't know what has happened. So I walked back to I said, I'll come and join. I came back to his room. Then he asked me, what Diwali gift you want for your department? No, this question I was never ready to answer. So I kept mum for 5 minutes. This is fact I am telling you. I was just thinking what to ask him. Now I have the opportunity. I said, sir, give me a robotic system for urology. He said, no problem. I will arrange the money for you, but you ensure that there should be a proper procedure for purchase, so that there should not be any government inquiry, because this is all funding by the government of India. And in cardiac surgery also they had some parliament questions and all that. So he had that bad experience, so that's why he warned me. A purchase committee was formed. That is the normal system in government sector. Dr. Mahendra Bhandari, at that time he was one of the senior, who was one of the technical expert in that committee, apart from other persons, secretaries and all that from government of India. Then Da Vinci 3-arm system was available at that time. Bids were invited but rejected twice. In government of India, there is a system that there should be minimum 3 bids, then only it is going to be approved, and the lowest one you have to buy. But you all know that there was only one company who was making the robot, so there was single bid every time, and this was rejected twice. Every time we have to prepare the document, we have to submit back. Third time we did that, and then finally that bid was accepted.
At that particular year in 2005 summer vacation, I normally used to go in my summer vacation to US, and I used to spend a month every year to Cleveland Clinic, then to Detroit. And this time I decided to go to Detroit, and I spent 1 month with Mani Menon. Though I didn't have any licensing in USA, so I used to sit by the side of him and I was watching him how he's doing the radical prostatectomy. And after end of a month, about 24 cases I observed with him, discussing with him each and every steps. At that time, he never used to mind for that. And then he was telling me some of the nuances, how you do. And then I realized that it is not the person behind the machine is more important. The judgment of the person is more important. And this machine is one which is converting your ideas into the perfect action actually, you know. So that is so I realized that yes, this machine this technology has got the potential. This story I will also tell you. 2005, Dr. Hemal came back, joined the department. Dr. Vipul Patel was invited by Escorts Heart Institute to perform the robotic radical prostatectomy. I don't know how this news got to Dr. Hemal. So he went to Dr. Venugopal and he requested him that he may be allowed to do radical prostatectomy in cardiac robot. And one day before, he did 2 robotic radical prostatectomy on the same day. Rajiv Kumar assisted him, and this was publicized in the news next day morning, the first robotic radical prostatectomy in India. I was not there in the department. Me and Dr. Ajay Kumar, we were attending a East Zone conference at that time. Finally, the bid was accepted in January 2006. Da Vinci S4 model was launched at that time. We changed our bid and negotiated, and company agreed to supply S4 model to us. We negotiated the price and purchased instruments for 200 cases, an annual maintenance contract for a period of 5 years. The story behind is this, that in a government setup, even if you want to buy something for 10,000 rupees and 1 crore rupees, the same kind of exercise we have to do. We realized, means Dr. Hemal and myself, we realized that if suppose we start and after 1 or 2 months something happens and we don't have the instrument, we have a shortage of instrument, we stop this program, then it will be utter failure. So we decided that no, we will ask the company to provide us the instrument for 200 cases so that at least for 2-3 years we can continue go on operating. And an annual maintenance contract, which you all know is one of the main expenditure for this machine. So we also decided to have it for 5 years so that uninterruptedly we can work for that. A final meeting was called in the ministry, and as the luck happened, all the 3 of us, me, Dr. Dogra and Dr. Hemal, we were attending the Varanasi RUFCON, and then that day was the meeting. Previous evening was told to us. I called my director, I said, sorry sir, we all 3 are here, file is there in the department, I'll ask secretary to give you the file. He said, don't worry, I will do the job. No, I'm telling you the great persons, how some other director would have fired us. If you are not interested, we are not interested. But anyway, Venugopal himself took the file, he presented the case in the ministry, and he got the money sanctioned. And at that time, we paid around 9 crore rupees for 200 cases, instruments, AMC for 5 years and all that. What has happened in this period of 2005 and 6, while this process was going on, I was criticized by our urologist friends from India and abroad that you are wasting government money by acquiring this costly technology which is not required for a country like India. And this is a true statement. I don't want to give the names here. So I was in dilemma. I had sleepless nights, what I am doing, whether I can justify myself or not, whether it is a wrong thing to do. But finally, my mind said, no, there is a potential in this technology, go ahead, we'll see what happens. Why I am telling you this? Because whenever you start new thing, and you are listening here also in this conference, the last lecture also, I heard the debate, laparoscopy versus open versus robot. So I have a lot of experience in my life. I started QRP, there was a debate of open prostatectomy and QRP. Now I have seen those days also in 70s and 80s. So you see how the things have changed. So everything is going to change. That I know very well. Now coming to the training. At that time there was no training facilities in India. The company used to provide the training, and we asked for the training of 6 doctors, not only one. Again, this is my concept that laparoscopy or robotic, this is only a technology. This is nothing else. Everybody should do it. Why it should be limited to 1 or 2% who have more money or something like that? No, it is not like that. Same applies when we are teaching to our students. We should teach to everybody. It is not the question that you have a favorite student, you are teaching him. So the company provided training. We decided 5 faculty members. My anesthetist said, no, Dr. Sahab, I will also go. So my anesthetist also went to one center. So we all 5 went there. It was a 5-day training, 2 days in the animal lab, 3 days the clinical cases. And when we purchased, it was also agreed that there will be 2 mentors who will be coming to start the procedure in All India Institute. Dry lab training, along with this equipment, there was a setup for the dry lab training. And in our free hours in the evening or Sundays morning, I used to go to the OT, open the theater and sit down and do the practice. So that is how we have learned. The most important thing was the assisting and helping each other. Dr. Hemal's contribution was significant. He used to stand behind me, say, sir, you do it, I am here, if any problem happens, I will take over and complete the job. So unless you have mentoring, you have somebody senior behind you, I think so it is dangerous to start with this procedure. Bedside assistance by our MCH students was a big learning for them. Each one of my MCH student at that period, 2006 to 10 names, I would don't have to give you, some are sitting here. They all assisted 200 to 300 cases of robot at that time. Because there were 2 assistants, sometimes you use 3-arm system also. Because 4-arm was a little bit inconvenient initially, but later on we became accustomed to that. So finally we got the Da Vinci S4 system. This was the system which was installed, and Mani Menon was invited as a mentor. And at that time the AIMS Golden Jubilee celebration was going on. So we decided to have an international live operative workshop on robotic urologic surgery. This was 31st July 2006, and this was the first robotic, can I have a water? First robotic workshop in India, and this is the 3D transmission first time, and we are thankful to Dr. Anand. Mr. Anand, he may be remembering because we have contacted him also, and with lot of difficulty we arranged 3D transmission to the auditorium also. And next day, then there was a American journal was coming from Delhi, so they covered this story that a American surgical robot in New Delhi. So they want to popularize that a American technology has come to India. That evening we had dinner. So this is the urology team. I don't know how we are missing Rajiv Kumar here. So Dr. Hemal, myself, Dr. Dogra, Dr. Seth and Dr. Rajiv Kumar, we were the 5 team, and it is like our family actually, you know. We all enjoyed working together, and you see the spouses also. We have very good atmosphere in AIMS. Now I have mentioned here that India is a great country. Why? Because robotic surgery was free for the patients. Time hai? Okay, I'll be fast now. Because we have never charged, even today in AIMS and Safdarjung Hospital probably, there are no charges for the patient, neither for the instruments, neither for the disposables. In general ward, and it is totally free. My international friends, they used to surprise, how can you provide free robotic surgery in India? But that is called India actually, you know. So what we decided at that time, because we have advanced prostatic cancer, they were not suitable for robotic surgery. So we have decided, me and Dr. Hemal, and that we will try this robot on all kind of urology procedures. So you see the outcome here of 4 years time. 470 patients were operated, 487 procedures were done. In 17 cases we did do double procedures also. So lower urinary tract procedures were 236, upper urinary tract 227, adlectomy 5, rectovesical this is excision 2, ablative and reconstructive 210. We did 181 robotic radical prostatectomy. In 3 we also did hernia repair, 1 orchidectomy. We did 25 radical cystectomy with extracorporeal urinary diversion, partial cystectomy 2, partial cystectomy with ureteric reimplantation, then pyeloplasty 170 cases with all variety and including removal of these stones and all that, ureterostomy for retrocaval ureter, ureteric reimplantation, VVF repair, uterovagical fistula repair. So all kind of surgeries have been done, radical nephrectomy, simple nephrectomy, nephrouretectomy, ureteric stump excision, bladder diverticulectomy, adelectomy. Idea was to explore or exploit the potential of this technology, what we can do, what we cannot do. And these are some other rare procedures. So as I mentioned, these are the cases, this bilateral pyeloplasty pre and post-op. This is the radical nephrectomy with IVC thrombus, radical cystectomy, bladder pheochromocytoma, retrovagical hydrated cyst, bilateral, this is case of bilateral upper tract. To one side we did robotic nephroidectomy, other side percutaneous resection of the tumor, and we also did this adrenal sparing removal of pheochromocytoma, which is now becoming more popular, and robotic reconstruction of retrocaval ureter, bilateral pyelolithotomy. Now at that time, because there was one company and only one technician in India, and we have an agreement with that company that that technician always used to be present in the theater, but still we saw a lot of problems, console related problem, flickering up the vision, no color vision, even in half of the case was done colored, half in black and white. We completed the case. Patient cart related problem, then instrument related problem. This paper is published in BJUI in 2009. Now these are the publications from the department, and the Saurabh was asked that question, if some patient asks you, you please keep your record, publish yourself, tell your patient, go and see the literature, there my experience is published. So that is the success. So we did outcome of the post URP radical prostatectomy, 27 cases. In that short period, I asked Ash Tiwari how many you have done post URP. He said, hardly I remember, I have done 1 out of 3,000. So that expresses you the type of practice happening in India. TURP was more common than radical prostatectomy. And then we did a pyeloplasty. This was the largest series at that time, which was published in BJUI. Again, transmesocolic pyeloplasty. Other papers are there. And this is the last paper, was 190 cases of radical prostatectomy. This is the first paper from India again on the, this is with follow-up actually, you know. We have shown our results, what has happened to these patients. So the current status, we have 88 system working in 85 hospitals. Now we have 3 new systems also. We have Vercius surgical system, CMI 1, Hugo in 1 and SSI 1. You are going to listen in this conference. Total robotic surgery done 59,000. Total urologic surgery done 33,000. Robotic radical prostatectomy 14,000. And total number of robotic surgeons today, I am happy to mention this figure of 748 are already involved in robotic surgery who have done more than 1 case. To conclude, your vision is very important. Pursuance, you may have a failure once, twice, thrice, but ultimately you will succeed. Dedication is required. Cooperation is very important. It's a teamwork. You all must have heard this several number of times. Robotic surgery is a teamwork. And if you have a dream, you can get it. I'd like to thank all my teachers, faculty colleagues, research associates, fellows and residents who have helped us. And thank you, AIMS, for giving me this, my alma mater where I learnt everything. Thank you very much.
Thank you, sir. I think you have nicely summarized the whole efforts which you have taken and developed this particular surgery. I think it is important for all of us to understand that you cannot just become legendless just like that. It requires the dedication, hard work, passion, and especially remaining in government service. You have developed this procedure, so much of efforts you have taken. I think it is all of us to learn from that. And we really are happy that you have narrated your experience, and that is how the robotic surgery has developed in the country. So thank you very much for narrating your experience.
Thank you. Thank you, sir, and I feel lucky to have been involved with you all through these years, and I was one of those 5 people who went with him to USA to Dr. Manimenan for the training. And for those of us who are working in the government sector, you know, this whole story is very interesting and a very interesting learning experience and practical guidance. And I'm sure Professor Gupta would be very happy to interact with any of us during the lunch or the dinner time. And the stories are definitely interesting and very good, very educative experiences. So now the next legend is Dr. Sudhir Rawal. He's going to talk about his experience of sparing robotic radical prostatectomy, and he's going to talk about technical nuances and outcomes.
So I'll show you the video first. Thank you, Dr. Sabnis, Arvind, Abhishek, and RUFCON for this conference. As far as Regis sparing radical prostatectomy is concerned, don't start the video. Now I have 20 minutes. How many minutes I have? 17 minutes. Okay. So we started doing anterior radical prostatectomy to start with, and this technique came from Milan, and the surgeon who actually did first 3 cases and which he published was a pediatric surgeon switched over to the robotic surgery. I don't know how that in those countries. In our country, if we do that, probably many surgeons will kill me. If I start doing pediatric surgery, when the sigmoid keeps falling into the if you do chemotherapy, just hold on. Yeah, chemotherapy, then the medical oncologist will be after your life. I saw him in EAU London when he showed his few video clips of Regis sparing radical prostatectomy, and there were many, there were 2 randomized clinical trials and there were prospective randomized reports which always proved that this technique has advantage over the conventional anterior approach in recovery of continence faster than the usual one. And you can imagine the patient who is in continence for 6 months and who is in continence for 6 weeks. So you can see the patient's psyche also and your comfort of the life also when the patient comes after 6 weeks and he says, I am quite happy with the continence. So this is how then we started doing this surgery. We do around more than 200 radical prostatectomy in a year, and out of those 200 we do around 60% of those radical prostatectomy are done by the Regis sparing. I'll just start the video. I hope this has a sound. Anandan? From the appendices episode, sound. The sigmoid go down. This is not
semicircular incision is made over the posterior peritoneum overlying the vas and the seminal vesicles. The right part of the procedure is repeated on the left side. The pedicles on the right side. Space. The procedure is now repeated on the left seminal vesicle. 230 PTS sutures on a key needle are placed through the anterior abdominal wall, then through the anterior cuttage of the peritoneum and back through the abdomen for anterior peritoneal retraction. And the vas deferens are then tucked under the sutures and retracted superiorly and anteriorly. This provides adequate exposure for So if you don't want to use the stitches, then you have to use another instruments. Then these sutures are not required. Dissection. The surgeon can now choose his plane of non-sparing. For extrafacial dissection, the plane of an incision is just below the denonvillous fascia into the prerectum.
Close to the prostate, then move laterally, taking small portions, clipping them and dividing them athermally with an aim to reach the levator fascia, which marks the interfacial plane laterally. We now follow this plane up to the apex of the prostate so that the preserved neurovascular bundle.
So you can preserve neurovascular bundle like this, as I have shown here, but other way is that you go laterally onto the prostate, and when you are going laterally, you can dissect the neurovascular bundle from the lateral border of the prostate down to the levator ani. And after that, when you take the lateral pedicles, you better be near to the prostate. They have to be very selective cases, as I shown in RUFCON also. You stay close to the prostate. If you are close to the prostate, the lateral pedicle is like around 1 centimeter like this. If it is T3 or disease or lateral pedicle is involved, you can go away from the prostate. But if you go close to the prostate, there is neurovascular bundle, they get separated automatically, or other way, otherwise this is the one way, other way.
Falls on the floor, whereas in the extrafacial dissection, the pedicle is clipped and divided away from the prostate and the levator muscle is exposed. The excised prostate thus has the denonvillous fascia and a part of the pedicle attached to it. Once the prostate has been freed posteriorly and laterally, the seminal vesicles and the vas deferens are removed from the retraction sutures, with the sutures providing upward bladder traction and a mild, gentle posterior retraction with the third arm.
Here is one catch. I know T. Kishore, he's a very good surgeon. Maybe he's here or not. He's here? Yeah. So when I operated in Esther Medicity, so he said you hold the seminal vesicle yourself. But I think he was making his assistant to do that. So I think that is better, that if you hold the seminal vesicle yourself, because then you can control wherever you want to do that. And it works out very easily.
The detrusor fibers are then gently dissected anteriorly of the prostate with blunt dissection and with light monopolar cautery. The longitudinal bladder fibers are teased away from the prostate and then transition into the circular fibers at the bladder neck.
In the beginning, when you start doing this surgery, this is the most probably critical step, because you feel you may enter into the bladder or you may be in the prostate. So what I started doing, when I started doing, I was coming from the lateral. Once you define the lateral border of the prostate, then you are sure that you will not enter into the prostate or bladder. Here we are using diathermy, but most of the time I use the cold dissection, just lift of the bladder of the prostate. That actually plane comes very easily when you start doing, except in few cases when there is extra prostatic disease or something.
The bladder neck is then transected, exposing the Foley's catheter. It is good to know about the anatomical variations at this step. Sometimes a hypertrophied central zone of the prostate may overhang the seminal vesicles. It is important to dissect cranial to this hypertrophied central zone to avoid capsular incision. One may encounter an enlarged median lobe as well. The key is to tease off the bladder mucosa away from the adenoma, to divide the mucosa close to the apex of the adenoma and not close to the circular fibers of the bladder neck, therefore preserving the ureteric orifices. Stay suture with Vicryl 2O is taken on the posterior bladder neck. This helps in anastomosis. The anterior bladder neck is now divided. Another stay stitch is taken at this time for the same purpose. Beyond the bladder neck, the remnant anterior detrusor fibers, the detrusor apron and the dorsal venous complex are dissected. Continued downward retraction of the prostate and the previously dissected anterolateral surfaces guide to maintain the correct surgical plane. Depending on the disease status of the anterior prostate, the surgeon can choose to widely excise the detrusor apron and the dorsal venous complex or preserve it as is shown in this video. The differences between the two approaches is readily visible, with the bloody field and open sinuses seen when the surgeon chooses to widely excise this complex. The urethral dissection continues close to the prostatic apex, preserving maximum urethral length and avoiding any injury to the sphincter complex. The Walsh's pillars are then excised and the prostate is removed. Any open venous sinuses are then oversewn with a VLOC 3O suture. We prefer to use a VLOC 3O 15 cm suture initially. The first bite is taken by providing downward traction on the anterior bladder neck stay suture and then coming from outside in inside the bladder and then from inside out on the urethra at 12 o'clock. It is important to ensure that the mucosa is included in every suture that is taken, and suturing in the urethra is aided by the in and out movement of the urethral catheter. After a few bites have been taken on the right side of the urethra, we now take another suture, VLOC 3O, and continue the anastomosis on the left side of the urethra. Suturing continues till the whole circumference of the bladder neck and the urethra have been anastomosed. A Foley's catheter is then inserted under vision and a leak test is performed, following which the sutures are tied. The retracting PDS sutures are then released and the procedure is completed. We do not advocate performing red gel sparing prostatectomy if the preoperative MRI shows bladder neck infiltration, disease in the anterior prostate extending into the detrusor apron, or in cases where there is extensive disease involving whole of the prostate with extraprostatic extension. It is preferable to avoid red gel sparing approach in the initial phases of the learning curve in cases with large median lobe or if the patient is post-TURP or HOLEM. Intraoperative conversion to anterior approach may be necessary if one is unable to find a plane between the prostate and the bladder during the stage of prostatovesical disconnection.
Can I, now this actually technique has been, put the PowerPoint, for as had happened in any new technique like laparoscopy or robotic, that oncologically this may not be a sound technique, especially in the patient who have high risk disease. And it does happen in the beginning when you start doing this, these techniques, there is a learning curve. I have also learned this technique and I have evolved also. You can go really onto the levator ani and take the, anteriorly you also can even cut the whole of the DVC if required, and then you suture the DVC from the same place. This is the BJUI 2019 paper, which actually compared the standard RARP with the Ridges sparing radical prostatectomy, and that showed that the likelihood of positive margin was lower in a standard RARP. Rate was 15% versus 24%. And the conclusion was that our analysis confirmed that RARP is safe, feasible alternative to standard RARP. This novel approach may be associated with faster and higher recovery of continence without increasing the risk of complication. One caveat might be the high risk of positive surgical margin, and this can be regarded as a current pitfall of the technique, probably related to the expected learning curve. And this is 2021 paper in Journal of Urology. They actually compared 500 patients, 280 or 250 in each arm, and they showed that there was no difference between the margin positivity in both the techniques. So this is how you evolve in your technique, but still I will not suggest to do in those many situations which we have told. But post-URP, when you are doing radical prostatectomy, and tomorrow we have post-URP patient only, you must do cystoscopy and make sure that ureteric orifice are away from the resection site, because then you cannot see the ureteric orifice with this technique. Thank you.
Yeah, okay. Thank you very much, Dr. Raval, for your wonderful disposition on the Ridges sparing surgery. We have had very senior people. The title itself is listening to the legions, and here is one guy who, if the history of urology is to be written, Indian urology, he has played a very important role. And I remember Dr. Gupta saying, when I was trying to embrace robotic surgery, this is for the juniors here, and I told him, "Arey Gupta ji, boss sapna." I took almost 4.5 quarter to 5 hours to finish. He encouraged me. He said, "Khatam kiya wohi baat, bahut badi baat hai." It takes a hell of a lot of time when you are mastering or embracing a new technique. And even today, I consider myself a kindergarten kid in this realm of robotic surgery. It takes me 2 hours 45 minutes, whereas experts like Vipul, if Vipul is doing a radical prostate and if it crosses 60 minutes, it's not Vipul Patel. It's somebody else on the console. He never crosses 60 minutes. That kind of an expertise which comes from a lot of exposure and repeated procedures that you do because of your volumes. And now talking about Dr. Raval, once again, a very dedicated surgeon. He has put in lot of energy in developing this uro-oncology, and here he is trying to popularize one more modification of radical prostatectomy, the Ridges sparing prostatectomy. Again, for the juniors here, a statement from Bruce Lee. He said that, "I fear an opponent who has practiced one kick 10,000 times rather than an opponent who is attempting 10,000 different kicks." Try to master one technique fully before you jump into the next. It is only volumes that will allow you to experiment. He has the volumes to experiment on this Ridges sparing, and the data which is emerging from the world is that yes, immediate continence is better, but long-term continence by and large remains the same for the traditional technique versus the Ridges sparing. And we all know that there is what is called the trifecta, in this robotic prostatectomy surgeries: cancer control, continence control, and potency control. There is a fourth parameter being talked about, which is called peri-surgery, the lesser the problems post-operatively is the fourth factor which is being considered, and that is very important, that you try and do one surgery repeatedly so that that fourth factor also is very much under your control, perioperative morbidity. I think we have time to have questions for both the speakers. For Dr.
Sanjay.
Raval to begin with. Take the mic.
The cut DVC which was left over after we removed the large prostate was massive, and there was continuous bleed which was happening all the time. So smaller prostates were easier because the curtain of the DVC left over was small. Did not want to tie over the DVC. Technique. The large prostates came, the amount of bleeding which could continue and we would suture around was a limitation. So is large prostate a limitation to you? Because we slowed ourselves on the very large prostates of 120, 20 grams.
No, I agree with you. Large prostate actually it has mainly, it occupies a lot of bladder wall also. When you start doing from behind, so, bladder gets lifted up, and then when you dissect that area, there will be users and all. But per se, the tapron will fall, that you have to take care of it. But as such, it's not a limiting factor for us. Many times we get large prostate, and there is sometime only you'll end up with a big hole in a bladder neck, and most of the time you can actually dissect onto the urethra with the large prostate also, but anteriorly you may end up in having a bigger, larger part of the bladder neck, and some apron may be falling. But what I do is not like this. I have shown in RUFCON also, and that's my technique here. This is done by Amitabh. He takes 15 centimeter suture. I take 30 centimeter 30 V-lock. And I start taking the DVC first and make sure that actually area of anatomy, it's actually solves all the problem, and that suture will continues as for anastomosis towards the right side, and then come with the 15 centimeter on the left side. These are some problems, but then with the experience they are doable. That's not a problem at all.
And the 30-degree up, you start only when you use the suturing part, or you use it a terminal part of the dissection?
Yeah, actually you can do this surgery with the 0-degree even. Kuhn Raha does with 0-degree even. Generally I use 30-degree once I have removed the prostate completely, then for taking the suture on anterior wall and anastomosis. Then I use, but many people use in the beginning part of the surgery. It's a personal choice. It's not a problem. Anybody can do whatever he wants.
Thank you very much, sir.
Thank you.
We end up with this session. We shortly will stop the lunch, so those who wish to have quick bite, please go ahead and have a quick bite. Dr. Omar Karim is not here, so we are going to skip that lecture. He was to come, but he was found RT-PCR positive, so he has dropped his idea of coming. So this, the topic of his lecture we'll discuss during the live surgery.
Well, thank you for that enlightening talks from the legend themselves. RUF is in its infancy. May I take this opportunity to urge everybody to become a member of RUF. The details to become member of RUF are as on the screen.
Thank you so much.
Now, may I take this opportunity to welcome Dr. C. Mallikarjuna for its next talk, What's on the Horizon? Is a robot an alternative to everything ever after? May I have an experts, Dr. Gaurang Shah, Dr. S.K. Singh, Dr. Anish Srivastav, Dr. Shanik Shah.
Sir, that's because we still have about 3 minutes to go.
Yeah.
Sir, Malik sir, I think we'll have to take them up. We still have 3 minutes to go. They are not the panelists.
And may I welcome the moderators, Dr. S.K. Singh and Dr. V. Mohan Kumar.
No, Gaurang is here. Gaurang is here. SK, we can call somebody else also. Anish is there. I thought somebody else also. I thought possibly it is not a multiple choice for anyone. You see, there are so many things which SK saying Anish is there, Shrenik is not there. That's okay. You can have somebody else. Abhijit, if you can put some. SK Singh is there. You can answer from lunch also, SK. You will be audible. You know very well that you will be audible from lunch also.
Sir, just a small announcement. The membership forms are available at the Inta stall. Thank you.
If I can have one practitioner who is into complete private practice coming into this podium, please. With robot. No, with robot. Shrenik sir. Okay, come. Shrenik sir. I was wondering. How can we miss Amitabh Bachchan? Okay. The whole thing what Arvind was asked me is to give a lecture on this, but I said it's never a lecture. We talk so many things which we don't practice most of the times. I think all of us. We talk so many things in the lectures which may not be practiced in the regular day. So we have some questions. What is the topic given is robotic surgery is going to be alternative for everything in future. In fact, Jitendra has already said that there are so many indications where a laparoscopy or an open surgery still hold true. In fact, robot appears to be useless. Sometimes it can happen. But where are we limiting ourselves and how we need to go about? We have some small clinical scenarios and then a discussion will start on those clinical scenarios. I recently went to my grandson. This is not my grandson, but I really wanted one picture. Okay? No, really. No, really, I'm not saying. Hey, you got a doubt or what? No, right. Okay. He still has got doubts. Jagdish, you're too old to have doubts. Come on. Okay. Okay, this is what I expected him to show me when I went there. But unfortunately, this is not happening. And this is what I saw. So where are we now? We are no more seeing slates. We are only seeing screens. So we have gone from an age of slate to screen. That means, will robot will be the only way for future? Are we getting into that level of confidence that it's going to be the only way? Tomorrow, somebody may not write a signature. They have a digital signature on their laptop which can be transferred, but they cannot write a signature possibly in a correct way. So that is what may happen in the near future. Because they are more well versed onto the screen rather than writing a sentence onto the paper. Well, that's what is happening, so we need to adapt for it. So the next question what Anil wanted me to answer was open and laparoscopy on deathbed after arrival of robot. Well, there are some indications which doesn't appear to be so, but why so? Why so? Let us analyze why so that. So why we need to think so? It appears that robot makes the job easy, which has been discussed. Easy to teach and acquire skills with dual consoles, etc., etc. Better results, well, that's a question mark which possibly there is a lot of debate happening onto it. Well, there is initially, as any trials happen, first everybody said non-inferiority, then equal, then superiority trials, everything will start until everybody get accepted into it. And tomorrow there is a lot of fusion of artificial intelligence coming into picture and you are in no way to escape from that phenomena. Once it comes in, you get addicted to it and you cannot get escape out of it. And you'll end up in doing the same way. Cost appears to be the most temporary discussion. That's exactly what I'm talking about. Initially, everybody talks about talk. Even when lap chole came, when they were taking 3 hours duration for lap chole, everybody criticized, I can do it open lap chole with the smallest possible incision in 20 minutes. Today, an open surgery is a rarity regarding lap chole is concerned. So let us not discuss about the cost part. Well, there is a element of cost which has to be viewed in a different perspective, not as an investment perspective. Let us look at that cost part in a later part of the talks. So I'll give a clinical scenario for all of you. All 2 of them are in a major institutes where everything is free. Well, a little is paid to you and to the patient also, or the patient pays a little, doesn't matter. Whatever it is, you are in 2 institutes, and Gaurang is in a private sector medical college where everything is available but he still practices, and Shrenik is into a government hospital where robot is not there, but it is expected, definitely it will come, no doubt about it, and you are still looking at that era of patients wherein they have a question marks regarding availability or affordability of a robot. So all 4 of you have a different perspectives regarding viewing the patient is concerned, and I'm going to give you 4 clinical scenarios for you, how you go about in those clinical scenarios. 8 centimeter tumor, for radical nephrectomy? Do you need a robot?
No, we don't need a robot.
All of you agree on that? Yes. So, no. So if robotic, if at all, when you wish so, suppose you have a robot clinic, you want to practice, will you do a radical nephrectomy on robot or not? No. Why? You can have a practice session, right? You can have some sort of a practice onto it.
For practice or learning, it is fine.
So majority of the institutions will end up in practicing robotic because many juniors are going to come. Right? So that's a possibility. So most of the time, if the patient comes to you and says, I want to do, Gaurang, if somebody comes and says to, I want to have a robotic radical nephrectomy, what will you say?
Yes, I will do it.
You will do it.
Yeah.
See that. This is where we are stuck here now. There is an indication of not doing it. There is an indication of doing which is driven by the patient. There is an indication of doing it indicated by training part of it. Are we looking at a better outcomes? So basically we agree on the point that it is not better outcomes. Basically, who are driving the forces? A training part is driving the force, or a robot or a viewing point from the patient's perspective is driving the force regarding these two things. Both are very important because patient is the man who decides what he wants. It is he to decide what he wants. Whether he says robotic, I have to do robotic. Yes, Shravan, please go ahead.
I think I have to declare that I am a teacher, I will be truthful and I will believe.
You are always truthful. We agree on that. No endorsement necessary.
Yes, I am a social reformer. So again, I will, but not talking about the cost. But yes, the patient, we say something, doctor, I want to die. I will say, no, don't die. So, because you have to live, you have been here to, again, to live for yourself and for your family, for the society. So, what I will do when the patient is willing, again, opting for the robotic surgery, I will tell him these are the points in favor, these are against. Again, I will say the conflict of interest. I am sitting in a robotic forum also, so that's also influencing my talk and my statement also. So what I will say, Dr. Malik, that when the patient is willing, again, opting for something, like he wants laser for prostatectomy, I say there's not much advantage for you, and I am doing this one very, again, gold standard, which I will like to offer. It has got, again, equivalent rather better result. So I will like to give him, this is samosa, this is pakoda. These are the merit, these are the demerit, these are the costs, and then you have to choose. Then later on,
you got a lot. You tell me the truth. You tell me the truth. You have so much of time to talk to the patient.
No, sir,
you really have so much of time to talk. You don't have time to talk to the resident man. Come on, talk to the patient. He doesn't have it.
So I have to tell him everything.
How much time? I don't know whether really anybody will express on it.
Just 1 minute. I think half minute only. Yes. So what I will say, that if the patient again says something wrong to be done, I will say evidence doesn't suggest any benefit. And this is my duty as a teacher, as a practitioner, as a truthful social reformer, I will put forward to the patient. Ultimately, then he has to choose and I will offer.
Perfect.
I want to say only one thing. Am I doing any unindicated thing? If I am not doing unindicated...
So methodology doesn't matter.
Yeah.
Methodology doesn't matter. Anish, do you agree on that?
Yes.
Do you agree on that?
Because it's only a difference in cost.
That's it.
Right?
Fine.
If the patient is willing to pay the cost, it is nothing illegal.
So
or
basically we come to a point. We don't need a robot. We all agree on that. But at the same time, we know very well that robot doesn't help in some issues. It is not needed. But still, for training of juniors, we are maybe necessary. Number two, to keep our lab and open skills, we may still practice it. Or if the patient demands, we may still continue it. Am I right? So you are driven without an indication which is not a medical consideration per se. Fine. First case.
One more indication.
Go ahead.
My training. If I am not trained in laparoscopic, but I am good in robotic, how will I do laparoscopic? Either I will do open or I will do robotic. And if he wants it,
if you have done only robotic training, you are not done open also. I am sure about it. Forget about laparoscopy. You are not done open also. If you are doing only open robotic surgery training, your open surgery also is zero. So I am coming to that point now. You have done a robotic partial nephrectomy in this patient. 3 o'clock you get the phone call, and that is the drain bag. What will you do? You have seen the drain bag.
Yeah. First of all, I will just see the vitals.
No, that is a hypertension.
Empty and see if it is still filling. I will open up.
That's it. That's exactly what I'm trying to say. I'm not questioning whether it is lab or versus robotic. I'm talking about methodology, whether open or lab or a robotic. I'm not talking about specifically for lab and open. You see, this is a conceptualization of what we are doing today in a perspective, because most of the time we talk something else which we don't practice. So for that conceptualization I'm talking this. So you result in an exploration. I think all of you agree on this.
Now why can't we do embolization?
At 3 o'clock in a private sector, your radiologist will take 3 hours to come.
By the time this patient
you will come 1 hour later, man. Forget about radiologist.
No, 1 hour required for his stabilization. By the time everything
no,
is
I
ready.
think, okay, whatever it is, yours. I'm not asking you, I'm asking Gaurang Shah. Come on. Gaurang, is it possible? He himself will take 1 hour to come there. Forget about it. So,
Yeah, but,
don't worry.
But I agree with
Agree with him, right. Okay, he always has to agree. He's a secretary man. Come on. Okay, you will end up in doing an open exploration, fine. You are not going to select robot at that point. Am I right? You are not going to select robot irrespective of your expertise. So we have a limitation.
because there is less time, I will not waste time and I'll immediately open up.
Okay. That's a basic thing, and why that approach is already accepted. Okay. So basically, it has got no role in emergency. So it's a very, very clear role in elective scenario where your planned surgery is concerned. So you need that basic surgery skill, which we are talking about laparoscopic skills. It has got no meaning. It is basic surgery skills, include that basic laparoscopic skills also with us. So the basic surgery skill training has to happen to everyone, including whom is being trained as a robotic fellows also. So that basic necessity is necessary.
No, once again.
Yeah.
So one small caveat here. So now you told basic surgical open surgery skill or a laparoscopic surgery skill?
No, I am not saying that. I am saying that we talked about laparoscopic surgical skill. We are saying basic surgery skills which require open also. That's what I am saying. I am not, see, I never considered as a laparoscopy as a separate skill. Today, if you look at a general surgical training, it should require a basic laparoscopic surgery skill also. Like you would require a port. We were discussing about port placement, etc. So that comes under basic surgical skill only. We are not talking about managing it laparoscopically. No, I am not discussing about that point at all.
Sir, in this particular case,
Yeah.
if I would have been gone for a CT first, then definitely a small bleeder which can be managed by
40
angioablation.
is the blood pressure. I have transfused 3 units of blood. There is a 1.5 liters in the drain. He is a private patient who was already paid, brother of a chief minister. Wait for a CT scan, come on here.
No, everything will be done. But the thing is that you told that it is a open.
So we should have a roadmap before going inside the abdomen again.
My roadmap is very clear. Everybody has got their own roadmaps depending upon the vehicle they have. Am I right or wrong? If I have a cycle, I have my roadmap. If you have an aeroplane, you have your own roadmap. So in my setup, doing it into the table before I even come into the hospital, that fellow is on the table, I explored him. That's all. I saved him. That's all I'm bothered about now. Today, I don't care about what sort of a methodology I took it. I saved him for that day. That's all it matters. That's all matters. Right. So, how should you train these sort of a scenario? So, whatever robotic training we are talking about should precede with a basic surgical skill training, which you cannot ignore. That is to be understood. There is no point discussing whether they require laparoscopy or they do require basic surgical skill training. Let us be very clear on this. That guy should know how to explore for a kidney. There is no point doing 200 radical nephrectomies by robotically without doing one incision on a flank. So let us look into it very deep here afterwards. Other skill set is needed. Case 3. We got a 2-year-old child. Shravan, you are an institution. Pediatric surgery nahi aata tere paas. Gaurang, tere paas aata hai, chalo. So now, you will get this patient, 2-year-old child, PUJ obstruction. You want to do what sort of a surgery?
No, I will do, in this case, I will do open.
Open. That's because you are more accepted. Shrenik, you do a lab because you are more well-vested lab. Anish?
Robotic.
Why?
Because I think that with laparoscopic thing, my suturing skills are not as good, and in an adult, whereas if an average person can manage it well, but in order to do for a very small child, we need that kind of magnification, and the benefits should be passed.
Basically, you are making your job.
Making my job easy.
Making your job easier.
Yes.
Let us be very clear.
Yes.
You are making your job easier.
Provided the patient can pay. Otherwise,
Are there better outcomes?
No, same.
So
Yeah.
baking us, so we have 3 indications now. One is looking into it because he is well versed with open because he is not experienced onto a pediatric lab. Somebody is pediatric lab and somebody is looking at his job made busier in a suturing for this thing. So basically we are not looking at improving the outcomes at the bottom line. Agreed? So we are not looking at an indication of improving the outcomes in any of these reconstructions. Solo. Yes. Absolutely. On a personal, not to the... I understood. What you mean to say is, he in his hands, to improve the outcomes, he needs a robot. I understood that point.
Shall I give an interesting example? Just one minute. See, when I went in 1998 to Dr. Mani Menon, then that time the robot had not come. And Dr. Mani Menon, every time in his talks, starts saying that my wife, Shamim, always, she always used to tell me when I was trying laparoscopic suturing that, Mani, you look horrible. You become tense when you come home, and you are irritable and annoyed, right? So he always says, from the most pioneer person in this world, he said, I could not learn laparoscopic suturing. That's why I used to promote robot at the time when the whole world was criticizing about the robot.
That's how. No.
On the other hand,
every evolution happens in the same fashion.
These people, let me just add. In 2003, I went to Cleveland Clinic. Anup was there, Mihir, they were doing their fellowship. So, within the Virgil, I was there for a month. So one day I asked him that, adjacent Detroit, so much things are going on. Do you have a robot? Because
Yes.
I didn't see anything. So he was actually drinking tea like this. He said, yes, the robo is here. So I could not understand what he is trying to say. He said, Anish, robo is here. So it was actually covered and he was drinking tea. He said, I don't need the robo.
That's
So
exactly. No, I understood. This is.
Yeah, so
I'll
that's the point.
ask you this question: will robotic makes it easier in children?
It does. It does for people who are a little uncomfortable with the
To-
suturing.
No. Let me tell you. Very put the question very frank. Don't emulate. If you have a 5 port instruments, are you sure that it makes it easier?
No, either way, whether it's 5 or 3
It is 5 I am talking about a 2-year-old child where I am not going to allow a 8 ports and a 12 port coming in. If you have a 5 ports, do you think that it is easier? I understand with a 8 port, but not with a 5
We have 5 robotic.
Yes.
No.
That's it. That's what exactly answer I wanted. So there is a surgeon-centric, not a patient-centric based decisions. Of course, we make a decision for patient outcome only, but the centric thinking process happens around the surgeon's abilities or his expertise, not, of course, that is end result is going to be the patient outcomes. Can we justify by evidence and bias? We don't have a justification for that. That's what we are. And patient asking for robotic surgery becomes one of the indications for doing the surgery, as we have been discussing about. Coming to the 4th clinical scenario. A very poor guy, localized CA prostate, beautifully seen in the peripheral zone there. He cannot afford robotic. He cannot say, sir, I got only 1 lakh, as somebody was telling. I can afford this much only. You do whatever you like. I don't care whether lab, I don't think anybody can do other than Janak. Nobody else can do a open prostatectomy now. I don't think so. Oh, open prostatectomy. I'm sorry, guys. No, don't go away. I'm not saying open prostatectomy, open radical prostatectomy is dear. Okay, dear. Okay. I agree. Come on, you're not doing good marketing, man. Come on. There's so many open guys lifting their hands. Okay, leave it. So, okay. Okay. So, he said he wants to do only one. He wants to do one lab and he wants to do a lab prostatectomy or robotic prostatectomy. What will be your advice, Shravan?
Yes, I will do robotic assisted radical prostatectomy.
Why?
Yes, because this has been proven to be convenient for the surgeon. It's a good for the patient because leakage is going to be less.
So, perfect. You got a fantastic outcomes coming out of robotic radical prostatectomy. That's absolutely true.
Right.
Then how are you trying to console that costings?
Yes.
What are your methods of doing it?
Yeah, so now I am in a government sector.
Yeah, you are an ethical committee. You are an ethical committee. Come on, you better talk sense.
Yes, agree. Yeah, that's right. So So again, you have to justify it because there's evidence based. This is the
No,
the
I
surgery
don't- I am not agreeing-
where the robotic surgery has an edge over laparoscopy open surgery.
No.
So
Shaman,
that is the
you
evidence
are
I've
mistaken. I am accepting that you want to do a robotic radical prostatectomy. I am not denying that fact. How do you control the cost of that patient? He's coming to your institute.
Yes, there are so many philanthropists like you. I will ask them to please pay for.
That's it. That's the reason you are still a professor. Come to Gaurang, what all you want to do?
Yeah, we routinely do this. We have got a method. We have got some trust. We request a hospital to cut down the cost. We don't take the charges, and we take some money from
Are
outside.
there any
and
ways to cut down the
bring it.
intuitive cost also?
Yeah, they sometimes they give us. They
No,
help
you
us.
cut the surgeon's cost, you cut your cost, you cut your, your cost, your hospital cost. There's one more cost, no? Intuitive cost. Can you cut down that intuitive cost?
No.
Yeah, it can
There's
be
no
cut.
way.
Actually,
Yeah,
if
yeah.
you
Sometimes
don't,
they.
if you don't
One minute.
remove that rate.
They are giving us the.
I wrote it,
benefit
clubbing the
that
cases
If
or
you do, if they give us the coupons, for using the
No,
instruments.
that's okay.
So that is we can use.
No,
that.
I put a word there, clubbing of the
Okay,
cases.
if
2-3
clubbing
cases
and if
together.
you don't remove the covering,
Ah.
so it doesn't read, and you can do the second case.
Ah.
It is
Will you allow it, Shravan, in your institute?
We routinely what we are doing, instead of 4 instruments, we are using only 3 instruments. Mallikarjun.
Yes, I understood.
So one instrument cost plus what he says we do 2
See,
cases
I'm not
simultaneously.
repeating what Anup has said in the
Anup has
morning.
already told that.
I'm not repeating what Anup has said in the morning. I have said one case, clubbing of the cases. सदियों का पुराना जो इंडिया में चलता है वही है, वो मतलब nothing new. I think. Yes, exactly. That's exactly. I am. No. That's exactly. Are we? They are not questioning nowadays. They have never questioned you. They never questioned you. Come on. That's okay. They may question one day later. But anyway, what I'm trying to say, the point here is to club or not to club. That's not a question. The question is, are we doing ethical practice in doing this? Are we doing it? So we.
As long as we don't harm the patient.
How do you know? Till that time, on the harm can happen. How do you know?
Mallikarjun, ethics in which sense you are asking?
No, we are.
No, ethics in which sense? You are only with the company, with the patient, or with yourself?
Patient. Not changing the apron onto it, and then reusing the apron and clubbing the case. I've made that comment very clearly.
Listen,
very
this is
clear.
a extra complex surgery, we all believe. That is why robotic has an age. On one side, we are cutting down the number of equipment or instrument we want to use.
That's already done.
To really,
No, that's not. You see, you may do with 2 instruments, you may do with only 1 instrument. That's why I'm not bothered
But
about.
why do you say
provided.
clubbing is unethical? Why you say that it is unethical? It's not at all unethical. Where is the question of ethics involved in it?
Yeah, you are using the same sheet for the 2 patients, which should not be done.
No, but that's sterilizing. The
No,
robot
I'm
instruments are
talking the moment
sterilized.
No.
Robot instruments are-
बस you don't know anything. अरे इसको वोटी में लेके जाओ ना कभी-कभी. अरे नहीं. No, that's not the thing.
Instruments are completely sterilized. It is wrong that it is to say that is unethical.
I think the guys who club all have it in their mind. What is clubbing is
Malik,
concerned.
you have to,
That's it.
Malik, you have to come to our OT and
It's okay.
understand how the
I
service
overlooked
is
the point.
maintained.
The only question now is, so basically the decision making has come on outcome basis and technical ease. Both, as Shravan said, is the reason for, even for a poor patient, you are opting a robotic surgery to better the outcomes, even at the sacrifice of your fees. Am I right? All of you agree on that. Am I right or wrong?
Yes.
No. No, that's because that's exactly technical ease.
Let me complete it.
Technical ease.
No, technical ease is always there. But the outcomes are same for all 3 except few perioperative outcomes.
Yes.
But still we are pushing this patient, although patient is poor to get a robotic surgery done. But if the same thing is done for a radical nephrectomy, what is wrong in that?
No, not wrong. I say that's exactly what we said. I am not saying anything wrong. I am taking an opinion from everybody.
And
that's
again,
exactly.
for the drapes and all those things, it will be very clear. You have to give the message to the
No.
audience.
I am not saying that. See, I am
Drapes
not.
should not be reused.
That's
for
exactly.
the
I am
second
talking
patient.
about lethal issues at the end of my slide. That's exactly what I am saying. So basically, we are opting for this sort of a venture because outcomes are going to be better in our hands. We feel better on doing the surgery. Am I right or wrong? And agreed upon, even though the patient cannot afford, we sacrifice and try to do that. That's one point. So looking at In case, if you're not able to progress midway, you should be prepared to convert and you should be trained. Again, I'm talking about the same point, so ethics of being penny wise is a question mark which nobody can accept, somebody may accept, somebody may not accept. But the question is, salvage surgery need to be trained for these people. If DVC they cannot control the DVC bleed on a robotic surgery, how many youngsters will be able to open up and control the DVC bleed, or doing a completion open prostatectomy is a big question mark to me. I'm not sure. All the people are trained, and I don't know how many will be able to do it confidently.
So how can we do it? That's what the robotic surgeons are asking now. Okay, because even in US, everybody is a robotic surgeon from point one. So now it is like we don't know how to write an inland letter. We know how to write an email. That is the drawback. So we have to accept it.
We need to start a fellowship on salvage surgeons.
So rather than that,
we need to create a fellowship for salvage surgeons now. So the people who can salvage you of the things.
So take home message should be like, correct. Correct. You keep one or two surgeons standby in the city. That's all.
So the question is, there is a talk on legal issues by Lalisha. Lalisha has got a talk on legal issues, so I'm not going to touch on the legal issues. But yes, whether it is ethical or unethical, it's our own conscience. I'm not questioning whether it is questioned in the court of law or not. It's our conscience to understand what we are doing good or bad.
See, about this salvage surgery, now this always is a talk. When TURP came in, people said that unless and until you do open surgery, you should not be venturing to TURP. When PCNL came, it was a clear talk that unless and until you have done pylolisectomy, unless and until you know very clearly pylolisectomy, you should not venture into PCNL. Now the talk is that unless you know open surgery of this, you should not venture. It is just a matter of time.
It's a transition
the
which
salvage
happens.
surgery and all, it will go away because every complication eventually will be managed by robotic surgery.
Hopefully.
And therefore need for that laparoscopy or robotic for controlling the complication, salvage actually will go away.
No.
It is just a matter of time.
That's exactly. See, if you are confident in your anatomy, if you are confident with your basic surgical skill, you should be able to manage. That's exactly
it will definitely be managed.
Exactly the management.
Yeah, that is what. So to open surgeons and standby is enough in a city. That's enough.
That's enough.
So
we'll go to the next patient. Next patient, a 40-year-old in a district hospital, transabdominal hysterectomy, supratrigonal VVF, lap robotic. What approach? Srenik? Lap Gaurang?
No, I will do robotic.
Robotic.
So I will like to do vaginal approach.
Okay.
if
How
it
about
is
you?
feasible.
रोबोटिक ओके यार अभी तो वेजिनल कहाँ से लेके आओगे अभी मेरे पास क्वेश्चन नहीं है उसके लिए क्वेश्चन बोलो okay now the question comes is
that is the theme I wanted to say. So now don't go carry away by anybody who is here, but be conscious what you are going to deliver to the patient.
Exactly.
How comfortable patient is going to be, how is going can be the outcome.
No,
is good and excellent.
the question what I put forward is, if half of you are looking at robotic, how many patients have to be referred to the centers from districts to get surgery done?
The people are trying.
We are
getting complex cases.
We need to realize that we cater to 2% of the population of this country. There is a 98% of the population who cannot afford this 2%, this clientele, what we are sitting here. So you should be prepared for some sort of an alternative or some sort of a training for this rest of the 98, which the government is more concerned about rather than this 2% whom being treated by us. So is it so that why I am asking
Malli,
one
those
question?
98 can afford lap, probably in periphery also.
And that's what I say. See, the reason why you preferred robot Gaurang, if I say, is it suturing the reason partly, which makes the lap difficult? Is it the only reason?
Is a very comfort zone is very
For
good,
you.
and I think my anastomosis and all leakage chances
you
are very
prefer-
less. I
no,
prefer
one of the reasons
either
is
open or
suturing?
robotic, not a laparoscopy.
Because of the suturing and dissection,
Yes.
possibly? Right. Do we really need, how many of you agree that we really require that wristed movements to do a great laparoscopy, a great robotic surgery? Just lift the hands. Do you need? No. I said in general, for suturing, how many of you feel that you definitely require this wristed movements, otherwise suturing is going to be very difficult? 30%. 30% of them definitely feel that, yes.
Yeah, pyeloplasty probably
But
most
I
of
still
us
say
can do,
what-
but pelvic surgeries and all.
Yes, what Gaurang said is to be looked into very seriously. He said, in my hands, the result happens on robotics, so I am preferring. In Shrenik's hands, he feels my lab result is best, so he is able to do that. So basically, the choice of approach is never by the patient. Most of the patients don't never even think about what approach you are going to do. They look at the result. That is the thing which matters basically. So it is, you need to balance between affordability and availability, and based on that you need to make a decision what sort of the way you require. I come to the last two slides. I'm asking you one question, all of you. You asked, you are an institutional guys, I'll ask Gaurang. When did you ask for a robot in your institute? Why did you ask for?
Because the number of cases we were getting and we were doing, where the robot is required, was quite high.
Is it for the better outcomes? Or
yeah,
for
better
the
outcome, and many of us are not very good at laparoscopy.
So you wanted to have. Is this the same
Yes.
reasons?
No, actually we wanted robot in 2006 because we were competing with AIMS.
That's it.
Gupta.
That's it. That's it. That's
Yes,
come.
so,
No.
I thought
come
we
to
should
the
have
point.
all modern
We are
technology.
getting to the point. We are coming to the point. So one point is load is more. How many cases per month you require to buy a robot? When did you say that I need to buy a robot now? In a number of cases you want to per month?
At least 10.
At least 10. It doesn't work out, man. Okay, it doesn't matter. Okay, is it one of the reasons that you want to project as a robotic surgeon? Or to survive the competition, as Shravan said? Both yes. Both yes. Did you ever thought, will you ever bother about a return of investment in these cases? All 4 of you. No, all 4 of you. Did you ever thought about return of investment in these cases? None. None of you really thought about return of investment. He'll know. No, that's exactly. Let me tell you here. Okay, come back. You are the part owners of it. You are not able to understand this point. Why this discrepancy? Why the hospitals are not investing into robot? Because you don't take the ownership. You take the ownership, every hospital will have to buy. How many 100-watt lasers are there in this India who have not completed even 100 laser prostatectomies? 90% of them even not completed 100 prostatectomies. You're thinking about buying robot without having a feeling of their own.
Yes.
Nobody will come forward to buy it. I tell this, no surgeon is clear on this return of investment. We are biased in one way of having it, procuring it for competition, for better outcomes to the patients, thinking of better outcomes which have not been proven till now in life, and still we are expecting a robot to happen. So try to understand, be a part of that institution and think about return of investments. Many more institutions will have robots. So, that's one. I am telling you that. No. This is the truth. This is absolute truth. So tell me the truth now. Which is beneficial to a hospital? Robotic or lab?
In our institute,
lab. Robotic is a loss-making thing. Is it needed for hype or competition or indication? Both. All. We decided that it's all. Is it needed in India? Are we available to everyone, even if you procure? Unless you be part of institutions, you cannot increase the number at any cost. Will the lab be dead in future? No. There are specific indications which continue to be more important to be done by laparoscopic surgery. Sir, we'll see, sir. It is even now. Even if you think we are, US is advanced, I'm telling you now, sir, other than robotic prostatectomy, 90% of urological surgeries are still done by laparoscopy. You take US statistics today. US statistics. Still donor. I am telling you today. Even, sir, I am telling you the statistics. Sudhir, I am telling you the Sudhir. I am telling you the statistics. 90% of urological laparoscopic surgeries in US today also, left alone with the radical prostatectomy, are still done by laparoscopic surgery. No doubt about it. I got a full data. So to tell me the truth, I'm going to get back to the conclusion. Advance in medicine is going to happen. What is hype today may be a necessity tomorrow, as everybody policies. Define the indication, retain the skill set of the other ways also.
let's not forget about affordable health care. That is necessary for any country. Forget about US. Even US requires affordable health care. They are struggling to cope up for it. Not only India. We are talking about India. Even US is struggling to give health care. Let's not forget about affordable health care. Let the decision be on patient-centric outcomes. Once upon a time, value of health care was defined, previous terminology is quality plus service by the cost. That was defined as value. That quality was defined by the surgeon or the metrics created by some public health measures. Never ever anybody looked into the patient per se or his feedback per se into this quality. Today the quality is health outcomes that matter to the patients. That is going to be the quality. It is not surgeon-centric outcomes. So many poor patients are continent in 1 month. It doesn't make any sense to the patient-centric outcomes. You look at 1 year or 6 months. How many patients will agree, I'll require a continence in 1 month? No, it is we take it as our indication for ourselves. No, you need to, this is a Harvard guy, Porter's theory, wherein health outcomes that matter to the patients is the quality. Whether you do a lab, whether you do open, or whether you do robotic, it doesn't make sense. For them, it is health outcomes matter to that. So that's what, be wise in choosing the modality, and thank you very much.
No, but I have one question, last question to Malik. You are a better laparoscopic surgeon, your outcome is far better, laparoscopy is quick. Robot is poor from the business point of view. Why have you gone for robotic then? Why have you gone for robotic surgery?
I have to compete with AIMS.
So what lecture you are giving?
I have to compete with AIMS. So I have to buy.
So what lecture you are giving, you are not following?
No. That's exactly. I never denied that robot gets better outcomes in certain scenarios. But leave it to that. I do a radical prostatectomy today only by robotic. Even if there is a poor patient, I take up my fee. What he said is correct. I do a robotic radical prostatectomy only. Half of my partial nephrectomies are lap, half of my partial nephrectomies are robotic. But I converted my pyeloplasties into lap because I didn't find much great efforts or necessities of robot in these cases. So I changed many. In fact, when the Spanish guy...
so even though it is poor business model, you are going for robotic?
No, the thing what I wanted to convey is, number one, until we don't think about ROI for ourselves, irrespective, it's not robot. I'm talking about every damn machine what you buy. Every damn machine what you buy for the hospital. If you don't think of return of investment, you cannot progress further. You will be stuck, you will be fighting with the administration, and administration will be fighting with you. Thank you very much. I think it's time.
Well, thank you, sir, for that wonderful talk and session. A complete jam-packed auditorium. Now, may I welcome moderators for the next session, Dr. S.K. Singh, Dr. V. Mohan Kumar, and may I welcome the next speaker, Dr. Sanjay Adla, for his talk on avant-garde technology in robotic surgery. Is there a revolution still waiting to happen?
Yeah. Good afternoon to all of you. Now we are going to listen to Dr. Sanjay Adla, who is a renowned urologist from Hyderabad, robotic surgeon or urocologist. He is going to tell us an interesting, again, going to deliver us an interesting talk. He is going to tell us how to, again, practice new experiment for the outcome, for a better outcome for the future. Thank you, Dr. Sanjay.
Thank you very much, sir. Good afternoon. Thank you very much for the invite. This is the first time I'm in the home of urology for India. Thank you. So when I was given the talk, these are the disclaimers. The slides have been prepared by Intuitive. I modified it so that it fits my story. Even if you don't listen to any part of the talk, I thought I'll let you know what avant-garde is. So the way to say it is avant-garde. So you don't say the T word, okay? And you're going to just remember this one: favoring or introducing new and experimental ideas and methods. Okay, I'll repeat it again. Most often we use it as an adjective: favoring or introducing new and experimental ideas and methods. So that's what avant-garde is. But then I thought, okay, who are avant-garde surgeons? If you take general surgeons, the people who introduce new ideas who like technology, who like minimally invasive surgery are avant-garde surgeons. So all urologists are actually avant-garde surgeons. Who among the urological surgeons are further avant-garde? Uro-oncologists. We want targeted treatment. We want much more precise treatment. And among the uro-oncologists, robotic uro-oncologists are the avant-garde. So I've been given you. The second element of it is, do we need a revolution? I.e., we are avant-garde surgeons, that's why we are here, but do we need a revolution? Robotic surgery, the surgical platform has undergone an evolution rather than a revolution. It has been a slow build-up over the last 25 years, but they were catering for people like me who are in their middle 40s or late 40s. And I'm going to introduce a new term called as digital immigrants. Anybody born before 85? Quite a lot of us are digital immigrants. We were born when there were no computers. We had to. And if somebody is typing like this on their phone, we can't even call them as digital immigrants. Digital immigrants are still two-finger one, whereas if you see your children, they can type so much faster. They are natives. We are coming to the area wherein we need to cater for the next generation, who are the digital natives, who are the people who are sitting at the back of this lecture hall, so that we don't become the digital refugees, in that the technology has gone past us and we don't have much job to do, computers are doing it. So we do need a revolution. Is Intuitive the right partner for us? Because if we want to be avant-garde surgeons, we need a partner who can deliver on that. And when you look at it, I didn't even put anything before dual console. There were too many pictures in it. I only started at around 2008, 2009, because there were too many discoveries before that. So from dual console to multi-port to single port to no port. And if you see the numbers, these are very good numbers for any company that is in this tech world. And when you look at Indian data, still it is a growing company. So avant-garde company for avant-garde surgeons. What am I trying to talk about? There are these 4 components. Whatever we are doing, we have to ensure that the patients get precision surgery, and we have to be delivering a safe care for our patients. Safety is of paramount importance. We can't just try because I can try. And then how are we going to improve the learning? How are we going to improve the access? How am I going to do it? Single port or multi-port, and the guidance for it. And the most important aspect, I think in the next 5 to 6 years, we are going to learn a lot about this insight element of doing robotic surgery. Standard training, we have already gone through this. Where we have to start replicating what we do in open in robotic, that's where we struggle. What is Intuitive coming up with? If you just see this, this is what it used to be. This is what it is currently. It is as close to reality as possible. It is still digital imaging, but still the tissues behave as though we are operating on them. Tissues retract as though they do in real life. When you're trying to do the anastomosis there, when you're trying to put the staple through, the bowel always moves away from your staple line, and that's what tends to happen in this more real life. So we will have surgeons who are better trained on better modeling, so that they are much more prepared by the time they come on to the patient. This one I found it very, very interesting. So this one is somebody trying to do the operation, and what he has is here, he is doing the steps, and this is the best performer in the group or his mentor. He is doing the steps. So each step he can counter check how they are doing, and then the computer keeps on giving a feedback saying that how they are performing. So rather than doing the whole operation and say you did rubbish, it will tell you saying that actually you did majority of the steps right, but the entry was into the aorta. And you will be able to have best people. Nowadays, anybody mentoring, the limitation is that they have to be free enough to come around and mentor. Whereas with this teleproctoring, anybody anywhere in the world, you can choose the best among them. They only need 2 to 3 hours, they can mentor you. And these are not far off. I'm not talking of what is going to happen by the time I retire. I'm talking of what's going to happen in the next year or 2. And this one I found it very, very interesting. All the things that we're having the discussion about, everything that counts doesn't need to be counted. There are certain things. Why do we do robotic radical prostatectomy when there is a RCT saying that actually it doesn't make any difference? Because we feel that it makes a difference. We can't count everything that we think does make a difference. But you know the robot is looking at you with a microscope. It knows what you are doing, whether you are a novice or not. It does know. And now they have come up with a way to measure a trainee to a surgeon. And if you see that it's looking at the angulation that you are putting, every time you are moving your arms out of the vision, it is looking at it, and then it will give you these. These are experts. All the movements are much more finer in a much more localized area compared to somebody who is a novice. So the intuitive company or the robot does know that you are a novice, and the more closer you become an expert, the more closer your patterns become to that of an expert. What they are trying to do is, if there is something that is measurable, they are trying to do that. Until now, whenever you see a robotic surgeon, the moment you see it, you think that he's a good surgeon. Whereas now they are able to say he's a good surgeon because of this. These are the numbers. So they are trying to count something that we could not count before. What about access and guidance? This is the single port. Again, not in the future. There are already quite a few systems available in the world. If one specialty finds a use of this, it is uro-oncology. Partial nephrectomy, pyeloplasty, any of those things, I think would be much easier done or much better done cosmetically because of this single system. Iris, which is, all of us have got different modifications of this, which is available. And what you can do is you can use it as a time. This one I found it very, very interesting, not in urology but in bronchoscopy, wherein a CT scan is almost taken into the software system, and it will be able to guide you exactly which way you are going to move the bronchoscope so that you can go and find out the lesion. And again, this is not in a developmental stage, it's already being used. And it's quite fascinating. So it's almost telling you exactly where to go, and then it will give you a proper navigation. So it is feeding in now, and then it will tell you which way to go. Yes, intuitive. This one, whether it is useful for stones or any TCC higher up in the kidney, I think it will be. So it's exactly showing you which one to take. And it is pointing out there how far you are from your destination. And the last and the most important point is the insight. We have to know, as a surgeon, we have to know that we are doing good to the patients, and we have to know that we are not doing bad to the patients. And this insight is quite useful into it. So what they will be able to provide you is how are you performing compared to your own peers in the same area, same country, same zone, and then what is the instrument variance, how is the system utilization that is going on. And I'm just going to play a video regarding the intuitive app.
100 at their fingertips. The app makes that connection.
One of my favorite things about the app is that I can take a look at, say, any little hernia case, and I can hold it and I can see it's like 124 minutes. I used 7 instruments. I can see exactly what I used. That's super helpful for me as a surgeon to be able to see the choreography of the instruments.
I was really impressed with the amount of data and the quality of data and how easy it was to use it without it requiring extra time or disrupting my workflow.
As a surgeon, you can log into a system in the OR. Your energy preferences, your ergonomic preferences, all that stuff comes with you. We never want to give surgeons more work to do. We want to give them a seamless experience. But what really shocked me and impressed me was down at the bottom whenever I could just say view timeline, and then I could just turn it sideways and I could be able to see the entire case from start to finish. As I drag this timeline back and forth, you can actually see the instruments changing back and forth. So you can see at what point in the case which instruments were loaded in which arm, as well as, you know, who was using them. That's where I went, wow, that's cool. That's what I was looking for.
Not only do you have your own experience, you have the benefit of a searchable past history of your personal experience, and also you have the benefit of your colleagues' experience.
So for example, if I'm taking out somebody's gallbladder, I can see that I typically use 5 instruments, but most surgeons only use 3 or 4 instruments. These are the 3 or 4 instruments they use, so I can say, okay, well, is there an opportunity here for me to be more efficient?
The opportunity now with the app to be able to see where I stand versus all surgeons and where I stand amongst the top 10% of surgeons, that's really exciting, and that really motivates me.
We know surgeons are absolutely high-performance human beings. They are like elite athletes. I think the My Intuitive app is going to be revolutionary. The power of millions of procedures projected to the palm of your hand in close proximity to a computer in your operating room. What we're doing here is going to change the future in a way that will not revert to the past. And I think it's important and it's crazy exciting.
That last statement says what they are doing is irreversible. We are going to have a much better insight into how we are performing, and it reiterates our self-belief and helps us deliver in an evidence-based fashion better care for the patients. So I end up with this one. All of us are avant-garde surgeons, and Intuitive, currently who has been working in this field for 25 years, helps us developing further into who we are or who are going to become. Thank you very much.
Thank you, Dr. Adla. Thank you very much for your excellent talk. As always, you have been excellent in your deliberation, and I think evolution is still awaiting for tomorrow, not a revolution, evolution. Thank you very much. Thank you all. If anybody has any question or comment, thank you very much. Thank you all.
Now we'll move ahead to the next part of the session, which is panel discussions. The first topic for panel discussion is robotic assisted kidney transplant. May I welcome the main convener, Dr. Pranjal Modi, co-convener, Dr. Arvind Ganpule, and the speakers, Dr. Anil Srivastav, Dr. T.A. Kishore, and Dr. Imesh Gandhi for this session.
Good afternoon and very welcome. Thank you very much for giving us this opportunity. It's a panel discussion, and Arvind has requested that he's having a few videos of complications, so he wants to show those things also, which will be including may I ask, I think in a kidney transplant, it's a relatively new topic to do the robotic kidney transplant. If I get the history rightly, the first robotic kidney transplant was done in 2010 at University of Chicago, and since then it has evolved. In India, it's Menon and Mani Menon's group who came over here. They started in Medanta and at my place, They also have come to MPUH here, but probably they have done a robotic anatrophic nephrolithotomy, if I remember it correctly. So that is way back in 2013. We did our first robotic kidney transplant on 26 January 2013, and since then in my institution we have gone over 600 plus cases of robotic kidney transplantation. Kishore has done very well, Anish sir is having, and everybody is having now the robot, and then they have started talking, Himesh is having that thing. So may I think ask the panelists, esteemed panelists, that first question is in a discussion, why you want robotic kidney transplantation? What's the advantage of it? Himesh, we can start with you.
So, robotic kidney transplant, basically our center has been doing open kidney transplant, and we have almost finished 1500 open kidney transplant since, I would say, 2012. So robotic, like across India, we have very selected centers for robotic kidney transplant, and looking at the result, we also felt that now it's the time to introduce a new technology, not for the sake of changing the outcome, because it's already proven that it's non-inferior, but giving something better for the patient in the peri-operative period, where the patient used to go around 7-10 days at home, and now he is going at 5 days at home. So this was a motivational drive for us to start a program like this.
Okay, so that's the fun thing, you want to see some advantages of the robotic kidney transplant over open kidney transplant. Did you find anyone?
So the biggest advantage what I felt was the quality of anastomosis, because maximum 3.5 times magnification we are using it in open kidney transplant. While robotic, I get 10 times magnified vision. So that was the biggest plus for me to ensure that the quality of anastomosis is very good. So that was another factor which motivated me to take up this surgery.
Okay, so may I ask to Anish sir about...
I am actually in the infancy, and we have just started with the help of...
That's what the exact question I want to ask. When do you think one should start doing robotic kidney transplant?
Well, once you are very well versed, so I think the basic for everyone who wants to come over from the open to robotic platform is that they should be doing other robotic surgeries. That is very, very important. And most important is to do surgeries where you are doing more of suturing also. So once you have a lot of practice with that, then only you should come over to the robotic transplant. This is an advanced and a complex surgery. So let me add at the same breath that why this has not become popular across the globe. I was asking this question to Dr. Maniman and to Dr. Bhandari, and I said, why in the US, they are the pioneers everywhere, why are they lacking behind? And in England also, I asked question to some senior persons there. The issue is that most of those surgeons are not doing other robotic surgeries. They are organ transplant surgeons, they are so busy, they do mostly cadaveric, life related is less common, and as we all have discussed, robotic is not usually for emergencies. So their programs are 80% cadaveric and all, and then they are so busy organ transplant surgeons that they do not do even the other robotic procedures. So whatever the other thing they do, that is open. That is one of the major actually issues why this transplant in US also it's a American Transplant Society, everything is different, they are not the part of urology.
Yes.
But for urologists it is easier to pick up if they wish, whether it is peripheral or it's a selected group of patients, obese patients and all that. That is an endless debate that will go on.
Correct.
But your question, the bottom line is, unless you are doing robotic procedures as on a routine basis, you should not venture into kidney transplant alone.
Thank you. I will just share my own experience about robotic kidney transplant. How did I start it? We have started initially the laparoscopic kidney transplant, that is laparoscopic recipient surgery, after the internal review board permission and other things. I got a permission for cadaveric organ laparoscopic kidney transplant only. I published paper in American Journal of Transplantation, and there the first case took 72 minutes of vascular anastomosis. However, the kidney functioned. And 4 cases I did, all were marginal donors, however the kidney functioned in all cases. And average anastomotic time was around 60 minutes. Of late we all know about the outcome of partial nephrectomy and so on and so forth. Then you clamp it for 40 minutes, 45 minutes, 1 hour, etc. Most of the time the kidney functions. It's native kidney, and it's a healthy kidney otherwise, except for the cancer part, but it works normally. We know the work, original work of Dipen Parekh also, that the kidney withstands the warm ischemia time very smartly, and then also the cold ischemia time is also not a problem. So I think considering these aspects which we have that when to start a kidney transplant robotically is very important. One is training part, second is graft function, which is kidney is going to get warm, and then how long you are going to take time. Sir has said very correctly, and so in my case it was an experience which I had in laparoscopic kidney transplant, which I translated into the robotic kidney transplant. For me it was much easier. For other surgeons, what we found is they have a robotic suturing skill, which is very high skill developed, like partial nephrectomy, pyeloplasty. In the previous talk it has been told that it's expensive to do the pyeloplasty robotically. In my mind, it's the investment to go for the next step ahead, and that is if your fellows or yourself is doing the robotic pyeloplasty quickly in a time-bounded procedure, probably you will be doing time-bounded anastomosis also. So it is very important to develop a skill which is which you can improve upon by yourself, and then just fix at the time that my anastomotic time should be 30 minutes. So the completion of pyeloplasty by continuous running suture may be 30 minutes, or maybe interrupted suture in an anterior wall or posterior wall continuous running suture should be 30 minutes. Something like that you target upon. This is just one example. There are many other examples you can take, and then you can carry on with such type of things for the transplant. So I think this is one of the important aspects, how to carry on the robotic vascular anastomosis. Kishore, you have a lot of experience now of a vascular anastomosis, kidney transplant. How did you pick it up in your experience, and especially handling the blood vessel and the fine sutures? What sutures and why?
I think when you're adapting the robotic transplant, we are taking a step backward, because open renal transplant is it's a standardized surgery, and it's quite easily accomplished with an extraperitoneal. So we're taking a step backwards. We're doing extra intraperitoneal surgeries, and of course when you start with, you're not as adept as suturing robotically. Okay, I would say the pros as far as robotic surgery is concerned, it's ease of anastomosis, especially in obese patients. Even though if you compare obese patient open and robotic is definitely, compared to thin patients, robotic is definitely difficult in obese patient, but it's much better than doing an open surgery, because the depth factor is taken out. Okay, so that is one big advantage. Okay, and another thing is that the ease of doing anastomosis with the Gore-Tex, even though it's not a very fine suture as Proline, but it makes things faster and beyond the learning curve, and in fact you can almost surpass the open surgical times actually. So once you go beyond maybe 100 cases, either it catches up or even goes better than the open surgical time. So you need 100
cases to surpass it, or maybe much lesser than that?
For me, I think it took about 120 cases, I would say. The learning curve for robotic surgery in the European urology, it said that about 35 cases, but to match the open surgical timings, outcomes might not be big difference, but to match the timings, I think for me it took around 120 cases. Yeah.
Fine. So I think and what about the sutures and the handling of those sutures? There are articles in British Journal of Urology also, like doing pyeloplasty with the vicryl, there is a fraying of the suture, and then you just have to cut it down, and then it's very difficult to get the initial ring, because robotic instruments are very robust instrument, and maybe you are handling with the Proline, or you are handling with the Gore-Tex or other suture material, whatever is your preference. What's your experience with that? Did you have
breaking of the sutures half the way, or maybe the short suture you selected and then you require extra notes, whatever, what are the experiences with that?
Breaking happens once in a way, but it's quite a resilient suture. Gore-Tex, you can handle it with reasonable care, it doesn't break. Breakings happens like whenever you have like a rash move with the left arm, or just like takes the thread, but it's not really due to the pulling of the suture, that's one. And it has got now kind of, it kind of expanses after the anastomosis, so the needle hole bleedings are rate is very less. Okay, and I've seen many patients after seeing the robotic surgeon in their open transplant, they've adapted Gore-Tex. But the downside is that for smaller vessels, say if you're a lower pole small vessels, even a 70, 80 Gore-Tex I've used, they're quite big. They don't give the comfort as much as a Proline gives. And I've tried Vascofil also, but again the memory is quite poor, so Proline and Vascofil is almost impossible, and that tend to break in minimally invasive. So.
Right, and one more question to you only, like, do you prefer to have a separate anastomosis, like if you found two vessels, versus you do everything on bench, make it single artery, and then to go for the anastomosis?
Initially there was a reluctance to do two separate anastomosis, because we were really worried about the timings of the anastomosis, but now I'm slowly switching back, because in open traditionally I used to do a separate anastomosis external iliac. When there is an equal size vessel which is far apart, we definitely go for separate anastomosis. It adds about 9 minutes extra generally. Okay, and off late, even for the smaller upper polar arteries, with the use of a 2.8 millimeter punch, we have ventured into like separate anastomosis rather than piggybacking. So,
Right.
and the magnification, I think Simesh said probably it's superior with robotics, but again the warm ischemia time or the rewarming time will be more when you do the second anastomosis.
Right. I think there is a little difference in opinion, my opinion, and I think it's little different here. I always go on bench, whatever is there, whether it is end-to-side anastomosis or it is side-to-side anastomosis, all anastomosis are to be carried out on bench. So that helps me in having multiple transvascular anastomosis intraoperatively, and or saving the time of warming the kidney, especially when you go slowly over a period of, especially in early learning part, even later on also, today also, that is a standard of care at my place. However, the experience with the different surgeon is different. May I ask Arvind about how did you start your robotic transplant program, and what problems did you encounter in establishing this process as a teamwork?
Before I started doing robotic transplants, I had done a number of open transplants as well. So I agree with the view that somebody should not directly embark on a robotic transplant just because he has got access to the robot and he's doing some other robotic surgery. So that is one point, that you have to have experience in open transplant, because there should be a point wherein you should be able to salvage a situation wherein something goes wrong in a robotic transplant, and you should be able to overcome it. As far as the program development goes at MPOH, we were very selective in selecting the patients. As you can see from the numbers, that from 2014 to 2022 we have done 42 robotic transplants, because we were very selective in selecting our patients wherein the BMI was more than 30 and it was very difficult to do a transplant open. Particularly we thought that when we are going to take a right sided kidney wherein the vein is small, we used to take the transplants on that side. Among the patients whom we have done the transplants, there are hardly 20% of the patients in whom the BMI was less than 24 and we had done the transplants. With your consent, I will be showing two videos later on.
Please go ahead, please.
Sir, before that I wanted to just bring out one point wherein you said that what were the problems wherein we faced, which we are facing in our transplants, robotic transplants. One is that we are seeing that the fall in creatinine is very slow. Initially we were attributing that fact to the thing that probably we are in our learning curve, and that is the reason why. And second, what we thought, that we are not able to maintain the cold ischemia in a better way as we do in an open transplant. So as we crossed 30, we found that the operating time went down and the fall in creatinine also went down. So from 2014 to 2022, if we see an propensity match in two, we saw that actually at 4 years, robotic transplants were doing well. But the crash in creatinine was very slow. Like at 15 days, the creatinine was comparable in open transplant and the robotic transplants. I would like to have the opinion from you, sir, as well as Kishore.
Yeah. My opinion is same. Like when I started doing laparoscopic kidney transplant, it was longer. Initial robotic kidney transplant, initially around 20 cases or so, it was little longer. But then after we understood few of the problems. Number one is a pneumoperitoneum. Number one, like once you open the clamp, we reduce the pneumoperitoneum for a while till the graft perfuses, everything is fine to around 8 millimeter of mercury instead of keeping it 12. My typical transplant is done with 12 millimeter of mercury, except that when there is a lot of problem I increase the pneumo maximum up to 15, but 99% of the cases it is 12 millimeter of mercury. After finishing the anastomosis, once I open the clamp, immediately the pneumo has to reduce because there is a negative impact of a pneumatic pressure on the graft itself, kidney itself. Once the graft is perfused completely, urine output it takes time, several minutes time, rather than just immediately you see in a normal open kidney transplantation. So maybe around 5 minutes, 10 minutes down the line, you just wait, it comes like that, and then once graft starts functioning, it's turgid. How to feel turgidity about it? Any instrument you try to, blunt instrument, you try to push or put on the kidney itself, there should not be indentation, right? So they say that the tactile feedback mechanism is not there with the robot, that's the problem, but you can easily encounter with your experience that its graft is turgid or it is a soft flabby kidney. So once turgidity achieved, till that time you wait, right? And then after you flip it off. If the kidney is not getting turgid because of whatever reason and you are suspicious about your anastomosis, a small thrombus is sitting in the artery or something like that, you can always go for the Doppler immediately by yourself. That's another advantage of these things. If nothing is problematic, just it's a matter of time. Once you flip the kidney on the psoas or the other thing after, you work with the low pneumo only if it is possible to do. Often I have seen the surgeons who again increase the pneumo and then the output reduces. So that is my experience also. And so when we typically drop the bladder, Kishore doesn't do that thing, I know, but then drop the bladder and then on anterior wall I do the anastomosis, ureteric reimplantation. So don't make the bladder overfill, like you make 250 ml saline in the open transplant. Here you need to make around 25 to 50 cc of saline only, so that just there is a little bit distension of the bladder. Otherwise what will happen, the space of radius and everything is occupied by the bladder itself, like because it's distended and the space to work is very minimal. So low pneumo is having several advantages. That is first and foremost. The second part is once your anastomotic time reduces to less than 30 minutes, I think you achieve everything. No need to cool the kidney. I have enough data with me, like I have not published it, but I have plenty of data with me. No need to do any hypothermia intraoperatively and the kidney functions fantastic. We have 1 year, 2 year, 3 year, 5 years now data available, and there is no difference in outcome of transplantation. We compare it with a little longer ischemia time, like 45 minutes of anastomosis versus the open transplant. Yes, the creatinine clearance is slower in a robotic transplant, but the outcome at 1 year, 2 year, 3 year, 4 year similar. Kishore, please, we have a few minutes.
A few things, caveats I would say. Whenever you start a surgery, like say prostatectomy, pyeloplasty, we always take thin patients. So that principle should be applied in transplant also, because we have a tendency to go directly to obese patient. I also committed the same fallacy initially to start with. The problem is that most of these obese patients, they have some of them huge muscular masses, they have diabetes, other comorbidities. Their creatinine is bound to come down. So that can invite criticism, especially from the nephrologist. And these people have like high intra-abdominal fat. They are more prone to ileus. So first thing, that mindset you have to change. You have to take easy cases. You have to do it fast. You have to get it comparable with the open surgery to start with. So I also did the same. I did like 10 really muscular obese kind of patients, and there was the same reflection from the nephrologist saying that your outcomes are slightly inferior. So then I switched. I just started doing on most of the patients thin. So then my skill also picked up. So obese patients also I started to get better result. And regarding the pneumo, because initially, I mean, first 10 cases everybody can land in a disaster, and sometimes it could be like a permanent. You have to closure of the program. That can happen. That all depends upon your luck. And I would say first, when you embark on, you do for a cadaveric, thin patient. These are the two single arteries. So and preferably a male donor to. Like easy male donor or a female donor, so you'll get good outcome. So at least you can convince the people around you this is a good procedure. The second, is that initially, what I do, I put a fan and steel and I put a gel point through that. So what I do is that once the vascular anastomosis is over, I just flip the kidney, wait for 5 minutes. As Dr. Modi said, I learnt it from him only. I just take the pneumo off and do the ureteric anastomosis through the gel point. It's quite easily accomplished unless the patient is super obese. You don't require that, but otherwise it is very easy to do. So you don't have the pneumo, you make the patient straight, the output start pouring in as if like an open. So that is how I used to do for the initial cases, and eventually, it's good for training purpose also. So our residents also used to get like that. So it's a double-edged thing, and that is one. And regarding why the output is less after doing so many cases, when you do the intracorporeal ureteric anastomosis, you're keeping the patient in Trendelenburg position and you're flipping the kidney to right iliac fossa. So there's a huge traction on the kidney. It's not like open, the patient is almost straight. So this is a very dependent right iliac fossa. So the renal artery, especially the slender renal arteries, they get pulled down and they go for the spasm. So that is what I've realized, especially in small renal arteries, they go for spasm and the output gets delayed. And then we are also in a fix, where output come, whether to open. All these things used to happen. So best is you take out the pneumo, the output will come immediately, do the ureteric anastomosis. You have to little bit swallow the pride like you're doing completely intracorporeal and do that, especially in the initial cases.
Right. There is a video. So this is a video of an upside down transplant, right?
This was a kidney wherein actually after the anastomosis we realized that the kidney has been placed topsy-turvy. You can see the anastomosis is absolutely perfect, but you see that the ureter is lying at the head end. So actually I wanted to ask the experts that experts as to how we can prevent this particular thing, and if at all it happens, what we did that we anastomosed it to the native ureter. So later on I also talked with Pranjal sir. He said that actually you can anastomose it to the bladder as well, but here we thought that it will form a kink, so we anastomose it to the native ureter. So two questions: how we can prevent it, and this thing, how to manage it?
Yeah, I think we have published it in first 72 cases of laparoscopic kidney transplant. I had 2 cases of a torsion and 1 case where we have done upside kidney transplant also. So we realized that the laparoscopy or a robotic laparoscopic assisted robotic surgery is a narrow field of vision. They do not have like what you have in open kidney transplant or so. So we always put a black silk mark at the upper pole, always, right? Since that day we learn, and then once the kidney is in, you have to identify which is upper pole and which is lower pole. That is the first step. And then you put it right there, because when the assistant put the kidney in, it can get rotated at any level. Sometime it is there in front, in the higher up, suppose you put an umbilical incision or subumbilical incision, then it is at the quite higher level. If you put a pharyngeal incision, then also sometime kidney is in a rotated or in a reverse side. So you need to find out that once. So that is such a simple measure, and always it should be seen. It should be kept long. And then just you cut it down at the end, even the silk remains there, it doesn't matter at all. Just a little bit of fat or a capsule is there, you can get through that. That's the answer to the first question. And, yeah, please.
What I realized is, when I did only one transplant, let me be clear about that. But this was a thing which was playing in my mind, whether I will go topsy-turvy and what all will happen. So I realized that when we packed the kidney, that the ureter will not be through the whole of the vessels. It will be coming through the mop, not through the opening which we have made for the vessels in the mop, so that the ureter is hanging way down. So once I put the kidney, I just go back with the camera and see where the ureter is. It has to go down. I'll have to pick up the ureter and see that there is it is not flipping the kidney. So that is what I realized, that's where I would probably, but my experience is extremely nothing in front of you.
Yeah, I think it's fine, but at the same time I would like to comment against this point also. Is anything additional maneuver which you require intraoperatively increases the pressure of a surgeon. Reason, it takes time. where does it go, how does it go, and then time is the money in robotic kidney transplantation. Everybody is interested. Once the vessels are clamped, you are worrying about DVT, you are worrying about ischemia to the limb, you are not only worrying, everything is timing. So it is very important that you reduce the number of steps, and that's how the simplest of simple is, like we wrap the kidney in a single layer gauze piece, keeping the hilum exposed completely. So what we do in a single layer gauze piece, like suppose this is the kidney, there is a gauze piece here, at the upper pole, close to the upper pole you take one stitch, at the lower pole you take one single stitch. So then the kidney is hanging in these things, and at upper pole you tie the black silk, so you identify which is upper pole, which is lower pole, etc. And ureter is wrapped within the gauze piece only. You put the kidney in, exposing the hilum, and now since it is a single layer gauze piece, through the gauze piece you can see the silk also. There is no need to have it hanging it outside. And then after you put the kidney in a position and start doing anastomosis, because it should be within short period of time. Yes, sir.
It has happened because that the kidney was in iceless and the gas piece was around, and through the phalansteal incision it is being pushed with a small incision. So while pushing it, the kidney got rotated inside, and that even though sutures were there in the gas piece upper and lower, the kidney itself has rotated inside, and this has happened. So to avoid that, would we do it like we also put a proline suture at the superior end of the artery and vein. It also helps in traction and doing the suturing, and we make sure that part of the ureter is coming out of that ice jacket, so you can identify it. But once both the time it has happened and we realized, then both the time what I did, what Arvind Ganpule has done, we used the ureterostomy, because I was trying to put the ureter back to the bladder and I saw that there is a tension. So I just did the ureterostomy. But the reason why it happened, when you are with a small incision, you are pushing the kidney which is in ice jacket, and you rotate in the jacket and you don't realize it.
Yeah, and then second thing is, like when the ureteric reimplant is to be carried out in upside down transplant, there are two aspects. One is you do the way you have done ureterostomy, usually it is stented. The second is you cut down the transplant ureter, graft ureter, and go to the pelvis level, and so it's a wide open pelvis, and just do the end-to-end anastomosis with the lower ureter. In that case, however, the patient should be practically anuric, and then there should not be a lot of urine output. Like say patient is having a lot of urine output pre-operatively, then certainly that technique is not acceptable, because patient can develop hydronephrosis, pain, even sepsis also later on if it is a closed pyonephrosis, etc. So these are the two different part but that can be happen. And in that case, I found that while flipping the kidney is very difficult because of the upside down transplanter, so I left the kidney in the pelvis also, and biopsy is definitely going to be a trouble. So these are the limitations of transplant. I think the time is over, but yes, yeah, please. No. I always prefer to go with the external iliac anastomosis, but it is not mandatory. It is very important. Like I started in my training with internal iliac anastomosis. All are doing probably external iliac, I believe, and almost, I do not know, Arvind, everybody is doing external iliac, right? It's more calcified often, especially in a diabetic and hypertensive patient. Erectile dysfunction is potential problem. Technically, it's deeply located. Internal iliac is much more deeply located, and where my kidney is usually on the internal iliac artery. Right, where are you going to put a kidney for anastomosis? So kidney is in the pelvis, so it covers the internal iliac artery region. So if you try to do it, then you have to have a fourth arm using the retraction of the kidney, which can traumatize the kidney parenchyma also sometimes. So it is prudent to go with the external iliac rather than with these things. Of late, let me tell you, it is not mandatory to put a gauze piece and other things. We learn that thing, how to manipulate the kidney without gauze piece also. We have done 40 odd cases of a transvaginal insertion of kidney and robotic assisted kidney transplant without any problem also, because there we can't use the gauze piece. It doesn't allow the easy passage through the vaginal mucosa, right? And then that is also possible. We have done pediatric transplant, initially with the pediatric robotic setup, but no more we are doing pediatric like 5mm instruments. I have SI, I don't have XI. So we have 8mm ports. We have used the youngest child which we have is 12.3 kg. So that is possible. 12.3 kg also. It is technically a little demanding. We did with common iliac. We did with the dual kidney transplant when there were marginal deceased donor is available. So everything and anything is possible. Interestingly, like if you find somehow your nephrologist has put the femoral vein for the dialysis somewhere else, or somebody has done and by mistake you open in an open kidney transplant found that there is a fibrous or a non-compliant external iliac vein. So you have to close this abdomen and then go to the opposite side. Here it is not, just you take the same kidney to the opposite side and start preparing it and do the anastomosis. That is another advantage robotically, where you can go with the left iliac fossa transplant with the common iliac vessel, I mean external iliac vessels or so. So many other advantages are there with the robotic surgery with a single incision. Right, with a single financial incision. You go in future with the second transplant, you just do laparoscopy, there are not much additions, you can always go through the same incision the second transplant also. So the advantage of minimally invasive surgeries are always available with the robotic surgery. Thank you very much. I think yes sir.
One point.
Actually, if you see 80% of the transplants are done only on the external iliac artery. Most of the centers, because whenever there is an issue, it is always with the internal iliac artery, like in the diabetics and hypertensives and other things. It will be usually the internal iliac artery which will be having some calcifications or plaques. And the answer is only doing on the external iliac. So, and then anatomically also, it is just, when you put the kidney across, the external iliac vein and the artery, they are just in front and it is easy. Internal iliac artery, when if you try to do, it has been done, but technically it will be always more challenging and demanding because it's an end-to-end anastomosis and there is a very small stump sometimes which is left over for doing the anastomosis.
Anand Kumar sir wants to put some comment.
Key point about the internal iliac artery. In robot, you need stabilization of the artery. So external iliac artery is well stabilized. Internal, when you cut it, put the bulldog, it will be free, and you have limited arms. So that becomes little difficult. So that is the one reason. You can do it. It's not that you can. The kidney is, you are doing an osmosis. Whatever pneumoperitoneum you keep, it doesn't matter because the kidney is not perfused. But when you are going to release the camp at that time, it is always be brought down the pneumoperitoneum to around 10-12. Third thing is that what Kishore said, kidney is under 10. Deep flap, it will go into the deeper part, the gravity and tension. But if that is happened, 2 maneuver you can do it. You can ask the assistant.
Just use this mic.
So ask the assistant to push the kidney from outside and take the sutures peritoneal flap into the cortex. That will get light and then reduce your tendon break position. That will take care of the tension part.
Okay, thank you very much, sir. Right, any other question we'll encourage outside, right? Because time is already over. Thank you so much.
Thank you, sir, for that wonderful talk on robotic kidney transplant. The next panel discussion is on newer robotic platforms. May I welcome the convener for the session, Dr. J.N. Kulkarni, sir. May I invite the speakers or the expert panelists, Dr. Sudhir Rawat, Dr. P.P. Singh, Dr. Pradnesh Barpuda, Dr. Raghavan for this session.
Hi. Everybody sit up.
Yeah, okay. Can we have the participant, please? Thank you. Dr. Bharpoda. Dr. Bharpoda. Thank you, thank you. Good afternoon. At the outset, I would like to thank Dr. Sabnis and Robotic Urology Forum, Dr. Yuvaraja, Dr. Ganpule, for asking me to take up this topic, which is newer robots. This is a part 2. In fact, we had a similar session at RUFCON in Ahmedabad, where we discussed about the actual procedure. But this is level 2. We are going to talk not about the procedure. I'm going to give you an index case and then request these panelists. You have Dr. Raval with SS Mantra, which is the Indian robot, Dr. P.P. Singh and Dr. Bharpoda. These are the two who are going to talk about CMR surgical. And I must say that these are the people who are not Da Vinci trained. Whereas others, Dr. Raghavan, who is talking on Hugo, myself and Dr. Raval are trained with Da Vinci initially. So these are the two new guys. Disclosure, nothing. And thank you very much, Dr. Ganpule has offered us, all 4 of us, Z security, so we can go from here to the state airport. So not to worry about, because this is a very controversial topic. So thank you for that. Yes. No, nothing to disclose. Now this is a classical case which will, Dr. Raval showed this afternoon, a very good video. Organ confined prostate cancer and a patient in a Trendelenburg position. Now these are the systems which are currently available. Da Vinci, Senhance, I had a chance to see in 2018. Revo is a Korean robot. Versus we have people talking about that. Avatera, which is not available in India, and remaining, and Mantra, which of course is absolutely new kid on the block. Just to show you all those guys who are behind, that these are the Da Vinci XI and single port. This is Versus. This is Hugo, and last is Mantra. Mantra is the. Now, what are the basic differences? And I will have questions as we go along. There are 3 basic differences. One is a closed console, which is Da Vinci, Revo, Hinotori. Open console are CMR, Versus, and Mantra. 3 we have open console. Now, as for the patient cards are concerned, single patient card is Da Vinci, Revo, Avatera, Hinotori. Multiple cards are remaining, which is Senhance, Versus, Hugo and Mantra. And the basic issue is that why these multiple cards? Because they are much cheaper to make. That's the understanding which I was told when I was talking to the IIT guys. Incidentally, we have at IIT Mumbai, we are also developing a robotic surgery program, and I'm one of the advisors, just to give you a haptic feedback. And they said that, and I asked this question, why this is, multiple cards and a single card? They said the point is, multiple cards are much cheaper. It just costs only 20 lakhs. That's what they told me. Now, having said that, what are the other differences? Finger loops in Da Vinci and Mantra also. Dr. Raval is part of that system. Joysticks and handles are for the Hugo and Versus. Now, question to the panelists. Now, there are first few concerns which I have. Sterilization, instrument maintenance, electrical connection. That's more important, electrical connection. Port placement recording. Now, I would like you to have a quick answers for me, one by one. Dr. Raval, please.
As you know, the Mantra is multiple cart, and there is a surgeon console, and then you have endovision. Endovision, which is used, is same as for is the Olympus. They are using Olympus, and I think Hugo is using stores. Sterilization is not a problem there. They have the separate, like you have in Da Vinci only. They have separate bags for that, which will get, which is sterilized all the time. And once we use it once, not like sometimes some center they do in Intuitive, but here we use once only, one time only. Instruments, they get plasma sterilizer or autoclave, you can do both, anything. Electrical connection, as far as electrical connection is now, what I have seen, it will improve definitely in Mantra, because it's a in initial stage, and every day they are changing. So there are multiple wire there, which they have made a platform which you can use on that. And but I feel I may be wrong in future. Their connections are more than the Da Vinci, because probably Da Vinci has single cart. Here they have multiple.
Yeah, Da Vinci requires 10 kV.
Yes.
So that's why. Now Mantra, one of the two. What is your
no,
analysis?
Versus no.
Versus, sorry.
Mantra is
no,
over.
sorry. Versus,
no,
sorry. My apology. My apology.
No, fine. No, as far as the sterilization is concerned, I think it is more or less the same.
Okay.
We have the sterile cover. But the used hand instruments are sterilized initially by just washing them with pH neutral water.
Okay.
Followed by they are cleaned in the autoclave area with the enzymatic solution. Followed by we use water jet and the gas jet to dry these instruments, and then they are sterilized either at 134 degrees or 121 degrees for 15 minutes or 4 minutes respectively, and then cool off period is 20 minutes.
Alright, so between the two cases you get a 45 minutes
yes,
or so.
Yes. Now as the maintenance, I think is
similar,
in
it's
this
not
only.
much, yeah.
The number of uses at present, we are using each instrument only 3 times.
No, we are talking about 13 uses or 10 uses.
That's what I am coming to.
Yeah.
The recommended use is 13 uses as of now. At all the centers all over the world, I have checked with them. The instruments are being used only 3 times.
Okay.
Fortunately, I'll just come to it in later part of my discussion. There are no add-ons in this system for the use of instrument, so it doesn't pinch me. I can pick up any number of instruments.
Sure.
I'll come to it.
Okay.
As far as the electric connection is concerned, the difference is like there can be 3, 4 or 5 patient cards. Generally there are 3 or 4. 5 I have never used. Maybe for the multi-quadrant I'll be using 5 cards. Now all these cards can be interconnected by means of a single wire, that 1 to 2, 2 to 3, 3 to 4 and 4 to, and from any of these cards a connection can come to the console of the patient.
Yeah,
so
like a Medusa or something.
So many wires jumping. People are working on it with 5G technology. How can we disconnect the controller, the control panel from the patient card? I think that will be the future with all things. As far as the port placement, should I continue?
No, I think we'll just understand. Port placement is the free port placement. Yeah.
And recording is external interface device.
Fair enough.
And you can take it to memory card.
Yeah.
Thank you, sir. I have very little to add upon. Sterilization is the same.
Sure.
Ports are very similar to SI ports, and there is a touch surgery. So the recording is live into the cloud, which you can retrieve by the evening. And the only difference from what that you need about 5 or 7 points on the floor level, which will be connected to the individual pods. And the other one point that you mentioned about the individual pod, the biggest advantage of the individual pod is even when one pod fails, the rest of the system works. You just disconnect and then continue to work as well.
Now coming to this another questions are like instrument diameter, and as you know now, Da Vinci has got XI system has got 8 mm things, and the CMR has got 5 mm. Well, let me come to your haptic feedback. All 4. Do we have anything at haptic feedback, or we don't have anything at this point of time?
Not yet.
Not yet.
As far as instrument diameter, camera diameter, instrument diameter is 8. As is for Da Vinci. Camera is 10, as used to be for SIHD. Control finger loops is like finger grip, not like palmer grip. So they say that this probably is more surgeons friendly. Port docking, as far as that port were concerned, port docking and all, they are like Da Vinci. The port gets locked, not like intuitive CMR where port is free. Right now it's free, isn't it?
Yeah, it's free.
Yeah, it's not. It's fixed with the arm. Only thing that the port placement is different. You just cannot do like Da Vinci you are doing.
No, that's fine.
You have to change.
Sure.
And ease of switching instruments.
That's important question. Yes.
It's like it's not as smooth as you have Da Vinci. Even I remember SIHD. There used to be a problem in the beginning.
So certainly,
so those things we are facing now, but certainly, then probably it will improve in future.
Yeah. Quickly answers the others. Yeah, go ahead.
Sir, about the port docking, and once you take out in any emergency situation, I think versus is more easy.
Okay.
It takes just like a laparoscopic surgery. You
we'll come to that. Yes, sir.
Sorry, docking is very similar. It takes like the SI system. The docking is very similar to SI system, and in terms of port placement, I have said SI system, very similar to SI system. It's a pistol grip. So anything else you want me to ask?
Yeah, now then we come to the most important question. Is patient in a trundle position? Anesthesia said there is a problem. And we have got 3 minutes only.
Hello, Dr. Kulkarni, if you just
sure, go ahead.
One is we have got 5 mm port.
Yes.
With this system, which is the basic difference. Now there is no port docking required with this system. It's just port placement, and there is balloon at the end of the port. You can just switch it. Only thing is that when you are putting in the port, I just wanted to mention, which I have realized in this system, you have to direct your port towards your target area.
Agreed.
If you do not target your port towards the target area, there is a port strain and there can be a false alarm, which keep on coming till actually you retrain your port, which can take a lot of time. Instrument change I counted with a trained sister. With a trained system, change of instrument requires around 50 seconds on an average.
Less than minute or so use.
Yeah.
So as you said, there is a learning curve for that.
Yeah.
Now coming to this is the most important. Everybody has to know through. It is possible that none of you have gone through this at this point of time, but this is what is required. So you got 3 minutes. Anesthetist said, I have got to straighten the patient and get rid of this thing. It is believed that if you have a single platform, the undocking will be easier. Let's listen from these guys now.
No, this is not a problem at all.
Not a problem.
Not a problem. You can, rather than 2 minutes, 2.5 minutes, you can undock the robot easily. There is no problem with that. But what I have seen during surgery, once, when I was using robot, the wire of my joysticks has got broke.
Yeah. Okay.
And, everything got frozen, and then we undocked the robot. And because this was not correctable, so we opened the patient with a small incision and finished the surgery.
Sir, yourself?
It's very interesting, crisis management.
Yes.
Now, crisis management I'll divide into 2 parts. One is a small crisis, like there is some bleeding. What I learned from robotic surgery, I was basically a laparoscopic surgeon for good 15 years. The most difficult part which I found was the sudden bleeding, which is difficult to control with robot, because you are working in a matchbox area. You can't see a surrounding area and all, and you have got one assistant who may or may not come at the right time. Now what you can do is just undock one cart. Let the robot be there, use the same camera, because camera has got good mobility, undock 1 or 2 carts and use it for the assistant, and again start with the robotic.
Okay.
In case even if you have to do laparoscopy, the same instrument.
Hybrid technique you mean?
Yeah, hybrid technique.
Okay, fair
just undock the camera, the same camera is used for this,
fair
because you have got 2-dimension view right on your front and the back side 2D views, so you can do it. That is not, I don't think it takes more than a minute to undock the thing. That is not a problem in case we have a trained team.
Right, good.
I haven't had a crisis, but when the new robot came in, we did the crisis management step.
Yes.
So we did 3 cases where at the end of the operation we said, okay, now the crisis is there. How much of time does it take for us to undock, extubate and put the patient straight? It took nearly 1 minute, sir.
Okay,
That's
very
what it
good.
takes.
So next, these are the advantages which have been standard ones. But I want to ask you the question, which is little in red. Enabling multi-quadrant surgery, quickly, one by one.
So this is probably the biggest advantage of multiple cart robot. You can put them in any quadrant. You just have to change the position. Rather in Hugo, I have seen Hugo also. There you need not require changing the position because they have very long arms, around 2 meters.
Okay, that's right.
Yeah. So, but in SSI, that's not a problem. You can do in any quadrant the surgery.
Yes.
And other thing is anything to add amongst your system.
Yes. Nothing.
Right now,
I wanted to say, because you said there is some belief that you can add one more arm. There is 5 arms.
Yeah.
So
that is there. No, that option is there. Rather, the surgeon console has 2 swap button.
Fair enough.
So that is why you can use 5th arm also.
Okay. Quickly.
Quickly, see, I'll tell you an example. I did 3 cases of nephrectomy for TCC ureter. Now, from the same ports, with patient in lateral position, we did the nephrectomy. Now, there was an assistant port which is there between the camera port near the umbilicus and the distal port in the mid-clavicular line. And in between, in the triangular fashion, there is an assistant port. This port was used as a robotic port to do the pelvic surgery. The camera port was same and everything remained the same. We did not have to do. Only thing was the assistant port was 10. It was to be reduced to 5. with
Okay.
a suture.
Piggybacking, okay.
So with the modular arm, I think multi-quadrant surgery is
Is possible.
Is a definite possibility. One needs experience to do it.
Very much possible, sir.
Possible, okay.
Very much possible. The biggest advantage with Hugo is that there is something called tilt.
Okay.
You can literally put the arm anywhere, tilt it up, tilt it down. You can join it from A to B at any direction.
Okay, now let's come to these limitations, especially in the city of Mumbai, where the operation theatres are very small. We have to have, all the robots do require space, and operating space available in modular OT these days is 350 only. More than that, it just cost not effective. So, anything to add? Is it fit in the 350 or you require a little more?
Hugo requires more, sir. Nearly it requires 500.
Yeah, I had to actually put off my XI robot from the bigger OT to a smaller OT, and because of the SSI we had to bring. But they have already coming with Mantra 3, where the floor space is very less. So this thing is evolving every few months. They come with the new things.
Okay, okay.
Versus the patient cart, each arm is, I think, approximately 18 by 18 inches. You can calculate. So there can be 3 or 4. That is not a challenge. Theatre area is not a challenge. The console is also smaller than the Hugo. And I don't know what the Da Vinci.
Da Vinci is 850 kg.
But you don't require extra space.
Fair enough. Chalo. Hey, Hugo, anything?
The space required at this point of time is nearly 450 square feet, sir.
This is the question which Dr. Malik was talking about. Can all surgeries done by these robots? And I don't want to take that discussion. It was a very hot discussion. But just to make a point, yes, yes, all surgeries can be done. You agree with that? All surgeries can be done?
See, when I said laparoscopy will actually get finished, there was a reason for this. We don't do open prostatectomy. Anybody does open pyelolithotomy? Nobody is doing pyelolithotomy open. Nobody is doing open prostatectomy. In future, if the robot becomes very cheap and the running cost, like I can tell you SSI what they have quoted to us, the cost of 3 instrument is nothing, is 25,000 per use. But if you use 4 and 5 instrument, it will be maximum 40,000. That's it. So suppose this evolve in further and it becomes cheaper, so who wants to use laparoscopy and make his neck, cry or your hands crying?
Remember, Dr. Rawal, that's why I offered Z security for you. Because you
so that's what future I was talking. I'm not.
Now, do you often use? Sorry, you want to say something quickly?
So you see, with my system, we have got a very good deal at present. Probably because we bought it at just at the entry. No extra instrument cost. Flat 80 or 90,000 rupees extra, plus added to laparoscopic surgery. If I want to accommodate my patient, I cut out on the procedure cost. Not completely, partly only. I am a salaried guy with my hospital, so it doesn't matter to me about the cost. Now, as far as all surgeries can be done with robo, I can say by now I have done 70 cases with this system. I have been able to perform whatever laparoscopic surgery I was doing. Renal transplant, I cannot comment.
Fair enough.
Probably we need more instruments.
Sir, I can comment only on oncology. Oncologically, everything is doable.
Okay.
I do not know about transplant and stones and all.
Borpada sir?
Sir, about the transplant, we cannot perform with this machine.
Okay. Now, do you look at this frailty index in all patients above the 75? Well, thank you. That's what I wanted to bring in the point. Now, what is my take on this before we put it further things? That while the debate on closed console versus open, single versus multiple card continues, the newer robotic systems will and look at the addressing the issues like tactile feedback, artificial intelligence, sensory output differentiation between hard and soft by robot, fitting to the table also, and use of drones. And this is exactly what IITB was talking to, what is called microbots. And what is microbots? Novel technology. Those who people, in 1966 there was a movie called Fantastic Voyage, scientific fiction, and that seems to be a thing which is going to happen in the years to come, that these microbots will get rid of this console, all these problems of skills and everything will be completely remote controlled and can be managed with the drones, and everything will be possible. So that is what as the new robots are. We are in an exciting times, and the generations which is sitting behind, you will not be listening to these multiple cards or something in about 10 years from now. Now, open for discussion.
Sir, before you open for discussion, just a comment.
Yes.
When you are talking fantastic voice, I'll tell you that there is a movie called Minority Report.
Yeah, that's right. I knew
And
you would say that.
those spider robot,
Yes.
and if you can make robot like this, you will be doing the single port surgery as effective as you do the open port surgery, open surgery.
Right.
This
right.
technology, once it comes, you will forget open surgery even.
Right. Yes, sir. Anybody? Well, we are on time. 4 minutes to go. Mallikarjun, you got to give me credit. I finished it all time.
Can I just add on?
Yes, please.
Actually, now we have been discussing about advantages.
Yes.
I would like to mention few disadvantages of the CMR at present, which need to be looked into. Because
No, that's a see, I'll tell you what. It's unfortunate that Da Vinci is 20 years. Again, my security is outside. 20 years. CMR is 5 years. So we cannot comment on an infant which is just growing.
No,
So
sir, I know.
so
Da
this
Vinci
will-
Da Vinci made a niche for itself,
No, the point
and it
is,
made it insurmountable.
No, it will happen. This will go. It will improve by the day, and we have to give time to them. For any system to do, it should be at least 1 decade.
Sir, another 5 years.
Yes.
You will have Da Vinci will be given run for money.
Run for
the
money.
reason that they are so aggressive now is for the simple reason that they are going to make a kill in this 5 years. That's all it is.
Off the record, these are not recorded, right? Are you recording?
Even on record, I don't care.
We don't
Because we
care.
have no disclosures, sir.
We have no disclosure.
No, we have no disclosure. Agreed. We have no disclosures.
We are in a disclosure.
That's where, that's why ROI, return of investment. Look at this return of investment here.
The advantage that Hugo has is that every COVIDian instrument will be integrated into Hugo in the next upgrade.
Yes.
Within the next 6 months,
Yes.
Staple, Whipple, everything will be integrated in.
Yes.
That becomes the biggest advantage. But the disadvantage is that there is a lot of wires around and the footprint is higher.
I can see that.
That is the only disadvantage of it. And I believe that with, as you said, another 3 to 5 years, Da Vinci will be given run.
So
for
you
money.
mean 2026?
So you
68, sir.
You showed
I have a
you
different
made a
opinion.
comment about the robot on table.
Yeah. Yes.
That
robot
was
on table.
actually already was there on the horizon, but then the company got
No. The problem was they did not understand. They don't have to use arms, which can be everything can be done exactly, and that's why the thing is it will be at the. You can just remove and finish it off.
No, sir. This is actually
I
was
think
there. I've seen that robot in Google.
Google,
Office
yes.
in
No.
when
They
the
lost.
Lexicon in Google came, but
They lost because they could not communicate to each other. Robot must communicate. Arms must communicate to each other. Like what happens?
But
My
I think
right hand
Anoop
moves.
is there.
Yes,
No, no,
Anoop there.
I have a thing. I don't know why we are looking at a point where they are going to be cheaper. I don't believe in this. There is nothing like, wait a minute. See, the question is, the model which exists today will become cheaper at the end of 8 years. But the unfortunate problem is you will have one more model which is costlier. I tell you, for example,
Yes, sir.
you had a 16,000 Motorola phone as a big gun-like thing happening in 1996 or 2000, and we all bought it. And today we are buying a 65,000 iPhone today. That's because the technology changes. So the thing what is looking this amount of money at the end of 8 years will definitely be cheap. I don't deny that
Malik,
fact.
I'll stop you
But
there.
but
No, I'll tell you.
there will be a new technology.
No, we have had a discussion about it in the morning when I did my signing with these people. The first condition was for next 10 years, whatever
Upgradation
is there,
upgradation
it is
is
in
free.
black and white. Listen to me.
तेरा ऑलरेडी 3 साल हो गए रे, अभी क्या करेगा अभी? 7 साल में खत्म हो जाएगा
अभी
तेरा।
3 years
उसके बाद तो उसका zero value होगा।
Let's have from the.
डॉक्टर 10 साल तक 1 रुपया भी
Any
नहीं है।
technology company, any technology company signs for 7 to 8 years only. Any technology company, any technology doesn't believe.
Malik sir,
beyond
one
8
thing,
years.
you have the choice. Imagine you can buy the single water Motorola phone and the iPhone. People have the choice to pick. More the robots come, the choice will be higher.
Raghav, we'll talk after 10 years.
All of them.
We'll talk after 10 years.
And all of them does
I'll
the
say
same
now,
job.
I'm telling you now, we'll talk after 10 years. The same Hugo guy, I said, You are in the infant stage of your this thing. Sir, they'll evolve in the
We
next
are
10
agreeing
years.
over your point.
Malik,
but
you only can afford.
It is a transportable robot.
No,
So
no.
you can
Okay.
shift the robot from one place to another place in the city also.
Now we can discuss
Malik,
further.
Malik,
Dr.
last
Gupta.
comment, sir. Last comment. Malik, just
Let Dr.
you know when I was born, even affording one cycle was a big problem.
Yes.
I know.
In a village, if suppose somebody gets cycle in dowry,
You have
You have a
that
Land
used to be
Rover
big
now.
problem.
You have a Land Rover
You
now.
just listen. Everybody now in that village are having the second-hand car.
Yeah.
That's it.
You know,
That's
because
progress.
it's became cheap.
Chalo.
Same way will happen this.
Thank you.
No. See, technology.
Thank you very much. Now, can I
We'll talk
request
after
Dr.
10 years.
Dr. Gupta, please?
What I want to tell you all is that I have to recently change my car because 10 years old diesel. So last 2-3 months I did lot of research on the car industry, and different types of cars are available. Even driverless car is coming. Same about the robots. So what I am trying to say, what I have realized is now there are so many players in the market. There are minimum standard. Safety of the equipment is more important, and then value for the money. How much you are spending, how much you are getting it back. I think so we should focus on that. Now we have a hybrid car, we have electric car, now we are driverless car. So like that, now I was thinking to buy electric car, but my family didn't allow me because they said no, safety is not assured. But future is that actually. You know.
Yes. Thank you very much. We had a great discussion. Thank you, panelists, for a wonderful thing. Thank you very much.
Well, thank you, sir. Your Z security is on the way. Now, to fuel the discussion further, let's have further talks in this session, which are crossfires in robotic urology. May I call the first moderator or expert opinion, Dr. Manoti, and the speakers, Dr. Santosh Vaigavkar, for the topic of robotic assisted partial nephrectomy, zero ischemia versus clamp in high layer tumors. So it would be 8 minutes of talk on hearing on one side, followed by 8 minutes of other side.
Good evening, everyone.
Go ahead.
Firstly, thank you so much, RUF, for the opportunity. I am here to talk about use of zero ischemia in hilar tumors and in favor of that. I have no disclosures, but I'll start straight away with the case. We have a 58-year-old male, incidental less SRM with 5 centimeter hilar mass, Padua more than 10. Now the patient came to me and he told me that he had also went and met Dr. Gopichand, and what was told to him was the surgery would probably be done by interruption of the blood supply to the kidney, the tumor would be removed, and then the blood supply of the kidney will be restored. Probably the chances of removing the kidneys are also there. So that thing struck me, and I thought that why can't I do this surgery without interrupting the blood supply to the kidney? Now we all know that partial nephrectomy offers better renal function and overall survival, and hilar position should not be a contraindication for performing it. Also, off clamp or zero ischemia is very well done in partial nephrectomy, but in hilar tumor, whether it is feasible or no, that is something we are going to see. As a starter, we know that Indians were the one who gave the number 0 to the world. In the same way, we have an Indian renowned surgeon practicing in US who gave the concept of zero ischemia. Now, this won't be the reason for me doing a zero ischemia partial nephrectomy, an emotional one, but let's look at the evidence. Before looking at the evidence, let's look into the mind of Dr. Gopichand and look at why he would refrain from doing a zero ischemia partial nephrectomy. What are the constraints he has? Probably the ischemia time, the understanding that he has about the ischemia time, whether it holds true, anatomical change challenges, unacceptable bleeding, conversion to radical nephrectomy. Let's look at it one by one. Will ischemia time matter? Now we all know that in 2010, Mr. Thompson told us that 25 minutes is the cutoff and every minute counts. But 2 years later, the same group went on to say that every minute does not actually count. As far as global ischemia are concerned, the investigator have found that surgeons are often obsessed with anti-hilar clamping. In fact, in 2016, Craig Rogers and his team went on to mention that almost all the cases of partial nephrectomy, global ischemia is performed even when it would not be required. In 2018, investigators also focused on minimal global risk renal ischemia, and they said that that will provide better renal function preservation. In 2015, again, Mr. Thompson came back and said that we need to put in efforts to limit warm ischemia time, and surgical techniques have to evolve which would minimize and avoid global ischemia. In 2019, finally, Dr. Pare came with his papers where he specifically mentioned that efforts should be made to minimize ischemia time in solitary kidneys and patients with baseline CKD, including hilar tumors. Now, if this patient of mine had a solitary kidney, what would have been if he would have undergone Hyland clamping? In 2010, it was clearly mentioned that partial nephrectomy without clamping was associated with superior preservation of late eGFR. In 2011, the concept of preserving renal parenchyma came. Now, if I have to conserve renal parenchyma, I need to understand the anatomy of the kidney well. Dealing with complex anatomy is going to be complex, but we know that there are intricacies available. I need to take out the tumor from this web of branches of renal arteries. And going back to the iconic paper where it clearly mentions zero ischemia is either off clamp or it is targeting the tertiary or quaternary branches along with superselective bulldog clamping. Now, if I have to deal with complex anatomy, I need to know the anatomy better. How could I do that? By the robotic platform which I use with 3D magnification, 3D imaging and 10x magnification. 3D CT reconstruction, which is done by most of us before partial nephrectomy, is use of Tile Pro and Firefly, and also use of intraop ultrasound, which will help us to understand endoscopic tumors, endophytic tumors better. We also know that in post-partial nephrectomy, renal chyma preservation is important, and that's where good imaging comes. We all know intraoperative ultrasound in hilar tumors will do magic. Also, use of 3D reconstruction in hilar tumors where we plan to do zero ischemia has got very good outcomes. Also, use of infrared technology in the means of Firefly help us to delineate the renal vasculature better. There is a concept of differential fluorescence as well, where we are able to prevent the positive margin, which is a concern when we are dealing with hilar tumors. In 2017 and 2018, Porpiglia and his team came up with a concept of hyper-accurate 3D CT, where they superimpose the reconstructed models while doing surgery, and they'll help them to get better outcomes even in hilar tumors. This is one of the surgery where they are depicted, where there is hilar tumor, they were able to reconstruct it well. They even went on to say that this concept of hyper-accurate 3D CT helps to simulate the selective ischemia. There is 90% success in selective clamping because we are able to predict what sort of ischemia areas will be there. Global renal ischemia can be avoided, and in fact, if we use Tile Pro and infrared along with that, then the outcomes are much better. They also went on to say that we are able to do simple inclination better by using this technology. If you look at procedure of zero ischemia per se and the outcomes, this is a paper by Mihir Desai and Imdar Gill, where they clearly say that they utilize micro dissection techniques where they go into the branches, the tertiary and the quaternary branches of the renal artery. They dissect them out and they do a non-clamping or a zero ischemia surgery, and they found it to be safe and feasible. And they also said that global renal ischemia appears to be unnecessary in these sort of tumors. Many people looked into this and came with similar outcomes. The last paper which I could see was in 2021, when this gentleman has shown how 3D imaging and augmented reality has helped him not only intraoperatively to look at how the image can be superimposed while doing the surgery as well as while cutting out the tumor from the kidney, but we are able to predict which tertiary branch can be sacrificed so that you don't cause renal damage and you're focusing only on the tumor and nothing else. And this Firefly can be used, and you can see that by this technique also we are able to see what are the structures near to the hilar tumors which can be saved. Last slide. So my take-home message is that present scenario robotic platform and with the help of enhanced imaging and augmented reality and with enucleation, zero ischemia is the way forward. But the question put to me would be, what about Indian scenario? I completely agree that augmented reality, iris and 3D hyper-accurate 3D won't be available, but if we were to use a simple mobile app like this, which is given by Inner Sight, in which we are able to actually see the tumor and see the vasculature surrounding it, see the renal vessels surrounding it, I think zero ischemia is very well possible even in our setup. So my final message is availability of modern imaging and robotic platform makes zero ischemia feasible, and counseling in these cases should now start from zero ischemia and then go on to SOS hilar clamping. Thank you.
Yeah, we'll call up to the next speaker for the clamping hilar tumors, Dr. Gopichan.
Thanks, Santosh. So I'm talking for clamping. I'm Dr. Gopichan. I'm Dr. Gopichan. I'm from Hyderabad. Advantages of clamping I will not reiterate, but we all know about the control of bleeding, margin, suturing is better, visualization is better. There is a definite advantage in complex tumors. We can see this. This is a posterior hilar tumor. We have to flip the kidney, and without clamping, we cannot imagine doing this very complex tumor, especially if it is a low volume center or there is some issues with the early learning curve and all. So clamping is a necessity in these cases. Some hilar tumor scenario I will show. This is the same tumor that Santosh had shown us, how we tackled this tumor. Similar situation. We clamped the renal artery and renal vein, and we can appreciate that we are dissecting the tumor now, and we can appreciate the sinus fat, the opening of the pelvic ileal system, the vessels being opened, and no bleeding there. The margins also we can very easily appreciate. So this is very well clamped, and then we'll repair it under good vision. And the most important thing is that there is no complication while repairing it. This is another case scenario where bleeding was there in spite of artery clamp. So this is the dissection that we are doing. So we have some bleeding in spite of the artery being clamped. So this is the situation. So in this situation, there is brisk bleeding there. So the margins we cannot see it properly. So we are clamping the renal vein and then appreciate the margins properly here in this case. See the margins very clearly it is seen. The third case again, this is a patient in which we thought that we had missed the renal artery. We had to clip the renal tributaries of the renal vein also, but it got a little messy and the margins came positive in this particular case. So I will not talk much about this 25 minutes warm ischemia time, but warm ischemia, this is 2011 editorial, warm ischemia less than 30 minutes is not necessarily safe during partial nephrectomy. Every minute counts. It was like quality, quantity, and quickness is also very important. 2019, there is some paradigm shift in this. Renal ischemia during partial nephrectomy, does every minute still count? What is more important, the warm ischemia time or the preserved renal tissue? Both of them seems to be representing the sides of the same coin. You know, when the tumor is complex, you will get more amount of warm ischemia time and you will have less preservation of tissue. So it is very important to balance between these two. Mainly the disadvantages of clamping, the nadir creatinine is much higher and delay to reach this nadir creatinine is also much higher. So more the warm ischemia, there probably is more comfort, less bleed, less complication, resection will be better. But what is the disadvantage? Loss of renal function, higher nadir creatinine level, delay to reach this nadir creatinine level, and definite perfusion injury. Is this really true? Is this relevant even in 2022? So we have to revisit what this warm ischemia time means. Does it really matter? Partial nephrectomy and warm ischemia time, clamp time may not matter. Off clamp techniques and going for speed may not be necessary to preserve the function. Now these are few of the very important publications. One is this publication by Simmons et al., functional recovery after partial nephrectomy affects the volume loss in ischemia injuries. This predicted in multivariate analysis that volume preservation alone affected the long-term outcome, and ischemia time was not a single factor in the multivariate model. This is 301 patients, volume loss, and the same paper, and not ischemia time was primarily determined. So we have to make technical modifications in a way so as to minimize the volume loss during partial nephrectomy, just not look at the ischemia time. This is another paper, residual parenchymal volume, not warm ischemia time predicts the ultimate renal function outcomes in patients undergoing partial nephrectomy. Again, multivariant analysis, the pre-op GFR and the functional parenchymal volume were determined of GFR at 6 months. This is another one by Parikh et al., which we have discussed 2 or 3 times today, tolerance of human kidney to isolated controlled ischemia. This was tissue biopsies were done in partial nephrectomy patients with normal contralateral kidney, more than 30 minutes clamp time. Renal function studies and pathological changes were seen. This suggests that kidney is resilient to warm ischemia time, and the kidney can recover even after clamping for around 60 minutes. Long-term response to renal ischemia in human kidney after partial nephrectomy results from prospective clinical trial, paper by Kellingal et al. Again, duration of ischemia did not correlate with the final functional outcome. This is 1 year follow-up. So factors determining the final GFR, the functional residual parenchyma, this is how much tissue we could save. It is important to have a normal contralateral kidney. Normal kidney is resilient to ischemia. This is also we have seen. So partial nephrectomy principles should be focused on the oncological integrity, the renal preservation, the surgical safety. Just no need to fixate on counting minutes. There is no need to do a zero ischemia in, especially if the patient has normal contralateral kidney and also in complex tumors. Even if we are doing a zero ischemia, all preparations have to be made so that, sometimes even the simple tumors, this is a very simple tumor, peripheral tumor. Here also we have to make all the preparations so as if bleed occurs, we can take a proper call on that. Thank you. And
yeah, thanks. Both the speakers have done the justice. There is no rebuttal. So I think both of you have spoken. I think what is the crux, the final outlines, what you spoke was the patient selection is the paramount importance, and with the advances of the imaging and intraoperative and preoperative imaging will help you in go for a super selective clamping. And I think you also mentioned regarding the bleeding part, I think there is also an issue. So the case selection is very important. Both the techniques has to be utilized depending upon the case selection and the imaging and the location of the tumors. I think this is the final bottom line where both the techniques has to be included in the curriculum. Yeah. Yeah. No, in the sense they mentioned that during the, I think the non-clamping is more helpful in renal insufficiency patients. That's what the literature said.
Yeah.
The material of the kidney that matters. So this is an ischemic kidney already.
It is already ischemic. It is already ischemic kidney. In such situations, if feasible, a zero ischemia would definitely give superior results over clamped this thing in a patient who already has some amount of surgery renal function is not good.
Yeah, it's very clear that patient selection is the paramount in selecting which technique to be done.
But then again, in that situation, zero ischemia, if we have lot of bleed or we are compromising on the volume loss and all, it will again give a poorer results. Yeah. Material.
Can I ask a question?
Yeah, Panjal, please.
Can I make a comment?
I have never seen in any workshop demonstration of a zero ischemia. Any workshop, have you seen that? Any workshop?
Come again, have you?
Yeah, I think this is an exceptional place where the zero ischemia partial nephrectomy has been carried out. So whatever the publications are there, it's different. Even in a like there are several workshops happening in Europe, several workshops happening in United States, in India, everywhere. I have yet to see if somebody has seen it. It is fine that zero ischemia, partial nephrectomy for mid-polar tumor or even a polar tumor has been carried out. And whenever even there is a small slippage of the poor quality of the bulldog clamps are there, the surgeon shouts that we are providing a poor quality of the bulldog clamps, and we talk about it. I think the debate, I don't think in this particular audience also anybody is interested in zero ischemia kind of partial nephrectomy. If anybody is there, please raise the hand. Because this topic is so controversial since years together and nobody practices it. Why should we debate about it? Thanks.
No, there is specific indication for that.
Can I make a comment?
Yeah, please.
Actually, in a situation where the creatinine is at 2.2 or 2.5, there may be two situations. One is that the vessels are atherosclerotic, and the second is the parenchyma is ischemic. In a situation where the vessels are soft and you put a bulldog clamp or any kind of a clamp, the likelihood of that vessel recovering is good. But if the vessel is already arteriosclerotic or atherosclerotic and you put a clamp, then even if you release the clamp, the perfusion in the kidney may not be very good. And that is a situation where we must try to achieve this zero ischemia kind of a thing, because putting a clamp in an arteriosclerotic vessel can damage the intima and can lead to a permanent occlusion, a thrombosis of that vessel.
Yeah, it's very evident that we have to at least try for the superselective ischemia. I mean, we have to reduce the main arterial occlusion should be reduced. That's what half clamping and clamping. Even if you want to clamp, it's better to go as super selective as possible to clamp it. That's the way to do it. Especially it is very useful in compromised renal kidneys. It is so that's where it should be going towards. What we learn from these two is ischemia is required depending upon the patient selection, and it should be super selective.
Can I ask one question?
Yeah.
The question is for Santosh. So if you believe so much in zero ischemia, would you be able to do the same procedure laparoscopically if you don't have robot? Because this is all started with the robotic thing earlier.
So as I mentioned,
you can come here. You can come here.
So as I mentioned in my talk that, and as sir mentioned about doing a zero ischemia and laparoscopy, well, I agree with some of the points that zero ischemia is something which would be supplemented by all the imaging guidance that is there available. And if the imaging guidance is available, I showed in my last slide, that small app from inner site, which is available now at a very nominal cost, if I am able to delineate the supply well, and if this information is available to me, where I am able to see the vascular supply of the tumor well, then I'll definitely attempt a zero ischemia with a laparoscopy. And in my last slide, I've also mentioned that the counseling is also important. That here the patient safety is extremely important. So I'll start with zero ischemia. If it is not happening, then definitely it will be hilar clamping. I'm not saying I'm not no, but zero ischemia definitely will be attempted even if I'm doing lab with the information given to me by enhanced imaging. I'm not talking about augmented reality. I'm talking about a simple app where we can actually subtract the tumor and actually see the vessels which go near to the tumor, and that information can be available to us. Iris, which probably will come in a year or so. If this information is available to us, then why not?
With artificial intelligence coming into the imaging, I think more and more super selective ischemia will be preferred. So we'll come to an end for this discussion. Congratulations to both of you.
Well, thank you, Dr. Santosh and Dr. Gopichan, and may I thank Dr. Manohar for that expert opinion. Now, coming on to the next mini debate is side docking versus front docking for RARP. The defenders and opponents are Dr. Ashwin Tamankar and Dr. Vivek Venkatramani. May I call expert opinion by Dr. Janak Desai, sir.
Okay, so we move on to the next small debate. Robots can be docked centrally, what is called traditional docking. They also call it TD or CD, central docking. And they can also be docked by side docking. There are advantages and disadvantages. So let's begin the debate. At the end, I'll sum it up with a few slides. So please go ahead.
Thank you, sir. So thank you the scientific committee for getting some different topics on the debate this time rather than a standard conventional robot versus laparoscopy debate, a little different than a normal run-of-the-mill way. So I'm defending side docking, but I have a disclaimer. I use SI system. I do front docking for RARPs. It is limited to RA. The discussion is going to be limited only for RARPs today. So we are not discussing about cystectomies or anything else. So I do front docking with SI, and my dear friend is going to talk about front docking, and he uses XI system. So there is a bias, but I've tried my best to understand the points myself as well for side docking, for the use of SI system, and I got some learning points which I'm going to put forward for everyone. So these are certain fallacies of lithotomy position. All of us know that. I'll just quickly sum up. Difficult hip rotation patients. We do encounter these patients once in a blue moon, and we probably need to be prepared for these patients. Kyphoscoliosis, morbid obesity. PVD is one element which I got to learn from while preparing for this debate. We generally do not actually ask those patients about the history of PVD or claudications, but they are the ones who are more prone for compartment syndrome. That is what the literature says. So one learning point for all of us. Important other lithotomy related aspects of compartment: neuropraxia, rhabdomyolysis, DVT, sciatic compressions, lactate levels. We generally have a lot of lactate levels perioperatively. Anesthetist flushes fluid, or ICU guys flush fluid for entire overnight to get those lactates corrected, but that may be there may be an element of additional lactates because of lithotomy position as well, giving some hypoxia. And obviously the assistant related factors, a better access with side docking for the urethra. If you need to probably we have encountered these situations that you have a subtle stricture which we have dilated, you're keeping a flexi cysto on standby before putting the final catheter, and it is little better for side docking in that particular occasion. And obviously a little less extra docking time. Table motion is little better with side docking with the higher versions of the robot or newer versions of the robot. And emergency de-docking, probably I think side docking is better because the assistant has a wide access for the entire pelvis as well as the other quadrant of the abdomen. So there are literatures about compartment syndrome. People generally have, they do not come forward to talk about it, but as probably people grow older with a lot of cases happening in their decades of careers, they must have encountered few compartments and neuropraxias, which ideally they should come forward and discuss about it. So UK paper about over 3,000 patients, 9 compartment syndromes, 0.29, though it seems to a lesser number, but that is probably an avoidable complication, and almost all required fasciotomies. Risk factors are important. Console time of more than 4 hours, early part of learning curve, obesity, and peripheral vascular disease. That's why PVD is an important stuff. Only few papers. I'm sure Vivek must be Vivek would be incorporating these papers, and in fact this is going to help him for the debating purpose, but we are here to learn. So side versus central docking, it's only one randomized study, but they did it with SI system. So that is one important part, because normally we use front docking for SI, but they use it with SI system, and results were comparable, no advantages or disadvantages, but obviously potential less complications related to lithotomy with side docking. Another retrospective analysis, it tells us that probably little lesser docking time, but I don't think that there is a point to be debated for 8 minutes of advantage with side docking. The SI system, again, this is how they do it. Personally, I have never done it. I became more educated after going through that, and I'm probably going to use it, or I'm going to take inputs from the senior members here about that. But SI system, it is doable. Unfortunately, not been a part of a normal training. That is what I would say. A recent, this is 2000 article, 2020 article. This is a survey which has been taken across various specialities, across urology specialty across different countries, predominantly from US and certain from European standards. So if you see this, people are using about 75% are using XI, still 75% are using front docking, surprisingly, and nearly 76% are the ones which are using lithotomy position are into the academic affiliations or academic hospitals. The main reason for not using or using lithotomy is it allows little better access, has little better access for the robot docking, and basically surgical familiarity with the entire team. That's the main reason which is quoted for using front docking instead of using XI system. So there are multiple points to be debated for between these two, but ultimately if you have a complication at some point of time, you will have 400% increase in the cost because of additional things, because of additional management related or emergency fasciotomies, and odds of patients staying longer in hospital is about 3 times. So the biggest reason for positioning choices were convenience of the surgical team, and obviously thereby that also translated into the era when they got trained into in their surgical training. Talking about some other systems, the SP system, obviously it comes from head, so it's never a side or front. You don't have to debate about it, so no lithotomy again, which is the point which I'm trying to drive across. Early papers of the Versius system or the CMR, it is from the sides, either 2 instruments or 3 instruments, but it is never through the leg or the front docking. So different other systems are utilizing different parameters, or they are not using front docking essentially. That is what I mean to say. So this was a short survey which we conducted last few days. Around 20 people, I should thank them, 20 people participated in that. So in Indian standards, people have a mixture of SI and XI system. We know about it. A variable pattern of about 10 to 15 years of experience, or 5 to 10 predominantly. The console times for RARPs have been approximately 2 to 3 and 3 to 4 on an average. Many people who are using SI systems said no for the side docking. They are still doing front docking, and the reason for that was they never tried side docking. They were not even aware that the side docking exists for SI system, and few were generous to mention about their complications, that neuropraxias do exist, buttock muscle necrosis does exist. So there are multiple factors which they came forward with. So that was our learning curve paper from UK. It's a humbling operation. Even you've listened to Professor Vip Patel, he says he's still learning after doing more than maybe 15,000 prostatectomies. So the console times honestly are still at least 3 hours or above if you plan to do a safe surgery, and then the lithotomy for that many hours and additional anesthesia time is a questionable thing. So whenever you can avoid lithotomy, probably I would try and avoid it. And that's why I'll end my session by putting the same slide again. What are we achieving by not giving lithotomy and preferring side docking is all possible complications related to lithotomy, the compartments, neuropraxias, rhabdomyolysis, which are the detrimental things which potentially are avoidable, and they do happen once in a blue moon, but if you are the unlucky one, then you have to obviously face it. So if it is avoidable by doing a side docking, especially with XI systems or the newer versions of robot, why not to go for it? SI, myself, I use front docking, so I can't actually debate about it. I'll keep it open for Vivek. Thank you so much.
Thank you, Ashwin. Now we'll have the other side from Vivek, and then I'll try and sum it up. So Vivek, please go ahead.
Yeah, sure. So many thanks to the organizers. As Ashwin said, we both, I think, learnt a lot while we were doing the research for this particular debate. So I think that's the sign of a really great topic. So, is it up?
Yes, I have.
Okay. No, it's not showing on that. Okay. So, I'm here to convince you that the traditional front docking is the champion and still the gold standard as compared to, the newer side docking approach. And the main aim of docking is to position the arms at a sweet spot to minimize clashing. And this also minimizes assistant and sometimes even patient injury. So that is what we are aiming for when we are docking the robot in an appropriate way. It needs to provide access to areas the assistant needs to reach. It needs to provide a clear field of view for the console surgeon of the robot itself and what's going on at the bedside. And it needs to provide a view of the video card to the bedside assistant and not get, too many cables and things stretched in the way. So optimal docking requires an approach angle which is perpendicular to the axis of the robotic ports. This is what allows the widest range of motion, and that is when it is parked at the correct sweet spot distance and centered on the camera port. And this is best achieved by docking through the legs for any pelvic surgery. And it's not me who's saying that. These are from the textbooks by our stalwarts, Dr. Hemal, Dr. Menon and others, and this is the conclusion of how to optimally dock a robot for any pelvic surgery. And this is what we see when the robot comes through the legs, that you are absolutely perpendicular to the line of your trocars, and that provides the maximum field of view. And similarly, there's no obstruction to the assistant. You may even have an assistant on the other side if you so wish, and there is a clear view for the surgeon as well at the console of what's going on at the bedside. The benefits of side docking are purely on the risks of lithotomy. There is no other added advantage of side docking. And what exactly are these risk factors of lithotomy, and how common are they? So neuropraxia, the incidence is 1 to 1.5% for robotic prostatectomy. By definition, it is reversible. Of course, it increases with the duration of the surgery. And there was this one paper which showed a 10% neuropraxia in those who they did front docking. I feel that's way too high, and versus 0% for those who had side docking. So there is one paper which does show a benefit for neuropraxia, but again 10% seems quite high for me. Compartment syndrome, I think the same paper Ashwin has also quoted, just 0.29%. Again, bilateral hip disorders which limit abduction of the legs. How often do we really see this? Maybe once a year, maybe probably even less than that. And simultaneous cystoscopy, very, very, very rare in cases of robotic prostatectomy. Some people say that, if you're side docked, you can access the rectum better. If there's any rectal injury, again, 0.2%. So everything we are dealing with here is 1%, 0.2%, 0.2%. So overall, you add everything up, it's probably like 2% of cases where, side docking really has some role. Disadvantages, there is a diminished range of motion with instrument clashing. And this is a quotation from the textbook. Experienced users may maintain reasonable access to the pelvis even with a side dock robot. So that's pretty diplomatic to say the least, again from Dr. Hemal and Dr. Menon's book. So in India, where we often have different staff, different technicians, different assistants, we are struggling, to kind of make a coherent system and a robotic program. Is it really worth it when your assistant doesn't know he's going to be hit by the robot, he doesn't know where to put the suction and things like that. So all this thing to struggle for 2% of cases, to me, it doesn't really make that much sense. A longer surgical time, as I think Ashwin also showed, in the side docking due to increased instrument clashes. It is difficult to do with S and SI. Like Ashwin, I thought it's only for XI that we have to debate, but when we looked at the literature, it's actually all the papers are from S and SI system, but it is difficult to do. And if you are really doing a side docking with lithotomy in an XI, there's obviously no benefit. It's only if you do it in a supine. The disadvantage, again, if you have a side dock and the vision cart is blocked a bit by the robot itself, then it's difficult for the assistant. Obese patients, it may be difficult to access the perineum. Like I said, we can use 2 assistants if you need. And these are some challenging cases where you need access to the perineum. If the patient is supine, you are going deep into the pelvis, you can't push the perineum up and get a good anastomosis. When the patient is supine, again you are hampering your surgery itself. Similarly, big bleeding from the DVC, you need again some pressure to access the DVC and get a good suture in. This again is much better with a front dock where you can push, and not in a supine position. You need some amount of lithotomy or legs abducted for that. And suppose you need to open for some worst case scenario. With the side dock, there's a robot right on the side. Where are you going to stand? You need to undock, get everything out, and then only you can open. So it definitely reduces the flow of the surgery. And these are quite clear. Optimal docking is a front docking. That's just how the robot is built. The absolute indications for side docking are extremely rare. Use precautions. I'm surprised. I think Ashwin's patients are going to ICU. I don't think that happens in most prostatectomies. Stay vigilant to prevent neuropraxia and compartment syndrome. Do what works in 99% of the cases and not look for 1% risk of complications. be vigilant and try and prevent it in whatever best way you can. So just keep it simple, use common sense, it's not so difficult. Thank you.
Excellent. Vivek, both of you put forward relevant points for side docking and central docking. I think most of us are still doing the central docking. The side docking is a concept which is building up. After listening to you, I feel very happy that I am still the central docking kind of a surgeon. Let me sum it up and then we can take questions. Or do we need to, anybody wants to ask? Yes, Dr. Adla.
Exactly.
It comes at a 45 degrees, and if you look at gynecologists, they have been doing it first as a standard of care.
Right.
I know they only use 3 arms compared to our 4 arms. The docking is so much more simpler. That's one. And whenever you have any trouble with respect to DVT, you take out the DVT out of it. So that's another advantage. So yes, it is a good debate, but it is a debate for the sake of having a debate. It's not actually that way. You don't even perceive that there is that much amount of clashing. That's from my personal experience.
I'll just tell you a secret. My technicians.
Yes.
Yeah. Yeah, but that's why there is more clashing. That's what is, in the literature. But my technicians always like to bring it in from the side, even though I always tell them come through the center. So I think we use it whatever is convenient for them.
At least because I have done the whole thing in my fellowship as well. From the assistant's perspective, when we didn't have side docking because we were using the SI earlier, now I'm using an XI for the past 1 year. With the side docking, you have a very nice clear view of the screen right in front of you, not at an eccentric angle. Also, for most of us who are right-handed, sitting on the left side of the patient, you get lot of area and exposure because there is nothing coming in from the middle obstructing your view towards the screen. So ergonomically, I do feel side docking is better for the assistant at least.
For the assistant,
yes.
Yeah. Okay. Okay.
Can I have one question?
Dr. Kulkarni, the grand old, not old, the grand young oncosurgeon.
Thank you for those kind words. French people do prostatectomy extraperitoneally, and what I saw them, they were doing very comfortably with the side docking. That's where I thought this is. And talking about to the people that you must start extraperitoneal, which is a natural way of doing it. Although you do transperitoneal port placement, ultimately go extraperitoneal. Why not go this way? So I think there's one indication where if you are planning an extraperitoneal prostatectomy, or side docking is the best answer. Thank you.
Yes, there is a young man there.
Yes. So the same.
We are regularly doing side docking for on SI system, and like Dr. Vikram said, we don't really bother much about the screen. So Ashwin alluded to the fact that most of the problems with front docking are due to the dichotomy position. Do you have any literature that looks into a split supine position, split leg supine position, where the lower part of the table splits? There are tables like that probably available.
There was one paper, but it is, I think, for a gynec surgery, not yet for...
Can we think of it as a possibility since you are so much in love with front docking? I just wanted to ask you that. Thank you.
Sure.
Well, if there are no questions, let me sum it up. So, I mean, I was just talking to Dr. Dogra once again, the senior colleagues here. We were all, I mean, I am still used to the central docking, and he moved to Gangaram. And he said that they convinced him to do side docking, and he tells me, Janak, it's easy, it's possible. So, I think, of course, there are points for the debates, but if we have to summarize what is important for the central docking, it is like if adduction is a problem, then there is an issue. Very rare perineal injury, which you put it like 0.2% or something like that. Compartment syndrome also very rare, but yes, possible. And rectal palpation, I think we are good enough not to damage the rectum, so we really don't need the rectal palpation. But the parameters that needs the parameters that we have to compare are the docking time, the operating time, and the complication rate. And Ashwin already put up this slide. So if you compare, this is this Italian study where they compared over a period of almost 5 years, 190 cases, something like that. Central docking versus side docking, and the setup time was more or less the same, a little in favor of side docking. Docking time was the same, surgery time remained almost the same, the mean blood loss was almost the same, hospital stay almost the same, though I was a little worried to see that the hospital stay was 4.5 days almost. In India also it's lesser than that. In America it is just 24 hours. If you go to Vipul's place, next morning the patients are out of the hospital. So side docking, the points are more space for the assistant, less collision for the robotic arms, supine position, less neuropraxia. These are the points put forward, but thank you very much. A very good debate. Both of you brought in some good points.
So one quick point.
Yes.
Especially in front docking, when you have a lithotomy position, your staff has to be regular and vigilant. It has to be a dedicated team, because padding, positioning, giving adequate padding to the lateral compartment, these are all things which are going to be dependent on the or operator dependent or the staff dependent problems, and which Vivek mentioned clearly that in corporates we may not have that kind of luxury every time. That's the hustle. So we have to be there on guard, starting from the beginning, from the induction till the end. You can't even have a cup of coffee going out.
Yes.
That's the issue.
Robotic surgery is teamwork, very efficient teamwork. So we agree with that point. Let's move on to the next topic. Thank you.
Thank you, Dr. Ashwin, Dr. Vivek, and may I thank Dr. Janak Desai, sir. Yeah. So now we'll move ahead with the next panel discussion, which is on best practices surgical management of localized kidney cancer. May I call upon on stage the moderator of this session, Dr. Arvind Ganpule, the panelists, Dr. Anand Kumar, Dr. Anup Gupta, Dr. Raghavan, and Dr. T.B. Uraja.
So thank you very much, the respected panelists. We have got Dr. Raghavan to come yet. So over the next 20 minutes, we'll be discussing a view, very selected, only 4 points we are going to discuss as regards localized kidney cancer. Without wasting time, we'll go straight away and dive deep into the topic. I'm esteemed to and privileged to be having these 4 panelists who really do not require any introduction. The background of this particular discussion is as follows. We all know that there are multiple guidelines, EAU guidelines, AUA guidelines, so on and so forth. But the problem is that owing to disparities in access and affordability, the treatment options that are offered in these AUA, AUA or NCCN guidelines do not necessarily apply to our population. So keeping this thing in mind, what we decided that we'll discuss on these 3 points. Which are those cases? We are talking only about T1 and T2 disease. Which are those cases wherein an NSS would be preferable rather than radical nephrectomy? What are the considerations in the opinion of the esteemed panelists, whether they will go ahead with an open, robotic or a laparoscopic approach? And what are their views on doing an nephron sparing surgery in T1A vis-a-vis T1B and T2? There is one more aspect to this discussion. Recently, a community survey was conducted of 120 community urologists, and what we'll try to do, that we'll take an opinion of the panelists and try to collate their opinion with what are the results of the analysis of the the survey of 120 community uro-oncologists. Just a brief about what is this survey that we are talking about. This was a community uro-oncology group survey wherein there were 2 groups of participants. One were the 120 community urologists, and the second group was an expert panel. And the expert panel actually discussed and devised and survey on these 5 points: the diagnostic evaluation of renal masses, surgical management of renal masses, and what are their views on the follow-up and surveillance of these patients. The survey included 35 multiple choice questions, and they were passed on to all 120 uro-oncologists, and we'll see what are the results of those survey. So straightway we'll go to the first question, and I would ask this question to Dr. Raghavan. Now we'll take this case as an index case. This is an right-sided renal mass. As we move through the movie, you can see that it's an posterior mass, almost an hilar mass. The reconstructed image, you can see that this is the mass, a single renal artery. So my question would be, how do you plan your nephron sparing surgery, specifically pertinent to this point? Which are those cases wherein you will typically offer an open approach? Which are those cases wherein you will typically offer an laparoscopic approach, wherein you approach an robotic approach? What are the key considerations?
Thank you, Arvind. It's a pleasure and honor to be here. Thanks for the invite, and thanks to sir as well. For me, the only criteria for doing a nephron sparing surgery is anatomical feasibility to do a surgery. That's my only criteria. If it's anatomically feasible to preserve a kidney, then I will preserve the kidney. Okay. Number one. Number two, open versus lap versus robot. I don't do laparoscopic partial nephrectomy at all. I stopped it in 2009-10. So only two choices I have, open and robot. The only reason I do a open partial nephrectomy, every year I do at least 3-4 of them, and the only reason is extremely hilar tumor where I desperately need to preserve the kidney and I need a longer clamp time so that I can give ice and cool the kidney and work peacefully. And those are the tumor, exceptionally rare cases I pick up and do the open surgery. Rest of all the surgeries are done robotically as long as cost is not a consideration. In my hospital, I figured out methods by which cost has been negated as a consideration.
Okay, so typically this has been given in one of the textbooks, and this is what we believe also, that if you see the conundrum, you will see that the easiest case to do an partial would be a lower pole anterior mass, followed by lower pole posterior mass, followed by mid pole lateral mass, right upper pole lateral mass, left upper pole lateral mass, hilar mass, and finally a completely endophytic tumor. So two questions wrapped up in one question. Do you believe in this conundrum, number one? And as you said that you only do open partial nephrectomies in only the last two set of patients.
Absolutely right. This conundrum or this graph is perfectly legitimate. It will be very good, especially for newly starting career people, because this is a nice way to select your cases, especially when you are moving from open to laparoscopy or robotic technology. And definitely the second answer to the second question is that for me almost the last one or the just bordering the last but one are the only two indications where I do open surgery. Even in those cases where I believe that I need more time, not just the hilar partial, it is absolutely hilar. There is no way I can do it comfortably in 25 minutes clamp time. That's the case I open up.
I think you have summarized it very nicely. A few interesting snippets from the uro-oncology survey. What did the survey say? That the 120 participants, almost 100% of the participants registered their response that the preferred modality for imaging before and partial nephrectomy was an CECT. And MRI was restricted only for those patients wherein they wanted to delineate the thrombus or there was a contraindication for CT contrast. And finally, again, this was a very expected response that PET CT was not used for evaluation by any of the respondents. And I'm sure all four of my esteemed panelists will agree on this point. Further, as we were talking on this thing, these were the 6 points which actually dictated as to whether the surgeon is going to decide whether he is going to go for an radical nephrectomy or an partial. First and foremost, as you said, is whether the mass is technically feasible or no. And there were a number of other reasons, but the interesting one was, of course, nephrometry score of more than 10. I'll come to that question when I'm going to ask Dr. Anup about it. And as you said very rightly, most of the open surgeries will be for those cases which are hilar and completely endophytic tumors. So the survey also completely agrees with your point of view. The next question goes to Professor Anup Kumar. The question is, how do you decide whether a patient is a partial nephrectomy candidate or a radical nephrectomy candidate? What are the parameters which are critical for your decision making? Say for instance that this is a 56 years old male with no comorbidity, and this is the mass, completely endophytic, I must say, and hilar mass. So how do you decide? What are the critical decision making points?
So in my practice, the indications for doing radical nephrectomy in a T1 and T2 we're talking about. T1B and T1A, I will go for partial always, except if I find that tumor is closely infiltration in the renal hilar vessels. One, it is infiltrating the pelvis significant part, or ureter is involved, or there is a significant lymph nodes in the hilar area, and of course then the thrombus will be T3 and beyond. So otherwise all the other patients will go for partial.
Do you do this routinely, renal, Padua, C index scoring? Do you practice this? And if yes, then do you think that there are any drawbacks which we have to look into in as far as these nephrometry scores go?
We use renal scoring more than the Padua scoring, and it does give us an idea that yes, we are going to face a technical challenge in this patient, and we are comfortable both lab and robotic. Only thing, if it's a central hilar tumor, I will go more towards the robotic. Complete endophytic, I will go more towards robotic. Rest all, I will go for lab.
It's a pointed question. Actually, what we feel at our center is that these scores do not include the toxic fat angle into these things. So there might be a score which is just 4, but if the patient is having an toxic fat, it becomes very difficult to assess from that particular
toxic
angle.
fat is a one parameter, you're right, but we have practically seen in very few patients. But yes, those patients, it was technically difficult, but still you can complete the procedure, whether it's lab or robotic. It will not change the outcome of the procedure.
Your points are very well taken. We'll come back to the thing later on. I would like to ask Professor Anand Kumar, who is having arguably the most experience as far as NSS is concerned. Sir, how do you track your outcomes as far as partial nephrectomies are concerned, particularly in terms of these 3 points? Functional outcome, do you do an renogram, you don't do an renogram? Perioperatively, what do you see? And most important, what is your follow-up, the way you follow up these patients, T1 and T2?
Yeah, the perioperative is the most important thing, is that is there any bleeding or not? Is there any urinary leak or not? Which are nowadays very rare. With the inner renography technique and early declamping, almost bleeding complication is taken care of. Urinary leak is also very rare. We have not encountered in last few years. And that long-term oncological outcome is the most important thing, and that you can only see. The first thing is your margins, which you get the report, type of the pathology, like what is the grade, any sarcomatoid feature, lymphovascular invasion, all these parameters, type of percentage of necrosis, all these parameters you will keep in mind while following the patient, and depending on that, the first follow up is either decided at 3 months and 6 months. If there is a poor risk factor, then it is at 3 months, otherwise at 6 months. We invariably follow the patient with the CT scan, and with the newer CT scan machines you can get a very good information. But if there is sometimes patient themselves are not very happy with the repeated CT scan, then we do offer them MRI, and then it is done at 6 months, 1 year and yearly outcome. And we have patient now who has recurred locally at 5 year and 6 year later also. So if you are following them at a longer period, you will see some recurrence, and we have also seen same patients in same kidney tumor developing at other part of the kidney. So long-term follow-up is very important, and that's how we follow up them.
Thank you very much, sir. I'll come back to all of you once I show you this case. So this was a case, if you go through the movie, this is an left-sided renal mass. So it's a lower polar mass, but the important thing is that the mass is not very well encapsulated. I'll jump to the thing over here. Like here, it starts here, and it's not a very encapsulated mass. So this was the reconstructed image, single artery. You can see it's an exophytic mass, but there is something that we make out that it's going to be something different after the excision. This was one more reconstructed image. So first of all, Dr. Yuvraj, would you go ahead with a partial nephrectomy? This is a T2 tumor because it's 7.5 centimeter tumor.
It's fine, but the remaining renal parenchyma is quite good enough and it is away from the blood vessels. We can do left heminephrectomy, lower pole. Still we can achieve negative margin.
So we also thought from the same point of view. We went ahead with an heminephrectomy. Grossly, when we opened up the specimen, because that is what we do, all of us do, that we opened up the specimen, we thought that the margins are clear, there was no problem. However, later on, as the histopathology came, it turned out to be that there was a tumor was extending into the renal sinus fat. So now I would like to ask all four of you as to if this happens, what should be our next line of management? Have we done a disservice to the patient? I think you can start.
No, I think it is, margin is negative, but it is in the sinus fat, right?
Yes.
It is fine. Even when it is in the small renal veins also, we do go away from that and we can do, and it is not a disservice at all. Still we can observe this patient. I don't think it makes any difference.
So, Anand Kumar sir?
Yeah, I think this patient needs close watch and follow up, and the decision was right.
So I did a small survey on this, in which this particular paper has come from Ann Arbor, Michigan, wherein they have done of course this is an retrospective analysis, and this analysis was quite a big analysis. A total of 1,955 patients were identified, out of which 95 had got upstaged. So this was a period of just a follow-up period of 38.2 months. So actually we should be looking at something which is beyond that, because the tumor stage has been put into T3, because naturally the follow-up outcome parameters are going to be something different. And interestingly, what they saw was the RFS as well as the CSS. So if we see that in those patients in which there was PT3 upstaging, the 3 and 5 years RFS was 81 and 58. Means there was and on the other side it was 86 and 75. So there was a significant difference. If you go just 2 years down the line, there was a significant difference as far as the RF, because my question was that if it comes out to be an T3A, and as we are going to do more and more complex tumors, it might be an T2 tumor. Are we doing a disservice because we don't have a follow-up as long as that?
Yeah, it's fine. It's a recurrence-free survival, but we still treat that, and the overall survival doesn't change at all.
No, the overall survival has also changed, as you can see here.
Okay.
The overall survival also changed, and more number of tumors are going to happen here.
Yeah.
In this way.
So my take is, in this patient, if you have kept this patient in follow-up, and when it is recurring and you take appropriate steps, then patient cancer-free survival will still be the same.
It's a local recurrence?
Yeah, local recurrence. It was the difference is the local recurrence. Professor Dogra was going to say something.
I'm glad you brought up this point, because many of us, we are sometimes practicing without really analyzing, and we practice what the other are practicing. I'm glad that you brought out this point. This is very pertinent. Involvement of the sinus fat, you are not considering as a bad sign or bad prognostic, but perinephric fat you consider that as a bad prognostic sign. Whenever I have seen patient, if the sinus fat is involved, please do not do a partial nephrectomy. You should offer a radical nephrectomy in those patients. Otherwise, what you are seeing, the local recurrence and even the metastasis are bound to happen in this type of patient. So, in my view, in my experience, what I have seen, which the literature doesn't say, if the sinus fat is involved, you should not consider these patients for nephron sparing surgery. This is all what I have to say.
Yeah, the Premnath, the question is not, this is question, the report came after that.
Yes, the clinical it was.
CT. If the pre-op you have seen it, then probably we have not considered it.
On CT scan, there are different signs you can make out. It's a loss of phase of the kidney. If you see the CT scan of this patient, sit with a radiologist who really know how to read the CT, there is a loss of, it's called the loss of the kidney.
No, I agree with sir that irregular tumors like this tends to have renal sinus involved.
Correct. So
Pre-operatively, if somebody says sinus fat is query involved, so should we go ahead and do a nephrectomy? Nephrectomy. But if it is post-operatively margin negative, if it is available, then we even in a positive margin we don't do it. So then negative margin generally we just observe them.
Arvind, your trial actually gives exactly what the renal tumor behaves. And renal tumor has got a long doubling time, and therefore at 3 years you didn't find, but 5 years you will find.
Yes.
Absolutely, it just gives you what we believed in the past. So now to go overboard and do a radical nephrectomy immediately is debatable. We do not know. But short of doing a very good follow-up, very astute and clear-cut follow-up, we tell the patient that this is the time, we are giving you observation, but anything which happens, he should go for a nephrectomy.
Because my question was from that angle, that if suppose it's a gross margin which is positive, we would advocate that it should be a completion nephrectomy.
On table, if you can find that.
Yeah, but then here, why not advise a radical nephrectomy, even though if it is in the follow-up?
Little be overkill. It will be overkill. Have a good follow-up, and maybe you can go at that time, because that time you might do a open surgery, fair enough. But
See,
you still not
this,
salvage.
Sorry. Renal cancer is one cancer which behavior is very, very unpredictable. I have seen patient operated, refined surgery, radical nephrectomy done, doing fine. Patient came to me after 29 years of follow-up with metastasis. Now, can you say at any stage of time that you have cured this patient? No. This is a one cancer in our urology where you cannot dogmatically say to a patient that I cured you. You can't say. So better to tell this patient that there is a positive margin, there is a chance to go ahead with the completion nephrectomy rather than keeping him in this limbo. Patient can sue you ethically, legally, medically.
Points well taken. Dr. Raghavan, anything?
No, if we explain to the patient that the recurrence rates are more and compare this, the survival is, you see the overall survival is 80% versus some
It
90.
was significantly different,
Yeah,
statistically
it is
different.
even in a but even then, I think majority of them will wanted to keep observation. Rarely patient will accept for a nephrectomy. And one thing, second thing, in the similar way, if I ask Arvind, if there is a one node which is enlarged, not many nodes, CT scan is normal, but frozen section, if I send it, it comes as positive, but tumor is partial nephrectomy possible. So should we do a partial nephrectomy or should we do a radical nephrectomy? So same question like T3A. You see, it is a one node positive, but tumor is amenable for partial nephrectomy. So is it, what is the opinion? Arvind and Malik can tell. Clear cut. Yeah.
However, now if you operate, do surgery and then it comes T3A, then we have all sorts of dilemma and this. Why is that? I don't understand. Just because we have committed.
No, because it amounts to one more surgery.
No, but why are we afraid of doing one more surgery when we know clearly that the indication is absolutely certain?
No. We'll give the option to the patient. If they agree, we are going to do.
The patient is wrong thing because you know that this is wrong option.
No.
Sir, I
because
still
you have shown the
believe,
figures.
see, we are
if it
confused.
was T3A pre-operatively, you would never have given option of partial. That everybody is agreeing. Now, just because you have done surgery, now you want to give option to the patient so that you are safe. Now, patient is deciding and decide. So you are confusing the patient.
No, one thing is
the survival rate is not that huge, and it is a retrospective analysis. We can't comment only
So these are all
based on that.
statistical jugglery.
It's very
but
difficult.
eventually we know that T3A requires radical nephrectomy, whether it is before or whether it report comes afterwards. It requires radical
majority of the times the positive margin which comes is in a small tumor for a partial nephrectomy, contiguous margin, it's fine. It's not a contiguous margin. It is a spread into the sinus with a margin per negativity.
So Malik sir, actually Dr. Mahesh Desai wanted to put in a word.
Yeah.
Dr. Desai, you're on. Sir, you're muted, sir. Sir, you're muted.
He's not muted.
No.
Yes, sir, please go ahead.
Can you hear me?
Yes, sir.
Okay. Arvind, that is a very good point you brought out. And I just want to share experience. I mean, Dr. Gill published 4 cases where there was a surgical margin positive or there was a little satellite nodule. And he went back and did a nephrectomy. And in 2 patients, they did not find the tumor. I think what panelists said that I think Anand Kumar said that we will observe this patient closely. The moment you detect a cancer, you go and act upon it. But it is the fact that even if you have a extracapsular spread or a nodule, the 5 year you are likely to develop a tumor again. So you have to play between the two. Immediate surgery or a little delayed surgery moment you see the tumor. That's it. Thank you. That was a very nice discussion.
Thank you, sir. So we'll take a last question. Otherwise,
Just want
yes.
to know if there is a doubt, should we err towards doing a partial or should we err towards doing a radical? Because these are cases where suppose we have a doubt, where should I err?
I personally I would err more towards an radical, Dr. Raghavan.
So it's very simple, sir. It's all about how centrality is the tumor. If the tumor is very central, where you think there is sinus fat involvement, or you feel that there is a nodule in the perinephric fat, then always err towards the radical. So the error is always towards the radical. But on the other hand, if it's anatomically feasible and it's a cortical tumor, where the size doesn't matter, even if it's a T2 tumor, but it's a cortical tumor, where you believe that you can give a negative margin both in the cortex as well as in the perinephric fat, then you go towards the partial nephrectomy. So the one point which was deeply discussed, here the question, as Sabnis sir rightly said, preoperatively we never anticipated, intraoperatively it was a R0 clearance, as in macroscopically clear margin. It is a microscopic deposit which is impossible to judge preoperatively. We may have to say if the face of the kidney is not there, etc., we can talk, but it is impossible to judge. Once a report like that comes, the international literature, including EU guidelines, clearly say it's only observation, because a sinus fat involvement or a perinephric fat involvement, if you believe that it is a cancer spread there are millions of cells which has already gone to the lung, liver, anywhere in the world. By just going and doing a nephrectomy, you are not going to make any difference to the overall outcome of the patient. What are you going to do for that? And as sir rightly said, why are we putting the blame on the patient? We stand up and say, buddy, we did the operation because we strongly believe it's an R0 clearance, and that's what we are. We'll observe you closely. When there is a problem in future, we deal with it. That's my approach.
Only one last comment.
I think we'll just, Dr. Anupkumar, just for last comment. You can take it and then we'll stop.
Yeah, positive lymph node, I err on side of nephrectomy.
So only just one last comment, like you asked, if you have a solitary kidney, there I will err towards partial. Except that, I will err, yeah, so that's something I want to summarize. Except that, I will err more towards radical nephrectomy.
So I'll just summarize the literature in just 2 minutes. Radical nephrectomy versus partial nephrectomy, T1A, T1B and T2. What does the literature say? There is only one very good level 1 evidence, EORTC phase 3, T1A tumor. This is the only level 1 evidence for comparative analysis of partial versus RN, and it goes in favor of partial. That is T1A, everybody agrees that it's partial. But as far as T1B and T2 go, there is relatively very weak evidence in favor of partial. There is no level 1 evidence which is robust enough. There is only one well conducted meta-analysis which you can say probably it's a level 1, which suggests longer estimated blood loss and post-op complications in this group with PN. So again it goes against favor of T1B and P2, and even the paper from Van Poppel also says the same thing. What about open versus lap versus robot for partial nephrectomy? They say very clearly that robot is superior to any other modality as far as this particular discussion goes. And what is the adequate technique as far as radical nephrectomy goes? So here the winner surprisingly goes for not surprisingly, but it goes for laparoscopy, that whenever you want to do an radical nephrectomy, the better approach would be an laparoscopic approach. Just the last two slides, what does this survey say? The survey that we were talking about, 87% of the respondents, and these were all Indian uro-oncologists, 87 of the respondents preferred partial nephrectomy for T1A mass, but as you see here, majority of them preferred T2. For T2, majority of them preferred an radical nephrectomy, while they were divided as far as the T1B goes. So the last line, the community survey suggests that the Indian uro-oncologists are following this preferred approach. All of them agree that T1A, it's robotic NSS, that is the preferred one. T1B, the jury is still out. Robot still may be the preferred approach. T2, radical nephrectomy, laparoscopy or robot, the jury is still out. Having said this, I stop my presentation. Thank you so much for your participation.
Well, thank you, sir, for that good talk on the management of localized kidney cancer. Now we come upon the king of all the debates, which is the clash of the titans. Robotic assisted renal transplant. Is it future of all kidney transplant? To defend is Dr. Anand Kumar, sir, and to negate is Dr. Ravindra Sabni, sir. May I call on stage the expert opinion by Dr. Pranjal Modi, sir, and Dr. S.K. Singh, sir.
Non-technical. Inspiring expert.
Okay. So at the
Good
outset,
afternoon to all of you. Good. I think end of this session, we can see how we can avoid the clash between the titans. Thank you,
okay.
sir.
Okay.
Anand Kumar.
You know, in IPL match, it was very difficult to defeat Gujarat Titan at the Gujarat Stadium. So at MPUH to defeat Sabnas is a uphill task. But anyway, let's face it. So the popularity of wheel is doomed. That was the New York Sun rendered their opinion when the bicycle was discovered. The questioning the application of proven technology wheel to a new field, new mode of transport. But we all know that now life is not possible without wheel. And in New York Times, when the car came, it said the prices will never be sufficiently low. Now even nano car was available in 1 lakh of rupees. And this is most interesting. I don't know how many of you know that when Dr. Kurt Sem did first lap appendicectomy in 1980, in his world, the medical world at the time reacted with the most violent hostility and opposition he had experienced during his entire career. Both surgeons and gynecologists were angry with me. They virtually stoned me. All my initial attempt to publish a report of laparoscopic appendicectomy were rejected with the comment that such a nonsense does not and will never become in general surgery. Sem was summoned from the operating room and had to undergo a computed tomography investigation of his skull in order to prove that he was in good health. So questioning the man in his method who is trying to do something different is always questioned. Like at this, from same land, Mahatma Gandhi has said, first they ignore you, then they laugh at you, and then they fight you, but finally you will win and they will follow you. So my disclosure is, I do both open and robotic renal transplant regularly. Robotic kidney transplant, why not? Is this idea not old enough to embrace? Is it technically inferior to open technique? Are the results not reproducible? Are there any limitation in applicability? Is the cost too high? Or is it just our inertia to accept and welcome a life-changing invention into our everyday practice? The open kidney transplant we all know is standard of care. Robotic transplant was first done in 2002, but it was not exactly the whole procedure. But and laparoscopic was done in 2009. And we all know laparoscopic is very difficult. Only people gifted like Pranjal Modi could do it. But the robotic assisted became popular. First it was introduced in Chicago in 2007, and then 2012 it was reinvented by Dr. Mani Menon and Rajesh Alawat. We all know these are the various advantages, I don't have to say, but two things are very important. Wound infection is not there, and obese patient, female patient is really a very good procedures. And the robotic surgery in some situation like in obese patient made transplant easy. There is a various way of doing it. And you know that open kidney transplant, how big is the incision, and robotic, how small is the incision. And you can put the graft without any added cost by phalansteal incision. And you can see this is the immediately after the patient is being discharged, and 3 months later you can hardly see where is the scar. Here is the wife has given to the husband, and wife was complaining that why my scar is bigger than his scar. And you know, we have seen especially in robotic open operation, sometimes wound infection is a very hostile situation, lymphocyte formation, especially 50% of our patients are diabetic and some of them are obese, and in diabetic obese patient, wound infection to my mind is 80 to 90%. So this was a very nice paper, whether it is a dream or it's a future, and it did say that it is the future and it is not the dream, and especially in obese patient it is a future. And this is a gynecologist from the Fiji, and after the operation she wrote a very nice letter and she was very pleased about the outcome. And we all know if you do have to do this open operation, what would have been your outcome. And it's not that it is done by few people, there's multiple papers have published, I don't have time to read them, but it all says that outcome is not inferior to the open operation. This is our which we published 2-3 years back, and also said that there is a learning curve, but in long term after 1 month results are more or less same. You do take extra time to do it, but we all discussed with the time you will improve. That's a paper. Another paper we have published, it shows that around 25 cases you overcome your learning curve and start producing good results. And it's not that you can do it simple case. Now you can do the multiple vessels. You can do the right side. Even right side doing the open operation is so difficult, but the robot it is not difficult because kidney is lying there and you don't have to do any extra effort, and you can nicely suture them. You can do it at the second operation. You can do it in the left side. You can put it at the higher up. So all these procedures we have done it. And in the obese patient, this is a very nice paper which has analyzed the result of people who have BMI over 40. And I just want to say that in this paper, open operation patient have more complication, including the thrombosis of the renal vessel than the robotic operations. So the robotic, and in India, especially our female patients, obese female, we have a central obesity. Most of the obesity in the abdomen and fat is hanging, and if we have to put the kidney in that situation is not an easy one. And obesity in Asia is very different than obesity because in there that they have longer, in West their length is high, even though their BMI is also high, but in obese, central obesity causes this problem. I just like to say this patient was from Bangkok, Myanmar, he went to Singapore and Bangkok, both refused transplant. They said you have to lose the weight and then come back to us. When he came to us, he first told me, don't tell me to go back and lose the weight. If you want to do it, just tell me whether you'll do it or not. So I did his operation, and this was my 7th or 8th case. I took almost 70 minutes to do it. And the post-operative he was on ventilator, he developed chest infection and all that. Finally recovered and went with the, 4 years later his creatinine is around 2. And he is always moving with the BiPAP. So such patient doing open operation would have been really very difficult. So these are the many obese patients, especially they have come internationally, but they all are very happy. And we have published our results in pediatric transplantation also. And this the girl which is on the left side, she refused to undergo operation till I convinced him that I'll give a very small incision which will not be seen after few years. Only then she agreed to undergo operation. So there are many questions. Are kidney can rotate on the pedicle? No, you can fix it extraperitoneally. Is this prolonged ILS, minimal ILS? ERAS protocol helps. Prolonged revolve ischemia time, as you improve and you overcome learning curve, the time comes out. Nowadays we take around 35 minutes and most of the time the urine is start coming immediately after reperfusion. You can do second transplant. Is the graft biopsy difficult? No, you have put the kidney on extraperitoneal space, biopsy is no problem. The rough handling of the graft vessels, if you are suturing carefully, we hardly catch the vessel at any time, and with the proper suturing and retraction you can do it with a very nice way. Is it Indian scenario? Everly's cost is always talked, and I know, even I tell my patient, if you have a money problem, don't go for robot. You have to have money for your immunosuppression. Those who can afford should come for robotic transplant. But you know that we have now many people who have enough money to undergo surgery. So affordability is not a serious problem, and you know that India is developing, and there are more than 100 unicorns in last financial year. And you can see that where the wealth is, most of the billionaire is now in the Asian countries. So more and more robots are being placed in the around India, and insurance is also coming, which is supporting it. So you can see many robots are installed. So I would like to summarize it that are we different from the Western countries? Or we don't want good cosmesis, we don't want less pain, or we don't want less morbidity? Can't we afford it? Or the robots are not available? So all over the world the patient wants the best possible care at affordable prices with no pain, and that can be provided by us. But that's what the Stargell said, you can't stop the progress, progress will run over you. And when the road is treacherous, it is safer to riding a better and more advanced vehicle. Yes, there is a definitely role for, and even my colleague will like to have the minimally invasive surgery. Thank you.
Thank you very much. Well, this debate is about the robotic assisted renal transplant, whether it is future for all renal transplant surgeries or not. So that's the question. And I strongly feel that it is not the future for all kidney transplants at all. That is very, very clear. Anand Kumar brought out a lot of points. I'm going to take all those points one by one. First of all, he said that it is difficult to defeat the Gujarat people in Gujarat. But actually my position is a little bit difficult, because here is a robotic conference. Here are all robotic surgeons which are present, and I am talking against the robot. So my position is actually critical than yours. So anyway, but still I am going to defend, because I know that these are all robotic surgeons. They are all very creamy layer of the Urology Society, and whatever confusion he has created, I am sure they will clarify. I will clarify all that confusion within no time. Anand Kumar showed a lot of pictures of the ghastly wound infection, some grossly obese patients, and some evidence of some papers and this, that. That is all half true. There are many things actually in statistics that you don't have to tell anything. You just say a little bit something to just mislead the people, but actually what important thing is not told at all. And I'm going to tell all those important things which he has actually told very halfway. First and foremost, people talk that this is a new procedure. This is not a new procedure at all. He also said that in this, that it was invented in 2002. This is Journal of Urology, 2002. It is 20 years now. Now, after 20 years of robotic surgery, of transplant, if you still consider, is it a new procedure? Just because very few people are doing, just because it is not done sparingly everywhere, because people know that there is no future in that. Still, even after 20 years, do you consider that it's a new procedure? Mini-Perk also was invented in year 2000. Now, do we consider Mini-Perk as new procedure? No, it is definitely not. Just because it is new procedure, robotics, and a new standard, new way of this future, or where the future is going to come? This 20 years are already over. Where is the future? You are searching future. So it is definitely not a new thing. It is definitely a time, a lot of time has passed. And if you see the literature search, he said there are lots of papers available. Now this is a truthful literature search. You can also check just now also in your mobile. If you put this as a search from year 2002 to 2022, in last 20 years, how many papers are published all over world in PubMed? Only 66. So is that the procedure which is adopted by everyone? You have to decide yourself. Now out of those 66 papers which are published in literature, this is a split up. It started with 2002, then 2.1, 2.2, this 11.7, this, even after 20 years, there are very, very few publications in the literature. Some of them are contributed by Anand Kumar only, but there are no other literature. Nobody is publishing anything. So in this, if you do transplant, what are the priorities when a person comes to you for the transplant? The first and foremost thing, we are not talking of radical prostatectomy and this, that. So kidney transplant is a very specialized procedure. Graft function is the top priority. Early and late complications should be minimized as a second priority. Then you have the less pain and faster recovery. Cosmos is the least on the priority. Nobody is bothered about this, what is a scar. They are all interested in how is kidney going to function. And of course, cost is the consideration. Obviously, it is there. But they have already exhausted all the money. On top of that, you want to put robot and exhaust further money, squeeze them further. The problem in transplant, in robotic transplant, there are multiple. He has not told a truthful thing. He has shown only ghastly wound infection. But you see, the kidney is lying in the transperitoneal. This is basically a retroperitoneal surgery which you want to go through the peritoneum, go into the retroperitoneum. So retroperitoneal procedure which is done through the peritoneum with no advantages at all. It is not like a native kidney where you have a space and other things. It is not like that. So even after this, the whole kidney lies into pelvic peritoneal cavity. Once anastomy is done, it is not possible to move the kidney. It becomes turgid, and all of us, you know, it's very difficult to move the kidney, although you can say that you move this kidney and this, that. Then you create a flap and you tug it and make it retroperitoneal. It is a complete eyewash. I have seen all the videos and other things. Putting this, taking the sutures, Pranjal only said in the morning that if you take too tight sutures and this, there is a compression, the output will drop and this, that. So it is an eyewash to make it retroperitoneal. It remains in the kidney. We have to be truthful and we have to accept it. The other problem which is highlighted all throughout in the morning is pneumoperitoneum. Now you have to put the pressure of only 12, 15 sometimes, no, make it 6, 12, 1. When you release the clamp, make it 0. Now 0 what you will see. So pneumoperitoneum definitely has a problem. And this problem, kidney is not immune to this, graft kidney is not immune to this problem. And what they have concluded that even though it may not be clinically significant and it is not seen, there is definitely injury, and these are all denervated kidneys. The injury is not getting cured completely. Engal and all these biomarkers definitely suggest that there is a kidney injury, and in graft kidney, unlike the partial nephrectomy or any other things, each and every nephron has a value. You can't have such injuries and say, no, clinically it was all right, it's okay. That's not acceptable in the kidney transplant. The other thing is position. When you do transplant, you have to give extreme Trendelenburg position. You know that pelvic vein pressure, abdominal pressure, they are all getting modified completely. Anesthetists are not happy with respiratory cardiac this because all ESRD and very, very compromised patient, their chest is a problem. Anand Kumar had to put the patient on ventilator with robotic transplant. Denervated kidney has exaggerated response compared to the in situ kidney, and therefore all this response and everything gets exaggerated with this because of this extreme position. Ischemia, there are lots of things talked about ischemia. Same as we had discussions about T3A. If you do robotic, if you get post-op, no, nothing, observation. But if you do pre-op, no, remove everything. Now, same way, Ischemia, no, because we are doing robotic, everything is fine, it's okay. But we know that once you have a ischemia, it is extremely important. This is a fact which we have studied for last several years. I mean, 50 years we know that what happens with ischemia, warm ischemia, and whatever you do, Pranjal was quite right that whatever you do, the cold ischemia is not possible in transplant. It is at the atmosphere, it is at the 37-degree temperature, and therefore cold ischemia is not possible. Now whether creatinine is same or not, it is different, but we know in our own mind that if you have prolonged ischemia and we say that even partial nephrectomy, you clamp it 25 minutes, it is gone. There are irreversible things which are going to happen. No, but we have seen that doesn't happen in transplant. No, it's okay. If you want to have that false sense of security, it's a different thing. But ischemia does matter, and ischemia is the key factor in transplant, whether it is robotic or whether it is open. And therefore, value of cold ischemia is extremely valuable. Kidney is exposed to 37 degrees centigrade. All attempts to maintain cold ischemia in surrounding have failed, and therefore there is always a pressure to finish the surgery, and therefore you do all in situ bench preparation and anastomosis and other things. But there is always a learning. Everybody has said there is a learning curve. Now what happens to those kidneys when you are learning? Now is it acceptable that learning curve it is okay, and during that period, no, that's all right. Those kidneys perfectly okay, but later on it will be all right. I think that's not right. So it is a procedure which has a problem. Every time you suggest, every time you say that it is non-inferior, but once you do procedure, it has to have some superiority, not just because it is non-inferior, so it is great and it is acceptable. That's not right. So actually what is the difference? Now this is a recently published exactly the discussion what we are going to have. The robotic versus open kidney transplant meta-analysis 2020. What they have said that there are only 6 randomized trials which are published with these many patients, and what they have found that if you see the pooled results show that of the received the robotic kidney transplant patient had higher rewarming time. This is the meta-analysis of all the randomized which are taken. They have higher rewarming time, and they had higher total ischemia time, and there were low incidence of surgical site infection. That definitely is there. There is no question that there is a less surgical site infection. So eventually, if you see this scar, this sort of a scar, this is all right, that you have a bigger scar and you have financial scar. But what is the benefit? Is it that only scar which is good is to be accepted? The lower incidence of wound infection is to be accepted? Pain score maybe a little less is acceptable? Now, all these benefits which are there in renal robotic transplant, they are all theoretical. In kidney transplant, these are not priority at all. The priority is completely different. Yes, there is definitely a role to play. Which are those patients? As you said that those obese patients, definitely yes, there is a role to play. Obese patient more than 30 BMI, and especially in those obese patients, if you have a right side kidney with a small vein, there is a role to play in that but otherwise apart from that, there is no other role to play. Quite often we tend to do a procedure just because we want to do it. Now, there is no point in doing the procedure for a simple task. Now, drinking this soup from this, do you need robot for that? And that too remotely controlled. Now, open transplant, kidney transplant is so simple, just open, everything is in front of you. You don't need 10x and 3D pictures and this, that. You just need a simple 3x magnification. It is more than enough. Why you want all this jugglery to be done? That I will remotely control, dock the robot, dock the this, put this. And then sometimes the Jagtap said in the lecture about the problems of robot, and there are malfunctioning of robots, and these malfunctionings can occur in a transplant patient when the life is at stake. It is not like any other, say, a prostate or partial nephrectomy where life is at stake. Even the minor point or minor error is quite often the patients who come for the transplant, it is their last chance, first and the last chance. You can't take a chance in this. And suddenly, suppose something happens with the malfunctioning of robot, who is responsible? There is nothing you can do about it. This is what, this can happen. This is a reality, it can happen. Well, at the end, I just want to say about 1 minute about this history. We all know Muhammad Tughlaq. He was a king and Delhi was the capital. Suddenly he thought, no, I think this is not proper. We have to take this capital to Daulatabad. It is a centrally positioned, this and everything is fine. Everybody advised, no, it is not required. It is like open kidney transplant. Everything is going on smoothly, properly. But suddenly he thought that, no, I think this is not proper. We have to go for this robotic kidney transplant. And then the whole chaos, the capital went to Daulatabad. There was a chaos, absolutely all sorts of problems. 3 years later, he realized the mistake and the capital went to Delhi. Probably Anand Kumar, after 1 year more, he will realize the mistake and next time he will defend the open kidney transplant. Well, at the end, I just want to say the life is really simple, but we insist on making it complicated. And this is what my advice is, that don't take it the other way, KISS is different. That keep it short and simple. Open transplant is the future and it will remain the future. Thank you very much.
Dr. Savnees, please be seated here. Now you could see now in this session 5, just observe. I just was making an observation. Now, in other 2 sessions, Dr. Manohar, the expert opinion only one. Now again mini debate between docking, front docking and side docking. Only one expert judge. Here you will see within the 2 titan class there are 2 expert opinions. So now see why. And I know we don't want to get a squeeze between the 2 titans. Maybe we can ask him for rebuttal, please. Because we are also afraid maybe that you will ask, I have not given you chance, we will get crushed between the 2. So maybe that you can take a minute or so. And now for the first time in this session we have asked the speaker to be seated because they are titans.
Now, I didn't prepare for rebuttal, but few points I would like to say is that what he said that kidney is not into the extraperitoneal space. I can assure you, once we put the flap, kidney is absolutely in extraperitoneal space, and in the follow-up all that, because these patients undergo multiple ultrasounds and kidney biopsy and everything, there is no problem. It is in, so I assure you it is in extraperitoneal space. Second thing, every operation has a learning curve. When anybody learns the even open transplant, it takes longer time. When you are teaching your resident, they are taking longer time. So even if anything you will evolve, you will take longer time. But now I can tell you, when it's not that there are many people who have watched and seen, and you will see again when will be doing our Surgicon in July, that it doesn't take much time. And urine output, even most of our patients creatinine is at day 3 is normal. And you know, my nephrologist still had a very resistance. He doesn't give patient for this. All patient is mine. But now they are watching. And now if any patient wants, they don't say anything. Because they have seen in due course of time that patients do very well. Second thing is that, this time is over? Okay. Okay, I think there was one more point I was just going to say that. Now that time will tell whether like Andhra Pradesh has also chosen a new capital, whether it will be good or not, time will tell.
Well, there is nothing much in rebuttal because there are no new points which are brought out. The only thing I want to say that the whole presentation was robotic kidney transplant. When you present and when he presented, it was all about the no inferiority. How long you are going to have no inferiority for robotic transplant? Okay, we are retroperitoneal accepted. Okay, yes. Okay, you put a flap, big flap and put it retroperitoneal. All right. But everything is only to show that there is no inferiority. So when you have a procedure which is of a high stake procedure, then you have to have some superiority over the existing procedure. Then it is all right to convince the patient that yes, it is to be adopted. Saying that only less scar and the wound infection, as such, how many patients we face wound infection problem in transplant, even if they are diabetic? Hardly 1 or 2 patients in a year. So wound infection is not a major problem. So unless and until you have a superiority over the existing procedure, procedure will not get accepted, and that's the reason why there are very few, even amongst the robotic surgeons who are here, hardly few people are doing. If you see, separate them out who are those who are doing robotic transplant, you will find only few people who are doing robotic transplant simply because there is no superiority. And I think that is the point which we have to ponder upon in a scientific discussion like this. That's the only point I want to prove. That's it. Thank you.
Just let me declare first. As far as Patel is concerned, it's both the speakers have done very well. I'm a bit biased because I have done both open kidney transplant as well as the robotic kidney transplant. So I'll put a few points, pro and con, just to try to be as neutral as possible. First point is Hasnack done first robotic kidney transplant in 2002 in France. And what he did was, like, he thought about it. That was a S type of robot, not very nice vision, not very nice intuitive. So it was open 7-8 centimeter incision and exposed the iliac vessels by open surgery. And then just he has an assistant on the robotic side. His intention was to demonstrate the feasibility. And he could show it 56 or 57 minutes anastomotic time when the open transplant, it was open transplant, but with the help of a robot, and it was done. So that is the reason why it was not very attractive to most of the people, that it's an extra, the robot has been used just for the anastomosis, that's all which we can do with the loop and blah blah blah. So then it was not picked up. Till in 2010, the group of the Chicago group has thought about morbidly obese patient, where there is it's in fact in a American Transplant Association's guideline, it is a relative contraindication to do the transplant because they have extraordinary morbidity, both in terms of graft outcome as well as the surgical procedure complications. And they have performed. So they didn't do the extreme Trendelenburg position, which we are following Manon's thinking about robotic prostatectomy. They put the patient in a lateral position. So they don't go in extreme Trendelenburg position, and docking is done from the side. Reason is extreme Trendelenburg position can give rise to the edema to the brain, and we do not know blah blah. And they also put the incision paraumbilical gel point, and even the one pot through one of the arm goes through that gel point also initially. And then it's hand assisted to some extent to minimize the wound related complication in an obese recipient. And they found that there are published data now, 10 years published data there in American Journal of Transplantation, that it's non-inferior. Outcome are not inferior to the other compared to the other patient. But then one of the relative contraindication or a contraindication for transplant is gone because of robot. So that is the major advantage they have advocated, and they have proven now that the robotic kidney transplant for obese recipient should be considered. As far as the non-obese patients are concerned, yes, it is yet to be believed, but the Europeans are trying to push it very hard. Italians have done the robotic pancreas, combined kidney pancreas transplant. I have done one combined kidney pancreas transplant at my place also. So a midline incision, we don't talk in a urology meeting like that, but when a dual organ are to be transplanted, you can do it through the single incision. So that is another advantage of a robotic kidney transplant, where you put a left kidney kidney in a left iliac fossa and pancreas in a right iliac fossa. But the indications are few, and especially in our country, it has not been picked up yet as far as the pancreas transplant is concerned. About the anastomotic time and all other advancement in the technical skill are concerned, only the volume and the time will tell. I remember very clearly the rebuttal done among the three giants in urology. One is, I think, Dr. Manon, who was trying to advocate about the robotic radical prostatectomy. Laparoscopic was by Gill, and I think open surgery by Patrick Walsh in 2001 AUA. Patrick was, everybody then he was advocating open surgery. 2001 or 2, maybe. And then Gill had its own data and his own skill, and everybody, he was advocating laparoscopy, and finally the robot was new for radical prostatectomy. 1999 onward, the robotic radical prostatectomy has started. And the one line which Dr. Menon lastly told, Menon is a student of Dr. Walsh, and Menon told one line at the end, train has already left. That's all. So here it is the time, technology, and you need to train yourself. PCNL has come, open nephrectomy is gone practically, the pylolithotomy. Connected robots are there and you can do the so many technological advances are happening, and probably small incision. We have already shown one advantage, I have to yet to publish it, is a transvaginal insertion of the kidney. So there is no incision. And believe me, the outcome of the transplant after 20, 30, maybe 40 some cases, or maybe 50 some cases are fantastic. You will not go backward to do the open kidney transplant after some point of time. That is for sure. But yes, there is a long learning curve. There are problems. Right kidney is not that easy to do transplant also, but you have to develop the innovations in technique. You start using and once you apply the various modifications, probably you can get better. So there is a learning curve, but I think ultimately the time only will tell us that there are many procedures which are vanished also after a new development, but I think it's the time which will tell us that which is the best. Right now, both procedures are having very strong standing at its own place.
Yeah, last point, Dr. Anis.
So what I would like to say that the learning curve here is very different as compared to any other urological procedure, because it's a question of a live related kidney. You can take 12 hours for doing, pyeloplasty, prostate, or many other procedures, but here during the learning curve, I mean, that is one of the major things. So probably you need mentors for at least some 10, 20 cases like that. So that way also it is different than others.
One thing I will tell is not the debate, is that especially in India, Indian ladies wear saris, and because of that reason some of the patients inquired and forced their family to pay extra and go for robotic, because with financial incision, no incision is seen. So I was little surprised when the husband came, no, she is saying that he has to go, even have money problem, can you cut down the cost and all that. So we did help them in this thing. So, but I was surprised that female coming and asking for that, because they wear sari and it is, this car is not seen. So
yeah, thank you both, you sir, Dr. Anand Kumar, my teacher, and Dr. Savnis, my friend. They have put their point very nicely and then kept you again attentive. Thank you very much all for your patience and your attention. Thank you all.
Well, thank you sir for this wonderful clash of the titans.
By technical expert Dr. Modi, and I am a non-technical expert for kidney transplant.
Well, coming on to the next important aspect of the conference, which is Kokila Dhirubhai Ambani Hospital Best Video Prize. I'll tell you some guidelines for this contest. It's a prize contest. 6 videos were selected based on the marking system by the experts. The candidates will have 8 minutes to present, followed by 2 minutes for question and answer. The contest will be judged by experts by an electronic method based on style of presentation, content, literature support, time management, and question and answer. 3 winners would be selected and they would be declared tonight at the dinner gala. The prize would be in the form of waiver for next RUFCON, registration, stay, travel, amounting to rupees 25,000 for the first prize, 20,000 for the second prize, and 15,000 for the third prize. May I ask all the 6 presenters to come ahead and have a seat over here. And I would like to welcome the moderators for this session, Dr. Keshamurthy R, Dr. Lakshman Prabhu, and Dr. Santosh Kumar to chair the session. May I please welcome all the 6 presenters to come ahead so that we can save on the time.
So we start with this Kokila Ben Dhirubhai Ambani Hospital Best Video Prize. Can I call upon the first presentation, robotic assisted left-sided renal allograft transplant, a stepwise approach, Dr. Ritesh Goyal from Max, New Delhi.
Okay.
Dr. Ritesh.
Good evening, respected faculties and eminent urologists from India. After a very much heated discussion on robotic renal allograft transplant, I have a very peculiar video to show, that is of left-sided renal transplant done robotically. Usually we do renal transplant on the right side. This was the first time that we had performed it on the left side. So it had some technical difficulties which we'll see in this video. Coming to brief history, this patient was a 45-year-old male patient, had second transplant. First transplant was done in 2014 and had graft failure in 2020. Donor was mother. Present donor was wife, ABO compatible transplant, and side of the donation was left. There was single artery, single vein. To start with, the first step is to incise the overlying peritoneum, overlying the external iliac vessels. This is done till you identify the ureter proximally and distally till the level of iliac bone. Next step is to dissect all the fibrofatty tissue around the vessels and dissect them circumferentially. So first we do the artery, we dissect it circumferentially. Next step is to dissect the vein circumferentially. This we check the adequacy of the length for adequate anastomosis. The next step is to create a flap to accommodate the kidney and to retroperitonize the kidney after the surgery. This is how the flap is created. The extent of the flap is laterally and proximally it is divided on the estimation of the likelihood that it might accommodate the kidney. The third step is to create a site for anastomosis of the ureter. Posterolateral oblique incision is created and deepened till the level of bladder mucosa. Bladder mucosa is not incised. The next step is when the kidney is inserted after the phalansteal incision from the lower phalansteal incision of around 5 centimeters. The kidney is wrapped in a ice sheath, and only the vein and artery, their small hole is made through which the vein and artery are brought out. The next step is to clamp the renal vein. A small venotomy is done using robotic port scissor, and the length of venotomy is equivalent to the width of the renal vein. The after venotomy is adequate. The next step is to flush it with hep saline to remove all the blood and any clotting material. This is a novel technique to perform the suture. Herein we take double-sided suture. The cortex comes usually in a single side. We take double-sided and knot it in between to save the time in knotting process. This is a novel technique and is under publication. This starts with taking a bite from the distalmost edge of the external iliac vein as well as the renal vein. First, the posterior wall is completed in the continuous manner in continuous watertight sutures. This is continued till the proximal end. Then the anterior, the other end of the suture is continued as an anterior layer, again done in continuous manner in watertight continuous sutures. Now before tying the final knot, a hep saline infusion is done to check for any leak, also to remove any air bubble pocket. Now final knot is taken. This is how, because one sider was already knotted, so we had saved some warm ischemia time by already using a pre-knotted suture. Now next the graft renal vein is clamped, and the clamps on the external iliac vein are removed, and those two clamps are applied on the external iliac artery. A small arteriotomy is made using Pott's scissor. Again, this hep saline flush is done to remove all the blood material. Herein, the graft renal artery is spatulated at the distal end, and suture technique follows the same pattern as that of renal vein. Again, we use a knotted suture at the one end. This is to provide traction. While on one hand we can pull the suture, on the other hand it is already knotted. So there will no chance of any loose suture. So once this posterior layer is done, the anterior layer is completed. This suture technique has been modified. The previously available suture techniques are of 4-knot suture, which we have reduced to 3 knots, and this is under publication. Again, same step, before tying the final suture, a HEP saline flush is done to see for any leak and to remove any air pocket. The clamps are removed, and you can see the perfusion of the kidney. You can see there is no active bleed. A small surgicel is placed around it. Now the jacket over the kidney is removed, and any superficial capsular bleeding vessels are cauterized. This is how we place the kidney in retroperitoneally under the peritoneum flap. As you can see, the kidney gets covered entirely. Next, the bladder is opened up, and standard modified Leach-Gregor ureterocystotomy is done. The care is taken not to touch the mucosa of the bladder of the ureter. This is after completing one layer, the stent is placed. We use a 6 French 16 centimeter stent for our transplant. The second layer is completed in a continuous watertight suture. The detrosography is done overlying the anastomosis. As you can see, the procedure is beautiful as well as it is neat and clean, and one can say and the anastomosis time in this was around 42 minutes. This has been standardized and we are reducing it further. Thank you.
Thank you, Doctor. Can you tell me whether you found any technical difference between the right and the left side that you're presenting it? Because transplants are being done for now decades.
Yes, sir. So first of all, being a right dominant surgeon, we are usually more accustomed to placing the kidney on the right side, and that too the dominant arm is towards the vessel, but herein the dominant arm was away from the vessel and the kidney was lying in front of the vessels. We had a lot of technical issues reaching up to the level of the vessel. So in that case, we had actually placed a fourth arm, below down, to properly assess the vessels. Also, being a left kidney, in this scenario, it actually helped having a left donor in this case, because the orientation was favorable.
Any questions from the house? Okay, thank you.
Thank you.
Can I call Dr. Likiteshwar for his next paper on partial nephrectomy with renal vein thrombectomy?
Yes. Good afternoon, respected chairpersons and all the delegates. Good afternoon. I am going to present a video on the robotic partial nephrectomy with renal vein thrombectomy in a solitary functioning kidney. Venous extension is seen in about 4 to 10% cases of renal cell carcinoma. The recent EAU guidelines state that partial nephrectomy can be performed in such cases for functional benefits and if technically feasible. But a more aggressive approach in form of radical nephrectomy with tumor thrombectomy is widely considered to be the gold standard surgery, as performing a partial nephrectomy in such cases can be technically demanding and so should be only considered when absolutely indicated, like in cases of bilateral diseases or a patient with CKD, or like in our case, solitary functioning kidney. Our case is a 73 years old female with ECOG status 3 and a fairly obese with a BMI of 36. She's a known hypertensive and diabetic, and she's been diagnosed with hypothyroidism and myasthenia gravis 14 years back. She previously underwent left radical nephrectomy for renal cell carcinoma in 2009 in our hospital, and on routine follow-up, she was diagnosed with right renal mass. She has a previous surgical history of hysterectomy in 24 years back. So CT urography showed a 6 centimeter right lower polar mass. There were 2 renal veins and an early branching of the right renal artery. The pre-op images didn't have any discernible venous extension of the renal tumor. This CT scan was done 14 days before the surgery. So plan for robotic partial nephrectomy was done, and the port positions, we placed 3 robotic ports and 2 assistant ports. After mobilization of the colon and the duodenum, the hilum is being dissected. We dissect the hilum by creation of 2 windows, that is one window below the hilum and one above it. This helps us in placing in en masse clamps if in emergency in later on surgery. So after dissection of the hilum, the gerotas is incised and the defatting of the kidney is done for better delineation of the tumor. Here you can see the 2 renal veins, and both the branches of the renal artery are being dissected. Considering the single functioning status of the kidney, we selectively clamped the lower polar artery. The intra-op ultrasound showed the tumor was extending with 2 horns proximally. So we took circumscribing incision is being given surrounding the tumor. The incision is given a bit more proximally considering the upward extent of the tumor. The arms of the bipolar are used for retraction of the margins, and the scissor is used for blunt dissection and sharp cutting. Here you can see this is the lateral horn of the tumor extension. We tried to completely dissect off the lateral horn of the tumor, but it was extending quite proximally and we couldn't get up to the upper extent of the tumor with a fear of causing tumor breakage with further mobilization. So we took another donut of normal parenchyma surrounding the tumor extension. This helps us in providing better access to the upper extent of the tumor, and also helps in maintaining the oncological safety. Because of continuous ooze from the parenchymal margin, we also clamp the upper renal artery. With careful dissection, we could dissect off the lateral horn of the tumor, which was slightly protruding into the segmental vein here. Then the medial horn of the tumor was dissected, but to our surprise, we found that it was also extending into the segmental vein. The segmental vein was incised, and the tumor thrombus is being dissected off the walls of the segmental vein. But it was extending quite deep, quite possibly up to the renal vein confluence. So we clamped the renal vein too, and we took an extra parenchymal margin medially, which will help us reach the hilum if necessary. With this incision, we could completely dissect off the medial horn of the tumor without any violation of the tumor. Here you can see the margin of the tumor is completely smooth, and the rest of the tumor is being dissected off. The inner rhinography was done with 30 Vicryl. In an interrupted fashion. The outer rhinography was done with number 1 V-lock by a sliding clip technique. After obtaining the hemostasis and declamping the renal vein, we saw that there was a tumor emboli in the renal vein. So the renal vein was incised and we could completely remove the tumor emboli from this incision. And was closed with 30 silk rescue stitch. Because the patient had 2 renal veins, we also could clip off the lower venal vein for added precaution. The surgery was completed with a console time of 128 minutes with a warm ischema time of 28 minutes. There was 400 ml blood loss. Postoperatively, 1 blood transfusion was given. The post-op period was uneventful with no drop in serum creatinine. The post-op color Doppler was normal, which is done as a routine in on partial nephrectomy in our institute. The drain was removed on post-op day 3 and patient was discharged on post-op day 4. The biopsy showed a clear cell carcinoma with clear margins. With 3 years, we've been following up for the past 3 years. She doesn't have any recurrence and we're maintaining with an EGFR of 68 ml. So, even with adequate preoperative imaging, intraop surprises happen. Especially when you see such tumor extensions, you should have an eye for the segmental vein extension. Don't be afraid from taking extra parenchymal margin, as oncological safety is of most important to us. And if possible, dissect the segmental vein and clip it. So conclude, partial nephrectomy can be done in such selective cases with reasonable success. Thank you.
Can you tell me, you had done the intra-op ultrasound,
yes,
and that would have told you at the depth,
yes, sir,
how much was the tumor. So
yes,
usually the intra-op ultrasound will help you,
yes,
to
sir,
make your cortical incision, keeping in view the depth deep down, not on the surface.
Right, sir.
So it helps in exophytic plus endophytic tumors,
Right,
or
sir,
fully endophytic tumors. So why did you have to make 3 incisions?
So first thing was that, like you said, sir, in this case, Doppler would have helped us in actually identifying the tumor extension into the vein actually, but with only ultrasound, we couldn't exactly understand the extension into the renal vein. We could only see the upper extension to it, that it is extending quite proximally. So it was a learning experience actually.
But pre-op, there was no venous
No, sir.
extension.
Actually, pre-op, it was in just 2 weeks before it. We couldn't see it actually.
When you did the intra-op ultrasound, the intra-op ultrasound did not pick up the renal vein thrombus?
No, sir. We couldn't understand it.
The other thing is, your literature review, you said that there's meta-analysis showing in
Right,
partial nephrectomy renal vein. So what is the level of evidence of that meta-analysis and how many cases there were?
Actually, in that, sir, there were 1,200 cases, in which there were 820 cases in the radical nephrectomy arm and 230 cases in the partial nephrectomy arm. And they have not done any propensity matching or anything or compared it. They took about 6. There were papers.
Level of evidence would have been 4 or 3 then.
Yes.
Okay. Thank you.
Right. Thank you, sir.
So very challenging case. Congratulations. Couple of things. So what sir asked you earlier, 2 things. One was you did the sonography,
yes,
after you clamped the artery.
Yes.
And secondly, I didn't see any scoring which was done. So I don't know how did you get the while doing the ultrasound. You didn't do any
after
scoring.
ultrasound, we generally don't do any scoring, sir. Actually.
So that's why probably you had to go on cutting the extra margins. Is that what had happened?
I wouldn't.
Because if you do scoring while doing the ultrasound, you know where exactly you want to go. So probably that was the missing point. I'm just asking.
It is not something I agree with you actually, but I think that is something which is debatable and it is different for each surgeon. I think.
Can you explain the another tumor which you have removed from the main renal vein, isn't it?
Yes, sir.
So wasn't this the extension of that segmental tumor, or this is a separate entity?
That is what is something which is we are not very sure, sir, because
how do-
intraoperatively we could see that the tumor margin was completely smooth and there was no breakage of the tumor. So it could probably be an emboli which has happened preoperatively, or
And this lady had single kidney or?
single functioning kidney, sir, actually.
Thank you very much. I think
Thank
now
you,
I
sir.
call upon the next speaker, Dr. Nirmaya Patak from MPUH Nadiad, robotic assisted zero ischemia partial nephrectomy with TFL laser.
Good evening, respected faculties and delegates. Hello everyone, my name is Dr. Nirmaya Patak and I am going to present step-by-step video demonstration of a case of robotic assisted laparoscopic zero ischemia nephron sparing surgery. As we all know, it's okay, I'll speak then. Continuous tissue vaporization and the Hello everyone, my name is Dr. Nirmaya Patak and I am going to present step-by-step video demonstration of a case of robotic assisted laparoscopic zero ischemia nephron sparing surgery. As we all know, in zero ischemia NSS there is no arterial clamping, hence there is no question of warm ischemia times and the resulting ischemic nephron loss. Thulium laser has the advantages of good tissue sealing and hence better hemostasis. Less penetration depth and safety, allows continuous tissue vaporization and the laser delivery is easy. We aim to give a step-by-step demonstration of the operating technique of robotic NSS with zero ischemia and thulium laser. Our patient is a 56 years old gentleman with asymptomatic presentation, found to have right renal mass on routine ultrasound and presented to us for further management. This is the ultrasound image showing right renal mass 3 cm in diameter at upper mid-pole junction. These are the axial and coronal reconstructed sequential images of a CE-CT scan showing 3.1 by 2.8 by 2.7 cm well-defined heterogeneously enhancing soft tissue density partly exophytic mass lesion involving upper pole of right kidney, and this is a video of the 3D reconstruction. This is the instrument trolley consisting of 4 robotic instruments of progress, lab needle driver, monopolar couch scissors, fenestrated bipolar forceps, suction irrigation cannula, energy cables, hemolog clip applicators, lap assistant instruments and the robotic 8 mm metal cannulas. For right robotic NSS, after the standard patient positioning and port placement, the surgery started. It begins with the mobilization and medialization of ascending colon followed by cockerization of the second part of duodenum to expose the inferior vena cava and the renal vein. Here we can see the arrangement of the gonadal vein, IVC and the second part of duodenum. Then the hilar dissection begins with the dissection of the renal vein. Then the renal artery is dissected and slinged. This is followed by dissection of the perinephric fat. Followed by dissection of the peritumoral fat. Then we use a drop-down ultrasound probe for doing intraoperative ultrasound for delineation of tumor from surrounding normal parenchyma from at least 3 sides. Then we score the tumor margins with incision mode of thulium laser. The settings for thulium fiber laser are as seen. With incision mode 1 joule 15 Hz and for hemostasis mode it is 0.5 joule 60 Hz. Enucleoresection of tumor is started with thulium laser with intermittent irrigation and suction in between. Good assistance is of utmost value as we can appreciate the immediate shift to hemostatic mode of thulium fiber laser for adequate and effective hemostasis. Tumor enucleoresection is completed in this way. The collecting system was not opened. First layer of rhinography was done with V-lock 20, secured with wet clips. Second layer rhinography was also done with V-lock 20, secured with wet clips. Capsule was closed at the end of the rhinography. Additional hemostasis was achieved by the use of hemostatic agents as a sandwich of Surgiflow, Surgicel followed by Surgiflow. Specimen was bagged and removed in the end. With total blood loss of 100 ml and operating times of 175 minutes, post-operative course was uneventful with drain removal on second day, catheter removal on fourth day, and patient was discharged in stable and febrile condition on fifth day. The tumor was clear cell RCC, 2.8 cm in largest dimension, nuclear grade of 2 and negative margins. Follow-up imaging at 1 month was through ultrasound study which showed good vascularity of remaining kidney. There is only one case reported in literature on zero ischemia robotic laser partial nephrectomy with thulium laser by Kohli et al. Thank you for your patient listening.
Nirmay, have you studied the literature on what is the effect of thulium on the nephrons which you are trying to spare by doing partial?
Sir, the thulium fiber laser has a very low tissue penetration depth. It is only of 0.5 mm. So the surrounding normal nephrons are not affected much in compared to other laser modalities.
But you have only one publication which shows that it's...
Yes, sir. This is based on the physics of thulium fiber laser which is studied in thulium enucleation of prostate. Yes, sir, that was a hindrance during the procedure because gas was constantly coming out through tissue vaporization, and we had to continuously do suction of the gas and also continuously irrigate.
what is the effect of thulium on CO2 pneumoperitoneum, which you are releasing?
Sir,
Do you
I
know, have
think
you
it
got
is
any
not studied
animal
upon yet.
studies or
If you look into the physics, basically it entirely will be the same, irrespective whether you talk laser or electrosurgery. It is the heat which cuts the tissue
Sir,
and the carbon dioxide.
we'll let the candidate only answer and no got questions. Yeah, please, sir.
Dr. Patel.
Yes, sir.
Yeah, you told that this was ischemia.
Yes,
and it was possible because you have applied thulium fiber laser.
Right, sir.
But I can say the tumor was peripherally located. That's why you could succeed.
Yes,
This
sir.
was nothing to do with the laser fiber, thulium laser fiber. What
Sir,
is your comment?
Yes, sir. The thulium fiber helped in better hemostasis. That's why we could complete the surgery in this case also, sir. So that's the. Yes. Right, sir. Yes. The hemostasis was good, sir, but since because we were doing this for the first time, we were concerned that we don't want to offer any inferior modality for the patient.
Dr. Mallikarjan, no
I
comment,
just want
only
to have a question.
Yes.
Basically, how do you know that you are not cut into the tumor? The problem in thulium is you don't know whether you are cutting a tumor or a normal kidney.
Right, sir. So, sir, that's why the importance of ultrasound. We scored the tumor and then we made a rough estimate of the depth and the extent. We could have gone wrong. Yes, I agree with you.
Thank you, Dr. Nirmay.
Thank you, sir.
We move on to the next paper. Dr. Ashwin Malya from Gangaram Hospital, New Delhi. Robotic assisted surgery for bilateral pheochromocytoma in a 15-year-old girl.
Good evening, respected chairpersons. This video demonstrates robot-assisted surgery for bilateral pheochromocytoma in a 15-year-old girl. A 15-year-old girl presented with hypertension in the last 2 years. Currently, her blood pressure was 190 by 110 millimeters of mercury. She complained of palpitations and sweating episodes. Her body mass index was 26, and she gives a significant family history of younger brother who underwent surgery for left pheochromocytoma laparoscopically a month back by our team. 24-hour urinary metanephrines were grossly elevated. A CT scan revealed bilateral adrenal masses, the right one measuring approximately 4.5 centimeters abutting the liver and the left one measuring approximately 2.5 centimeter directly relating to the left renal vein. There was an accessory inferior hepatic vein which was traveling very close to the adrenal mass. Considering that this was a bilateral procedure, we had to plan the ports in such a way that most of the ports could be utilized for both sides and one extra working port was taken on each side. Docking of the robot was over the ipsilateral shoulder with the patient in lateral position. There are several challenges while preparing patients for pheochromocytoma surgery. We took a couple of weeks to stabilize the patient's blood pressure using alpha blockade followed by beta blockade and adequate fluid loading. There were some challenges during the surgery with the fact that this was bilateral. There could be abandonment of the procedure after one side. There is always a risk of hemodynamic instability during the procedure. Proximity to major vascular structures makes it more challenging. We also had to be careful that we do not render the patient adrenal insufficient and we had to do only partial adrenalectomy on the left side. So starting with the right side, our first step was to dissect the tumor from the undersurface of the liver all the way up to the diaphragm. After the liver is separated adequately, we focus our energies on the medial aspect of the tumor, wherein we try to create a plane between the inferior vena cava and the tumor. The endo-wrist movement of the robotic instruments plays a very major role in accomplishing this accurately. Accurate bedside assistance is of paramount importance as we are working close to major vascular structures. We find the adrenal vein, dissect it well and clip it with hemolock clips and divide it. There is a chance of precipitous fall in blood pressure following this step. Hence, communication with the anesthetist is very important. We proceed to dissecting the undersurface of the tumor and from the upper pole of the kidney. So, major vascular attachments are clipped and divided to prevent reactionary bleeding later. Care is taken to ensure that the vascular supply to the right kidney is not injured. While dissecting, we have to be careful not to breach the capsule of the tumor. Clips and bipolar energy are used liberally. Since this was a bilateral adrenal tumor, we tried to preserve as much of the normal adrenal as possible. It is possible to encounter a second main adrenal vein draining into the inferior vena cava posterolaterally. Pheochromocytomas being inherently very vascular in nature, their vascular attachments have to be properly managed with hemlock clips and bipolar diathermy. As can be observed, we have attempted to preserve the normal adrenal to the maximum extent possible. The specimen is packed, adequate hemostasis is achieved, Surgicel fibrillar is kept in place for low pressure, low volume bleeding, and the specimen is kept under the left lobe of the liver for easy retrieval when operating on the opposite side. Robot is undocked, position change and redock for surgery of the left side. On the left side, the adrenal is dissected in such a way that the surrounding structures are separated from the adrenal rather than direct handling of the adrenal itself. Hence, the spleen, the tail of the pancreas and the upper pole of the kidney and the colon have to be dissected out. Since this is planned to be an adrenal sparing surgery, we have to spare the adrenal vein, so hence we loop it and take control of it. We then proceed to dissecting the tumor bearing lateral limb of the left adrenal gland. We then proceed to perform enucleoresection of the tumor from the adrenal using a combination of blunt and sharp dissection, using hemlock clips when necessary. Some bleeding is expected to be encountered during this process. As can be observed, a major part of the left adrenal gland has been preserved. Hemostasis is achieved, drain is placed, the specimen is packed and retrieved along with the right-sided adrenal gland. The total operative time was 180 minutes with console time of 136 minutes. Blood loss was approximately 150 ml. This is the specimen that can be seen, the right-sided adrenal gland along with the tumor and the left-sided adrenal tumor alone. Histopathology of the specimen revealed bilateral pheochromocytoma with a PAS score of 3 indicating benign disease. Whole exome analysis revealed VHL positivity. The patient was kept in the ICU for overnight observation and shifted back to her room on post-operative day 1. She was discharged on post-operative day 4 after drain removal. Blood pressure at the time of discharge was 110 by 70 millimeters of mercury with a pulse rate of 80 per minute. Since this is a familial form of pheochromocytoma, genetic testing has been done. The plan is to keep on long-term follow-up for any possible recurrence or associated tumors. In conclusion, bilateral procedure for pheo in the same sitting is possible provided the patient is optimally prepared and remains hemodynamically stable. Pre-operative preparation is very important. Wristed movements of the robotic instrument makes accurate movements possible during surgery. An adrenal sparing surgery is necessary for bilateral cases and familial syndromes to prevent adrenal insufficiency. Thank you.
Thank you very much.
Dr. Ashwin, what are the family syndromes that you are expecting with bilateral pheochromocytoma? You have done a genetic analysis
Yes.
and just jumped to the conclusion, but
We did a whole exome analysis on the patient. So this is a test that costs around 20,000 rupees and covers almost 1,000 genes. So as far I have discussed it with the genetics, medical genetics department. So the index patient has only VHL positivity. So now we are going to test the brother as well as the parents to look for specifically VHL positivity, as at least one of the parents would be definitely positive. So the whole exome analysis ruled out all other possible genetic.
That is the one I am asking. What are the syndromes you think are involved, associated?
So the other syndromes are familial pheochromocytoma, paraganglioma syndromes. Then there could be neurofibromatosis syndromes. So these are the main ones which have familial pheochromocytoma.
Dr. Aswin,
yes, sir.
I have one question to your technical part.
Yes, sir.
How did you confirm that whatever adrenal you have spared is working? What was the sodium and potassium on third postoperative day or fourth postoperative day?
They were tested to be normal, sir. They were normal even in the pre-operative period, and since this was a metanephrine secreting tumor and there was no problem.
I'm just telling the adrenal sparing surgery you have done.
So
now I'm just asking the question to you.
It was normal, sir. At discharge,
so
both
adrenal
sodium
cortex
potassium.
was working.
Adrenal cortex was working.
Ashwin, wonderful work.
When were the steroids?
Yes.
So,
thank you, sir.
yeah, so I just was wondering that we knew it was familial. The brother had had a pheochromocytoma surgery earlier, and this was bilateral. So, you have spared the adrenals.
Yes.
Now, you know if these spared decide to develop more pheochromocytomas,
absolutely,
you are the going to go there. You should have at least removed one adrenal completely.
Yes.
So that there is less possibility that you go back and do a bilateral surgery again. Of course, you could have removed the right side, which is you were there, right there. You are left behind a burning, smoldering.
Yes.
Ash
so
there.
that was the intent when we started the surgery. So if you see, sir, when I was doing the right side, I could see a very clear normal adrenal gland. So we did not know what would happen on the opposite side. So we did not want to take a chance. That's why we spared as much adrenal gland as possible on both sides. And that is recommended as well.
Going back again, and if there is another pheo.
Yes.
Sir, no counter
this was
questions,
discussed.
Any other question?
And honestly, I didn't want to make her adrenal insufficient for life. She's a 15-year-old girl.
So Ashwin, one last question. Logically, I thought the left adrenal was easier to do as compared to the right. Why did you choose to do right first, which was much difficult? If you had encountered any bleeding,
yes,
you would have had a lot of trouble.
Had to, yeah. So that's a good question. But my thought process was, let me do the difficult side first, the larger tumor. In case, because I was not very sure, this was the first time I was doing a partial adrenalectomy. I did not know clearly what to expect. On the right side, I was sure that this is a larger tumor, more close to the IVC. So I wanted to be very clear right in the first part of the surgery, and I knew that probably on the left side, technically it wasn't that. It's not going to be that difficult. I was more anxious about the right-sided tumor, and hence I proceeded with the right-sided tumor.
One last question there. Yeah, one last.
Yeah, thank you for that question. So when I discussed, so this patient came to me with the CT scan already done. So I discussed it very clearly with our radiologists, and they gave me a very confident answer that in this case we are very sure that there is nothing else extra adrenal right from the diaphragm to the urinary bladder. So we really don't want to recommend. So I went with the advice. So I have advised the family that I would be doing an MIBG scan in future, as this is a familial syndrome and there could be recurrences. So pre-operatively we decided not to do it.
Thank you, Dr. Ashwin.
Ashwin, one question. How pre-operatively you have decided that it's not a malignant pheochromocytoma? Because if it would have been a malignant pheochromocytoma, leaving behind the rest of the adrenal may be disastrous. You have not done any tissue diagnosis. There is no other way by which we can prove that it's a malignant or non-malignant.
Yeah, thank you for that question. The only way we can prove it is by, actually earlier the thought process was the only way it could be proved to be malignant is if there is metastasis. Now the PAS score helps us.
But that you have got after.
Yeah.
What I'm telling you, because you have made your mind before the surgery that you are going in with the adrenal sparing surgery.
Yeah.
So what has decided on what basis decided that you are not dealing with a malignant pheochromocytoma?
So
because I think CT is not the right investigation for that. It should be done with the MRI, because that can give you an answer whether you are dealing with a malignant or MIBG scan. Because if it would have been a malignancy, then
yeah. No, this was a discussion that we had with the family, and the risks of making the patient completely adrenal insufficient versus risking a malignancy. So we decided in terms of doing a adrenal preserving surgery,
Okay,
because the chances of it being malignant was less.
Thank you, Dr. Malia. We'll call on the next presentation.
The fifth, Dr. Akash Shah, robotic retroperitoneoscopic retroperitoneal lymph node dissection in post-chemotherapy, post-surgery, recurrent mass in testicular cancer. Dr. Akash.
So, good evening everybody.
Hello everyone, I am presenting a video on robotic retroperitoneoscopic salvage RPLND in post-chemotherapy, post-surgery recurrent mass in testicular cancer. A 36-year-old male patient presented with left testicular mass and underwent high inguinal orchidectomy followed by 4 cycles of chemotherapy of BEP regime for non-seminomatous germ cell tumor and an 8 cm retroperitoneal lymph node mass. Patient was on follow-up for the next 4 years, during which his retroperitoneal mass increased from 2 cm to multiple para-aortic paracaval lymph nodes with largest 6.5 cm, for which he underwent robotic RPLND. Its histology was suggestive of a teratoma with no immature component. Patient was on follow-up for the next 2 years. Patient was lost to follow-up for 1.5 years due to COVID pandemic. He presented in April 2021 with normal tumor markers and CT scan suggestive of single 5 into 3.3 cm mass below the renal vein and IVC. After taking due concern and explaining the procedure, patient was taken for surgery. We followed following steps. Left lateral decubitus position was given. A 1 cm incision was taken in mid-axillary line 2 cm below the lowermost costal margin. The external oblique and internal oblique were retracted and thoracolumbar fascia was pierced and finger was inserted, creating a retroperitoneal space with the finger. This was followed by creating a balloon with the cut end of glove finger and tip of the red rubber catheter, introducing it into the retroperitoneum and filling it up to 700 cc to create adequate space. The camera port was inserted through this incision and 2 other working port and one 12 mm assisted air seal port was inserted with a pressure at 15 mm. Da Vinci XI robot was docked and targeting was done towards renal hilum. After entering the retroperitoneum, the loose areolar tissue and the retroperitoneal fat was dissected to increase the retroperitoneum. The anterior and the medial peritoneum is reflected so as to create space for placement of the 4th port for the 4th robotic arm. The retroperitoneal fat further dissected over the psoas muscle up to the point between Gerota fascia and the psoas muscle. The perirenal fascia is cut with scissors at the point it joins the psoas muscle and is extended from its lowermost point of dissection to superiorly, thus exposing the Gerota fascia medially along its entire extent. The tissue in this region is dissected further and pushed upwards as it will contain the gonadal and renal vasculature. As soon as the space is created, mass could be well appreciated in the region. Dissecting the mass from its surrounding perirenal tissue on its lateral aspect up to the lowermost point exposes the kidney, and dissecting it further anteriorly separates it from the renal hilum. On dissecting on the posterior medial aspect of the mass, there were multiple feeding vessels and lymphatics which were encountered. Those were clipped and were cut to free the mass on the medial aspect. Dissection was further continued on the posterior aspect of the mass where it was dissected free from the muscle. Here is where there were multiple feeding vessels which were burst as and when possible. The mass was densely adherent to the muscle all along its course and was slowly dissected using monopolar scissors and cautery, layer by layer, trying to find if there is an additional feeding vessel to the mass. As we were dissecting further and cutting through the dense adhesion, one of the feeding vessel got cut and it started to bleed. The field was dried and the vessel was held first with prografts, thinking that the vessel could be clipped. Further tissue was dissected on the lateral aspect, but it was not possible and it started to bleed again. So now the fenestrated bipolar was used to hold the vessel and it was cauterized. The bleeding stopped. After drying the area, the dissection was continued further, dissecting the lower end of the mass completely. Multiple feeding vessels on the inferior medial aspect of the mass were dissected and clipped one after the other, simultaneously dissecting the mass up till to its lowermost end. The mass was then dissected from its lowermost attachment and was then kept in the upper fossa. Hemostasis was seen for the next few minutes. The mass was kept in an endobag. A surgery seal was placed to aid hemostasis and drain was placed. The specimen was retrieved from the midline. The total console time was 44 minutes. The blood loss was 150 cc. Patient's post-operative course was uneventful. Drain was removed on post-op-day 2 and patient was discharged on post-op-day 3. Patient's HPE report was suggestive of mature viable teratoma with capsule intact. Patient was followed up after 6 months with CT scan and tumor markers. Both were normal. In our experience of over 9 years, we have operated 18 cases of post-chemotherapy robotic RPLND with mean operative time of 248 minutes and blood loss of 165 ml. The mean lymph node dissected were 16 and the survival rate is 100% up till now. 3 patients showed recurrence, of which 2 patients underwent surgery and 1 underwent chemotherapy. The case we present was one of the case of recurrence among these patients. To summarize, robotic retroperitoneoscopic approach in RPLND gives us a great outcome in carefully chosen patients, as robotic in itself provides better 3D magnification, easy maneuverability, improved dexterity and precision. Retroperitoneoscopic approach avoids peritoneal complication, especially in previously operated cases, provides an avascular plane, major vessel dissections can be avoided. Both together decrease the pain of the patient, provide early recovery and lesser hospital stay. Thank you for your patient listening.
Is there any difference in the pathologies when you find these masses synchronous or metachronous?
So I didn't get it actually. Sorry.
Your case is a metachronous recurrence.
Yeah.
Okay, it's not synchronous recurrence. So I'm asking, is there a difference in the pathologies when you find them synchronous or metachronous?
So I don't know actually. So I don't know.
the primary was having teratoma in this?
Yes, sir. Primary
Yeah,
was having teratoma.
that is why it grew.
It grew, yes, sir.
Did you operate this patient before, or this was first surgery on him?
No, we had only operated previously for robotic.
You have not operated, you have operated it.
Yeah, we have operated, sir.
Okay.
Yeah.
So this was a recurrence post RPLND.
Post RPLND,
And that
yes.
was previous RPLND was robotic.
Previous RPLND was also robotic, transperitoneal.
Transperitoneal.
Yes, sir.
Actually, it's very uncommon for a patient having recurrence after RPLND. It's very uncommon.
Right,
if
sir.
you do proper RPLND,
Yeah.
they are reported the most common site of recurrence is the left renal artery.
Yeah.
That's the place where actually you have to be careful. And this was on your right side.
Right side.
So that I was wondering why did not you complete the RPLND, because you have already done it.
Yeah, we have already done this before.
Yeah, yeah.
That is why we did not complete this.
We-
We have done a PET CT, which was still surgery of a single lesion.
So it's with teratoma, which probably left over.
Yeah,
small
maybe a
node
left
which
node-
grew.
left node may be
Yeah.
possible.
So when you do RPLND, it's not that you just come out with the tumorectomy. You have to complete the RPLND.
Yes, sir.
So that's make the proper RPLND. Okay.
Yes, sir.
Thank you, Dr. Akash. We move on to the next.
cases of RPLND robotic that you had done.
Yes, sir.
What was the final histopathology? How many had viable disease? How many had necrosis, fibrosis, and how many had teratoma?
So there were around 50 or 60% which had necrosis, and around 20%, 30% which had teratoma. Rest were the other viable tumors which were there for the next 20%.
Okay, and they received post-op chemotherapy.
Yeah, so all were post chemotherapy, sir.
No, after finding viable tumor, they were first.
They were further underwent chemotherapy.
Thank you, Dr. Akash. We are running short of time. We move on to the next paper, ICG assisted R wheel. Dr. Ashish from Kokilaben.
Good evening, respected chairperson and all my dear delegates. I am very thankful to Yuvraja sir, and being very lucky being a student and seeing all various uro-oncological surgeries. So today I am going to present a narrated video over ICG assisted robotic wheel.
Hello everyone, myself Dr. Ashish Asari, a Vatikuti Fellow in Robotic Uro-Oncology from Kokilaben Dhirubhai Ambani Hospital, Mumbai, India. I am going to present a video on indocyanine green assisted robotic video endoscopic inguinal lymph node dissection. I don't have any conflict of interest. Here is my patient, a 43-year-old male with ECOG 0, presented to us as an operated case of scrotal mass with wide excision which turned out to be moderately differentiated squamous cell carcinoma with clinically N0 groin. He was planned for bilateral robotic whale. These are steps of robotic whale, from ICG installation on the foot to surface marking and port placement to removal of lymph node packet. We start the procedure with installation of ICG on foot, where after induction of anesthesia 0.2 to 0.5 cc has been injected in each and every web space as well as medial and lateral aspect of the foot. Here is the diagrammatic overview for the port position of left-sided robotic wheel, in which we use 3 robotic arms along with 10 mm assistant port. To start with, in a split leg position, surface marking is done as described in diagram and a small incision kept for camera port. This incision is deepened till we reach the white glistening fascia lata. And then we create a space over a fascia lata by lifting up the scarpa's fascia by swiping fingers sideways. And further, ports are placed over finger guidance, and you have to secure ports very snugly as space is very less and likelihood of ports to come out is quite high. Now we dock the robot from the lateral aspect of the patient in a split leg position. Now targeting is done in the middle of the surgical field and other arms being docked. And then dissection starts with incising deep fascia lata and lifting up the lymph node packet. Dissection is continued by exposing adductor longus and sartorius muscle. Indocyanine green, which is sterile, anionic and water soluble, has a quality that penetrates deeper tissue and helps in visualization of nodal or vascular structure in an unknown surgical field. This dye can be injected into human tissue without any practical side effects. In healthy lymphatic system, the uptake of dye is swift, and in an impaired system, the dye stagnates and pulls. Here we use firefly fluorescent technology, which is advantage of using XI or X robot, which helps in identifying lymphatics or lymph nodes that illuminates or activates ICG. Here we were observing lymphatics being clipped and cut carefully, and on further dissection, femoral artery and vein being exposed and taking care of multiple lymphatics around them. And on further dissection, inguinal ligament as a cranial boundary and saphenofemoral junction is identified, and all the boundaries are defined. Great saphenous vein was dissected meticulously and spared to reduce post-operative limb edema. Now dissection continues with dropping of inguinal lymph node packet from above under the guidance of ICG from superior, medial as well as lateral boundaries for late retrieval of lymph node packet. While dropping the lymph node packet, assistant has to make sure that we are not very close to skin. Cranially, we identify spermatic cord and whole lymph node packet is detached from all the boundaries and plan to extract it out from the camera port. Here we can see completely exposed surgical field after dissection and negative suction drain is kept. Specimen on the left side was sent for frozen section, which was positive for malignancy, hence we perform robotic pelvic lymph node dissection, and similar procedure was done on the right side. Our surgical console time on the left sided veil was 73 minutes with a total operative time of 240 minutes and a blood loss of approximately 30 to 40 ml. Drain was removed on the 5th post-operative day and patient was discharged on 6th post-operative day, and he was followed up without any complication on 10th and 30th post-operative day. On histopathological examination, 1 out of 9 left-sided inguinal lymph nodes turned out to be metastatic squamous cell carcinoma with extranodal extension. Rest right-sided inguinal lymph nodes and left pelvic nodes were negative. And in our experience from 2009 to 2020, we have come across 79 patients with penile squamous cell carcinoma, out of which 47 patients we have operated as robotic veil, which has a comparatively less complications than open inguinal lymph node dissections. In the last 5 patients of robotic veil, in which we have used indocyanine green, and the drain output has been significantly reduced with an on an average drain removal duration was within 7 days with good lymph node yield. This is our study that has been published in Journal of Robotic Surgery in January 2021, which concluded that robotic veil is safe with less wound related complications and equivalent survival compared to open surgery. And these are some surgeries where role of ICG has been proved in urology. And at last, to conclude, robotic veil is a safe and a technically feasible surgery which maintains good oncological outcome with good lymph node yield. It also reduces the complications which is compared to open inguinal lymph node dissection. With add-on application of indocyanine green, further morbidity can be reduced, but still more cases and studies are required. Thank you for your patient listening.
Thank you. Thank you, Dr. Asari. Can you tell me what is the literature evidence? Has anybody else used ICG for lymph nodes or lymphatic in this veil?
There are not so much literature available in urology, especially using ICG related lymph node dissection, but in gynecology there are some literature. They have used for vulval cancer and they have done the sentinel lymph node dissection using ICG, and the false negativity rate has been reduced quite from 20% to 5% using ICG.
But that's a different indication
Yeah.
for different reason. In
There
this,
are no much papers are there.
Yes, Dr. Assis, how does this ICG helps you in veal for lymph node dissection?
Sir,
is it the yield which you targeted for? Is it the lymphatic drainage or drain output you targeted for? What was the idea of ICG?
By using ICG, we can get the good yield of lymph nodes. One. Second, we can reduce the morbidity, as the keeping drains for longer time, like 20-25 days, and taking care at home, it's quite cumbersome to the patients also.
How does ICG causes less lymphatic drainage?
So we can identify the lymphatic tissues very well, and we can clip it under the guidance of infrared. So it helps in doing dissection.
So one of the conclusions that you're telling, number of lymph node yield, it has improved, but in your surgery we did see you chasing the lymph nodes or identifying lymph nodes or sentinel nodes. So that part is not valid, but lymphatics, we do agree that your lymphatic time for drainage is less, and also that you could identify the lymphatics along the vessels and you could clip them separately. I think we'll end the session there. Thank you all for your participation.
Thank you.
And all you for your wonderful videos. Thank you very much.
I would like to thank all the speakers, presenters and the moderators for this session. Now, as an extension to our learning from legends, we have the next legend, Dr. Mahesh Desai sir, presenting outcome metrics of robotic partial nephrectomy. To moderate the session, may I welcome Dr. Sudhir Rawal sir and Dr. T.B. Uraja. Since Dr. M.R. Desai sir is at US, he will be presenting his talk on virtually.
Good morning, sir. Can you hear us? Sir, voice is not coming. We are just sorting out. Sound. Sir, you are muted. Unmute yourself. No, he's not.
Okay.
Yeah.
Yes, sir. You're on, sir. Okay.
We can hear you, sir.
Right. Okay.
Thank you for seeing you in Los Angeles. And without delay, we will go with your talk. Thank you, sir.
Yeah. Thank you, Sudhir, and thank you, Yuvraj, for the I'm allowing you to have a presentation from LA. I'm sorry I couldn't be there because yesterday was my grandson graduation, so I had to be there. So I would like to share my screen. Can I share?
Yes, sir. Please go ahead.
Yes, sir, you can go ahead and share, sir. Can you do that? No, sir. Sir, you will not do it, sir. Your rights have been given for you to share, sir. Just go to the presentation and share it, sir. How do I? 1 minute, I share the screen. And the password खोल and the password खोल अच्छा. Dr. Mead, open the presentation and then go to share.
No, but he has to first do the.
No, minimize the zoom, open the presentation, do not go full screen, go back to zoom and then click share. You will find it as one of the icons.
No, but he has to change his system setting. 1 second.
बेटे का कल ग्रेजुएशन सेरेमनी है, बाप कैसे आ जाएगा जब दादाजी नहीं आए तो दादाजी नहीं रहेंगे और
Dr. Mead, what settings? I don't think you have to change any settings, sir.
Yeah, I got it. So, are you able to see the screen?
No, sir. No, sir. You have not shared it yet.
We can see you both.
Go back to Zoom. Zoom would be at the bottom, minimized.
Hang on 1 second. Using this computer for the first time for a Zoom presentation. It is asking him to go to settings to allow Zoom to share screen. So you have to go into system preferences first, I think.
That is in the system settings. You'll have to go into the system settings.
Yeah.
Go to accessibility. It's a Mac, Dr. Meir?
Yeah, it's a Mac. It's a new Mac. So accessibility, okay. And then
So
Zoom.
go to system preferences.
Yeah, I went to accessibility. So I click Zoom there.
Yeah, you click Zoom and
then I have to go to advanced.
go to Zoom 1 minute. We are also trying and seeing where. No, come back to share. On the right, you will have security and privacy.
So in accessibility, no, not accessibility.
Security and privacy.
Hang on. Okay. And then go to privacy.
Once I click on security, 1 second, because here it's sort of hanging up for us.
One thing, yes. But I need to hear what he's saying.
If not, Dr. Meher, can you mail me the presentation? I can run it from here and give sir accessibility.
No, I can now. Just a minute.
Oh yeah, sure.
It says open system. This is not set up for Zoom. I don't know why. Can you see the presentation?
No sir, we only have your camera on. No, you'll have to go back to the Zoom, sir.
Okay. Okay. Hang on now. Now I think it should work. It should work now. 1 minute.
Yeah, take a time.
So I will have to quit and reopen, okay?
Yeah, that's fine.
Yeah, there you are. 1 minute. No, you clicked the wrong one. Your presentation has not got shared. You have shared our screen. So stop sharing. No, he is not shared actually. They have gone to a different input. Yeah.
Okay, we have. Yeah. Now can you see it?
Yes. Yes, sir. And can we go? Perfect. Sir, can you shift your camera? Can we have your camera as well, sir? Just give me a minute. Yes, sir. We are ready to go.
Ready to go? Okay. Well, I'm sorry for the delay, and let me come straight away to my talk. Okay, can you hear me?
Yes, sir. Yes, sir. Please go ahead.
All right. Okay. So in a previous session we have heard lots about partial nephrectomy, and I would like to share some of the renal. I'll just take out my picture. The incidence of the renal cancer is increasing, and it has been recorded all over the time from 2014 onward, and it is because of the rapid adoption of the cross-section abdominal imaging. And the data from the National Cancer Database demonstrated that the stage where one renal cell carcinoma increased from approximately 43 to 57% of a newly diagnosed between 93 and 2004. And 5-year survival rate for localized disease increased from 88% to 92% in recent time. Thoughts and concept change with the passage of the time, and we are lucky to have Andrew Novick at the NPH in 2002, and Dr. Gill came and he demonstrated a partial nephrectomy in one of the Shrenik's workshop. And that's how we started, and we learned from these two giants. It was a paper which was a landmark paper where Andrew Novick did a long-term follow-up after a partial nephrectomy at the 10-year follow-up, and a cancer-specific survival was 88.2% at 5 years, 73% at 10 years, and local recurrence-free rate was 94 to 92%. So we would like to share. After that, we have taken and inspired by them, and we are really grateful to Dr. Gill and Mihir Desai for putting us on a robot. So robotic partial nephrectomy, we'd like to share about data of 328 from 2010 when we acquired the robot till now. Now, in this time, we also done advanced cancer, and then a total of 578 lap radical nephrectomy was done, and then robotic radical nephrectomy was done 93, as against robotic partial nephrectomy was 324. So it is 46% of the open radical nephrectomy, we did a partial nephrectomy. But if you see the radical nephrectomy, we have done maximum lap, while here we have done maximum robot. Robot has an age over the lap in doing a partial nephrectomy, at least in our experience. And this is the breakup from all this last 12 years, what we have been doing, and then suddenly our number has increased. And this is a male and a female, male predominance, but the age is between 41 to 60 is the maximum incidence, but all across the age you will find the tumor. And total of 325, male with 232, female with 93. The age was 52, average age was 52 plus and minus 12, and average size of the renal mass was 4 plus and 1. So it was quite selective. But what is most important was the comorbidity. In almost every case, you see either diabetes, hypertension, or in combination, some CKD status because of diabetes and hypertension. So comorbidity is one of the things. That's why I think the partial nephrectomy is very important to maintain the normal renal function afterward. The location, well, we find that the upper pole, upper pole, mid pole, lower pole location were almost similar, and hilar was 5. More lateral tumor we have come across compared to the more medial, probably more medial in the hilar situation where we may found it difficult to do a partial. We may have gone to the radical prostatectomy. But this is the demographic analysis. Now, when you see the maximum tumor was between 40 to 70 years of age, 202 out of 254 tumors were between this age. But and majority of clear cell RCC or a papillary RCC. In this situation. And as we are discussing about the tumor grade, and even though we thought all of them were T1A or occasionally T1B, but here you can see that some of the tumor, not much, about 15 tumors were T23 or a 2B. So that was a surprise on the table. So that discussion was already happened. So what is important is the outcome. I'm going to talk about the outcome. The trifecta optimal perioperative outcome of robotic laparoscopic partial nephrectomy. This is a multi-institutional study, and they have divided by a trifecta is a enucleation or a resection of surgical margin, zero perioperative complication, warm ischemia, and Dr. Kauk has included renal preservation and CKD stages. It becomes a pentafecta of the thing. So let's see the overview. What is most important is the ischemia while you are doing the surgery. Second thing is the resection technique, and third is the technique of a renal reconstruction. And all are interdependable. The most important is the dynamic effect on the anatomical amount of renal parenchyma spared. You are removing a tumor, but you must preserve the maximum possible. So there is a question of either you do enucleation of the tumor, for that you need a very clear-cut margin. Not the case which Arvind showed where you have an uneven margin, probably you require resection, but then you will lose more tissue. That technique of renal resection, a dynamic effect on the amount of vascularized renal parenchyma is spared. So reconstruction, renography is important, where if you take a big bite, then you lose lots of blood supply and the functioning kidney. So I influence the effect of the resection technique, renography technique, and the kidney quality on the ultimate function outcome. That is most important, and finally unmodifiable is a strong effect the post-operative renal function, setting the limits of the functional recovery after the partial nephrectomy. And most important, the quality of the kidney and the comorbidity does affect the outcome result. Everything is interdependable, and because of each point is important when you are doing a partial nephrectomy. For example, when we started a small apolar tumor, and where you can dissect out nicely, but most important I find is the ultrasound, and the ultrasound really helped, and I was very used to this, where it gives a surgical margin, you can do the color Doppler, and then you can resect out, and then you can see the mobility of the robotic arms were so beautiful that to resect in a different angle and then suture it and close it is very nice. Of course, the Willock suture has made lots of difference, and the two-layer technique has been very, very important. I will go a little faster because I think we are behind time. Here the warm ischemia time was 16 minutes. Blood creatinine actually, what happens very often, the patient comes with a CT scan or ultrasound and or a picture, and we have to do a angiography, and because we do angiography, creatinine little goes up before the pre-operation, and that's temporary, it comes down. Here the blood loss was minimum, and if you see the eGFR at the end of the 6 days before patient leaves, it has gone back to 1.9 normal. And if you see a 1 year follow-up, and which has been done, you can see from 0.98 it is 0.9 creatinine, and eGFR from 92 to 101. So there is hardly any effect on the kidney function. But technique is important. You remove, this is the exophytic tumor. This is only the tumor which was attached to a kidney, and this is the fat around it. And then it was a clear cell carcinoma. Most important, we would like to know that the margins were free, and that was the thing. Now this is the case which Arvind has shown. This is the tumor, and then we were debating whether we could do it. We did angiography. I think angiography was very, very important. We showed a major vessel with the multiple branches, and then of course you can do a 3 as he has shown it, and then we do a nephrometric score which gives you the idea that it's not going to be an easy one. But here what we do, we prepare ourselves for every eventuality, especially bleeding. So we control the main renal artery, and then here there are multiple vessels, and then here we have controlled the vessel. This is very important. Either you can clamp here, you can clamp here, or you can do without clamping, depending upon your artery. Here most of the tumor was exophytic, but in the hilum, and so we did ultrasound and try to find the margin, and you can see the margin where you can be able to mark it out beforehand, and then you deepen it and feel the cortex. After the cortex, you just have to strip it, and then it comes out easily. I find like now we have cut. Now you can see I'm stripping it, and then there is a vein which was going it. It was near the hilum, and then it has been done. So it is possible by doing what is important, which Anand Kumar has said is a perioperative investigation, and that helps us to plan your surgery. And then of course the technique of urology, which is important, and you control. We use a hemostatic agent. I don't know how far it is useful, but there is no harm in doing it, so we do it. So this is a 18-minute ischemia, and you can see creatinine slightly increased, blood loss is hardly anything, GFR is little drop at the end, but if you see after the 1 year, the creatinine is almost normal. eGFR had dropped earlier, then it comes to 96, 103 to 97, and that's perfectly all right. And here is the technique where you do the enucleation and it completely clear the stone. Capillary renal cell carcinoma. This I would like to show you a enucleation where you preserve the maximum amount of the tissue in the resection, where you have in initial period we didn't realize, but this is a part of the normal kidney tissue where you should have been preserved. Now it comes a large tumor. Now can we do an open surgery or a partial? Now this is a very, very big question, and this requires lots of study, and we depends our study on angiography. And here you can see that the tumor mass is long, and here you can see there is a feeding vessel here. So if you control this feeding vessel, you can preserve the vascularity of the upper pole, and then you can do it. And this moves around, so it gives you the idea that how doing operation is going to be taken. So here, most important, the adequacy of the vascular control, which is helped us by doing a preoperative imaging, intraoperative visualization of what you have seen in the preoperative imaging. Complete hyaloid dissection is important. Inspection of the vein is important. How does it lie? Where are the branches going? They inspect the cortex after the clamping and see how much is the ischemia, or whether there is no ischemia, or you might miss some vessels. And intraoperative imaging and ultrasound, I use a Doppler or NRF imaging. And here is a kidney tumor. We decided that we will dissect out. We did a color Doppler. And then we decided we will do the selective vascular dissection with a zero ischemia. So we clamped it, and this I will go a little faster. It is, everybody knows, we had opened up the lower pole collecting system, so we closed it, corrected it, and then we closed the tumor. And here that basically everything to shorten the ischemia time is important in preserving the kidney function. The primary aim is to remove the cancer. So early unclamping, selective or a segmental clamping, super selective clamping, fluorescent imaging to manage clamping, ischemic preconditioning, and unclamped partial nephrectomy. And then whenever you think, no hesitation to approach to perform the hypothermia. I think all options are available to us, and we should use all the options. And here I have shown you that we can do a large tumor in a zero ischemia by selective clamping. Here it was a tumor, and it was a clear cell renal carcinoma. Here ischemia time is 0. The creatinine rose to 1.25. Hemoglobin drop was there, and GFR 91 to 60, significant drop initially. But zero ischemia rationally is eliminate global renal ischemia, countered resection, pinpoint hemostatic urography, and a better volume preservation. And here you can see the graph. 1 year, we have followed up each and every patient over the years, and we have found that the 89 to 84 was a creatinine, 91 to 92 was a EGFR at the end of 1 year. So the renal ischemia time has not affected the EGFR. And here is we also do the post-operative CT, which we will tell you. And here is another mass in the lower pole. Here is most important, this technique of rhinography. I talked about resection, the rhinography, and here you take and then you put a clip, and then you slide the clip, and that pressure is enough to control the bleeding at the edge. And I would like to say that this technique was done, popularized by Dinesh Agarwal. Now, Dinesh Agarwal was trained in Bombay Hospital, then he spent 2 years at Nadiad in MPH. Now he is in Australia. He is an excellent robotic and laparoscopic surgeon, and he was the first one to show this, and that's why we feel as an Indian, Indians have done remarkably well in the robotic surgery. And this technique was done, and here again we follow the same principle of 2 layers in closing the technique. So here is the same thing which I am showing you by Willock suture. We do the first layer and then the second layer. I will go faster. 20 minutes ischemia, and creatinine is slightly raised. Hemoglobin drop is again only 1 gram. EGFR is 95 to 86. Again, over the year, if you see the graph, it is all stable, and it is a post-operative. So, most important challenge is VHL syndrome. And I operated twice for a cerebral hemangioma, and right robotic radical nephrectomy was done, and a clear cell RCC was the diagnosis at that time. And now he has come, he has got a multiple tumor. Now, Pranjal says that there is no place for a zero ischemia. I think here clamping in a single functioning kidney with so much tumor, but look at that tumor, all are superficial tumor. And anatomically, I feel that probably there may be a little bleeding problem. You may need to give a blood transfusion, or there may be a functional problem. But we control the artery whenever be necessary. We can clamp the artery to control the vessel, and here one by one we went and then resected the tumor and completely removed all the tumor. Ultrasound helps you very nicely. Again, I will go faster because everybody knows how to take it out, and then we put into a Nadiad bag, and then we have removed all the tumor. There were 5 ones. And the intraoperative ultrasound, I feel, is important in controlling the resection margin in partial nephrectomy. It's a simple, efficient, effective method for ensuring negative surgical margin with a small increase in warm ischemia time can be conducted by the operating urologist. And here he had a stormy period. Here anuria and creatinine rose to 8.5. He was managed conservatively. Slowly urine output began to increase and creatinine started decreasing. Then we changed it to a digestant, and then he had a fever infection, and then we controlled the infection. So this was a zero ischemia time. Creatinine increased at the time of a discharge, but if you see the EGFR has dropped significantly from 105 to 35, but it was a single functioning kidney. When you look at after 1 year, 1.24 was the initial, it 1.42, and this was from 105 to 42, not on dialysis. He's doing extremely well at the moment, and this is the tumor, and then it was removed. Sometimes you have a difficulty, a patient who had a right open radical and the left upper pole partial nephrectomy for a bilateral RCC, and he developed a tumor again. And we did contrast enhanced ultrasound, which will give you can do during operation time. This is almost endophytic tumor, and then we did a CT angiography. It is very important to know everything, and then of course we have to dissect out the kidney. We had open surgery before, so it was all adhesions, and we did a mass clamping because there was no way you can do the dissection of the hilum. And then of course when we removed it, it was a little anatomically difficult to pinpoint the margin like in a virgin case. And here the ischemia was 19, creatinine rose to 1.19, and hemoglobin drop was minimum 110 to 74, not bad. And then look at that, he is stabilized now after the 2 surgery, and this was done in 2011. Now it is 11 years and he is doing extremely well. Only thing, of course, I feel bad that we left some of the we resected more, but there was no way we could do it because he was already operated case. And similarly, this is the bilateral tumor, and here we did a bilateral partial nephrectomy, 0 ischemia. Luckily, it turned out to be a chromoform renal cell carcinoma. Again, I'm stressing about the ischemia, 0 ischemia. Serum creatinine was 8.9, 1.25 because we did a bilateral dissection. Creatinine drop was, hemoglobin drop was minimum, eGFR was 91 to 60, but in the end it is come back to normal. That's what I'm to say, creatinine, eGFR. So it doesn't have the long-term effect. Sometimes you have some problem, like this is a large tumor which I was dissecting, and then in between there was hardly any space. But when I found the tumor had punctured by the scissor, and it is filled. So I had to convert it to open surgery and then try it out. So when you are doing the open surgery, you have to be very careful how you put your instrument, and that was one of the complications which was done. This is the second one, which was a big tumor, and we thought this is a higher tumor. You see the vessel, all vessels are pushed laterally, so we could do it very nicely. But post-operatively, he was bleeding, and she was bleeding, and she had developed hypertension. We had to explore and do the nephrectomy, and here you can see that the vein which was collapsed had torn, and then the bleeding was from there. So you have to be careful on the venous discussion in arterial. This thing is going to happen when you are tackling a difficult cases. But one mistake makes you little wiser, and then you learn from your mistakes and then do it. And then lastly, the mean tumor size of 328 was 4.12 into 1.57, less than 4 centimeter, 161 cases, 4 to 7, 149, the more than 7, 18 cases, and score less than 7, 174, more than 7, 149. That gives you the idea you can tackle. But then you have an option, 0 ischemia in 39 cases, less than 20 minutes, 99 cases. Best is 20 to 25 or less, 25, 93 cases. And sometimes more than 25 cases in 97 cases. Overall, warm ischemia time was 19 plus and minus 10. And here the warm ischemia, we have compared with the size with the warm ischemia time, and we find that with the increasing the tumor size, warm ischemia time increases. Then we also looked at the nephrectomy score, and we find with increasing nephrectomy score, warm ischemia time increases. And here we have found that GFR, usually in 25% there was no change, 40% minimum change, and 24% 16 to 30%, but 9.5, 31 to 45 is significant. But that one afterward was dropped to 6.3. And here we found that after a partial, nearly 39% drop is about 15 to 30. It varies, depends upon the comorbidity, size of the tumor, not warm ischemia time, but this is important. And then here we found the GFR at 1 month versus warm ischemia time. Conclusion, in all these cases, I won't go into detail, but not a significant factor for eGFR fall in 1 month. None of the thing warm ischemia time matter, which I showed you earlier also. After 1 year also, warm ischemia time is not a significant factor for eGFR fall at 1 year. The most important is preserving the maximum kidney, and of course removing the tumor without a surgical margin. If he has a diabetes or hypertension, does it make a difference in eGFR fall? In our study of this, we found that the ischemia time is not a determining factor for a fall in eGFR at 1 month and 1 year after considering the comorbidity. So do not worry about the cold ischemia or anything. And we have published a paper, One Ischemia Time in the Renal Function Preservation in Robotic Partial Nephrectomy. Evaluation is renal impact, and we found one ischemia time is not predictor of renal function at 1 month or a 1 year follow-up. This was published in 2020. And post-operative course was normal, few drops, and Canadian grade 7 patient had a fever of paralytic ileus, 1 patient had a pulmonary embolism, urinary leak in 3 managed with the digestant, and 2 grade 3B ureteric stricture and postoperative bleeding, which required intervention. Average hospital stay was 6 plus and minus 2 days. Now these are the patient, about 11 patient which had GFR less than 60 at 1 month, and we followed up, and 5% patient progressed to CKD. Not all of them require dialysis, but they are may require dialysis. But these are the patients whom we took a risk. There's a single functioning kidney or a bilateral operation, something like that. And the complications, 17 patients require 1 unit of blood transfusion, 2 patients require 2 units of blood transfusion, 1 patient requires 6 units of blood transfusion, 4 patients had a fever, 9 patients had a death. And I will talk about that. And the majority had a clear cell variety or a papillary variety, but we had a chromophobe, cystic, tuberculosis, AML, benign tumor, oncocytoma, and the margin positive was 3. In 1 we corrected on the table because we suspected that, and 2 we kept under observation, and 1 patient after 5 years showed a small doubtful metastasis in lung. Biopsy was not very proven, but then he was under observation. Probably he got chemotherapy. That was my understanding is there. So our duration at the moment is too little follow-up. We need to do 5 years or more follow-up for that. The death in 9 patients, 1 immediately within 4 days who had a heart attack, surgery had went easily, and 2 had ischemic heart disease. 3 CKD already compromised patient, they died. 2 we don't know the cause. 1 severely uncontrolled diabetes, and he followed up for 1 year. After that he was lost. 1 secondary doubted, which I told you, after 4 years, and that time his PSA was 7, but biopsy was negative. But we are following up all this patient. But we find there are 2 patients who had expired, had a spread out of the lung, and a death due to kidney cancer. So this is the 2. Remaining we didn't find any evidence of tumor. In 2 patients that lost to follow-up, we could not do it. So current status and take-home message is case where the hypothermia or a no ischemia really is likely to be beneficial is a solitary kidney. Familiar syndrome, multiple tumor, VHL, and perform the partial the safest way possible, if possible minimize ischemia without compromising oncology standard. That is the bottom line. And a heroic compromise partial with a significant bleeding is not beneficial in 2 kidney model. So if the second kidney is normal, I usually would not like to take a chance with a technique or with the tumor with the oncological principle. So in conclusion, technically feasible, better for the higher popular tumor, for hilar and polar tumor, the pulmonary data, better preservation of renal parenchyma and GFR, no increase in blood loss and complication or a positive margin, increase over time, transfusion rate, technically advanced procedure. I think this is now well established standard procedure, and then we are really is a partial nephrectomy has given a boon to the patient, preventing them from early dialysis or having a normal kidney life. And in the end, sometimes people are appreciative. That is your reward. Thank you very much.
Thank you very much, sir. It was a really enlightening talk on kidney tumors. Thank you so much. I'll hand over mic to Dr. Sudhir Raval.
Thank you, sir. It was a great talk and great learning, and your experience are actually astonishing. And the way you have evolved in the center and country and all over the world, that's amazing. Thank you, sir.
Today, you know, this is only possible when you have an institute where you have a team like Sabnis, Arvind, Abhishek, and this is a combined experience. Every complication we discuss, and then we try to improve. We don't try to see who is at fault. We try to see how it can be overcome.
Yes,
and
sir.
I think everybody's involvement is very important. And Yuvraj, I just compliment you by organizing this society. You have brought all the people who can share the thing. I have been stimulated by Sudhir for doing a retroperitoneal block dissection. Now, of course, I am crossing my age, so I am pushing Arvind and Abhishek to do that. We have not yet started, but I think this conference take-home message is very, very clear. Go ahead. I think this is that today. Thank you so much.
Thank you, sir, for that enlightening talk. Kindly be with us for the inauguration ceremony. Now may I welcome Dr. Rohan Batra for further proceedings of inauguration ceremony.
Can you remove my
Good evening to all
Sir,
dignitaries.
I have stopped your sharing, sir. 1 second. I have stopped your sharing.
Yeah.
So, we are going ahead with the program, sir.
Good evening to all the dignitaries, faculties and delegates present at the 4th RUFCON 2022 Nadiad. With great joy and immense pleasure, I feel privileged to extend a warm welcome to all the present here for inauguration ceremony of 4th RUFCON 2022. Now I invite and request the dignitaries to come and occupy the distinguished chairs on the dais. I cordially welcome Secretary RUF Dr. T.B. Yuvaraja with a floral welcome. We give a warm welcome to Chairman RUF Dr. Sudhir Raval with a bouquet. I welcome our Medical Director MPUH Dr. A.K. Rastogi sir with a floral welcome. I humbly welcome Chairman Urology and USI President Dr. Ravindra Sabnis sir with a floral bouquet. We wholeheartedly welcome Chief Consultant Urologist and Managing Trustee Dr. Mahesh Desai sir who is present on Zoom from US. I welcome Shri Rohit Patel, Chairman MPUH, who is joining us on Zoom. And I invite Organizing Secretary RUFCON 2022, Dr. Arvind Ganpule sir, with a floral welcome. Now I would like to invite Dr. Arvind Ganpule, Organizing Secretary RUFCON 2022, for the welcome address.
I will keep it very short. From the bottom of my heart, I would like to welcome all of you to Nadiad. And we all are really very much obliged that you came all the way to Nadiad to attend this conference, and I'm sure it's going to be an enriching experience. I would not like to be very repetitive, and hence I make it very short and address you and say that all of you are welcome here. Thank you very much.
Yes. Let us gather for the light laming ceremony. I welcome all the dignitaries on the stage to please come forward for lighting the lamp. Pavan. Saraswati one.
इधर देखिए आप लोग फोटो के लिए।
Now, I would like to invite Secretary RUF, Dr. T.B. Yuvraja, for the Secretary report.
Good evening to all of you, respected dignitaries on the dais and my dear friends, seniors and colleagues. So it is always a pleasure to be a part of Robotic Urology Forum. It gives me an immense pleasure as to see the society growing as you know as the years are passing by. And this year, so I really thank the Nadiad group, Dr. Professor Mahesh Desai sir, to accept and conduct a wonderful meeting. And we have tomorrow, day after tomorrow, yet to go. I think we are all of us are learning a lot. So with the 2 years of vacuum, where we didn't upgrade our knowledge, although online webinars were available, so it was really very nice to have all the people physically here and learn each other. So to tell a little bit brief about Robotic Urology Forum, so I got this idea when I attended naturally the European meeting and United States meetings. So then we decided that we saw that the robotic surgery is one of the important field in urology, and that is the #1 branch where the robot is being used a lot. So then we decided to have the society to be formed, but we had almost took 1 year to decide and configure how it to be. And really I thanked Dr. N.P. Gupta to give me advice, and we sat together and formed a foundation team. And then finally in 2017, so we started this forum and we registered under Charity Commission of Mumbai. And from hence onwards, so then we decided to have a yearly meeting. We named it as RUFCON, Robotic Urology Forum Conference. And every year we are growing in numbers as well as in technology, as well as in understanding the application of robotic technology in treating urological diseases. I think this year is really wonderful, where we are seeing many new robots coming in the field, and in future is bright as far as robotic surgery. I always tell that. And having said that, again I reiterate saying that we always, the surgeons, we know the disease first and then the technology next. We are applying technology to treat our diseases. That is the take-home message. And apart from this, we had a yearly meeting. We had 2 years, we didn't do it, and this year we are doing it. And every year in the month of, generally in the month of April, we do this meeting. And I request all of you to become member of this society and make our strength. The strength is the numbers first, and then comes the the activity comes naturally. And I really thank the seniors over here who guides us how to take the society to forward, because now USA has dropped, Urological Society of India has dropped a technology based societies or sub societies, and now we have to grow because we have to improve along with the technology. We can't leave behind the technology in our life. So with these few words, I really once again thank Nadiad Group for this wonderful meeting, and thank you very much, and we'll see next 2 days will be a great learning for us. Thank you so much.
Thank you, sir. I would now like to invite Dr. Mahesh Desai, Managing Trustee, MPUH, to speak a few words.
Dignitaries on dais, and I would really welcome all of you, and I feel really sorry that I am not there personally, but at the same time I am so happy that without me, my team has done an excellent job. I think it has done a better job than what I could have done, and I really congratulate them. Secondly, I do believe in MPH, we believe technology saves the life. And right from the beginning, For last 40 years, we have been investing in technology to see how the patient improves. And this Mihir in 2005 put a proposal that we should go for a robot. Jaran Bhai that time accepted the proposal, but then we have to look at the viability. We prepared for 5 years the laparoscopic surgery, which later on could be converted into robotic surgery, and then the Rohit Bhai arranged the finances, because this is a charitable hospital, and he arranged the finances very nicely, and we paid off the loan which we had taken within 2 years, and today we see the result, and not only result in radical prostate and kidney tumor, but in also in a reconstructive surgery which has been doing. And then we have divided, we have Dr. Arvind, Dr. Abhishek, and all the juniors have been helping us, and we also made our hospital a training center, so we believe we need to train the upcoming students so that they can cater the service all over India. And I'm very happy that this is being conducted very well. I wish you all the best, and I again thank the office bearer of the RUFCON, Sudhir Raval and Yuvraj, to help us out. And I also again thank Dr. Sabnis and Dr. Arvind and Abhishek and Abhijit and Batra and Patel, all of them to do the job wonderfully. Thank you. Thank you.
Thank you, sir, for your kind words. I would now like to invite Dr. A.K. Rastogi, Medical Director, MPUH, for his address.
Good evening, gentlemen on the dais, respected faculty members and delegates. Once again, I'll welcome all of you to this RUFCON 4, and I'll be very, very brief. Actually, robotic surgery gives precision and it gives flexibility to the hands of surgeon, but if you see in real sense, it is the surgical inherent skill and your experience in such common forums which really makes a lot of difference. Now, this RUFCON 4 was on card since April 2020. Unfortunately, because of pandemic, we got this opportunity now. And of course, the response was overwhelming, with almost 150 delegates registering for this event. And the organizing committee has ensured that maximum scientific content could be squeezed into the sessions for healthy discussions, and they have put in their best effort for logistic support to make you all comfortable at Nadiad. And I'm sure over next 2 days we will have very, very interesting and healthy discussions in this classroom and otherwise, which will definitely help the fraternity of robotic surgeons and in the long run all our patients very well. I wish you all a very, very good conference. Thank you.
I would now like to invite Shri Rohit Patel, Chairman MPUH. He is joining us on Zoom, and I would like to read the address he has sent to us. His address is Chairman RUF, Dr. Sudhir Raval, Secretary RUF, Dr. T.B. Yuvraja, President Urological Society of India, Dr. Ravindra Sabnis, Managing Trustee, Dr. Mahesh Desai, Organizing Secretary of RUFCON 2022, Dr. Arvind Ganpule. It is my pleasure to welcome you all at the 4th Robotic Urology Forum, which is held today at Muljibhai Patel Urological Hospital, Nadiad. I understand that this forum has been established in the year 2017 under the leadership of Professor N.P. Gupta, New Delhi, and Dr. T.B. Yuvraja. Robotic surgery has been developed in India recently, and therefore establishing this forum will be a pathbreaker in coming years. Muljibhai Patel Urological Hospital, Nadiad realized the need for robotic surgery more than a decade ago. It is the first hospital in Western India to install the robotic system. It has helped patients immensely to carry out complicated urological surgeries, giving them quality of cancer-free life after a complicated surgery. I know from my personal experience that robotic surgery is commonly used for treatment of cancers. The premise being a fast and remarkable recovery from cancer with minimal convalescence. However, the application of this platform is just not restricted to cancer surgery. I was delighted to learn that the theme of this meeting is Robotic Urology 360-degree, meaning the application of this technology is not restricted to uro-oncology. The live demonstration of surgeries will also be a part of this conference. The best way of learning any surgery is to teach one or see an expert performing a procedure. This concept remains the soul of RUFCON 2022. We at MPUH have crossed the mark of 1500 robotic surgeries, which include robotic renal transplants and pediatric robotic procedures, apart from uro-oncology related procedures. I am glad to learn RUFCON 2022 will also be acknowledging the best papers presented by young and upcoming doctors. Stepping back into the past, anything new is met initially with criticism, then analysis, and finally acceptance. The same thing has happened with this technology. I still remember when the SI robotic system was installed in MPUH way back in the year 2010, there were a number of naysayers who actively debated on the cost implications and the futility of this new technology. But you can see now it is close to becoming a gold standard. This is evidenced by growing number of delegates attending RUFCON. I am told at RUFCON 2017 that there were 40 delegates, while RUFCON 2022 boasts of more than 145 registrations. There are also a number of new robotic installations companies coming up on the horizon in the market. I conclude by quoting the quote from Alvin Toffler: "The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn." I do appreciate the hard work, professionalism, and the innovative mindset of medical professionals like you, who have the unending zeal and courage to unlearn old things and learn new things through such forum. I wish this event all the success. Thank you. Now I would like to invite Chairman Urology, MPUH, and USI President Dr. R.B. Sabnis to address the gathering.
Well, good evening everyone. Well, as Head of Department of Urology here, I have a great pleasure in welcoming all of you for this RUFCON 2022. As you know that RUFCON is the forum or the conference which is organized by the RUF Society, and I must thank Dr. Sudhir Rao, Dr. Yuvraj, and the entire council of the Robotic Urology Forum to give us this opportunity to organize this particular conference this time in our hospital. Actually, this was supposed to be organized last year, but because of COVID, it got cancelled, and they continued to give us the opportunity this year. I hope we have worked very hard, and I hope that the faith which we have put in, we will be able to fulfill that. Well, in urology department of this hospital has been in the forefront in organizing various conferences, workshops. The first I remember in 1993 was a very big conference which we actually organized, the first big conference of endourology. That time the live operative workshop. That started the various conferences that we started organizing. So almost 30 years now that we have done so many conferences, so many workshops, so many CMEs under auspices of the West Zone, State Chapter, the National Conference on the platform of SIU, WC, so many things have been done. And that's why we get privileged and we feel really proud and privileged that this is the first time that a Robotic Urology Forum has put the responsibility on us, and this is the first time that we are organizing this conference under the auspices of Urology Robotic Forum. Well, all these conferences and all these challenges actually we take up simply because there is a fantastic support from the management and the trustees. Whenever we put forth this proposal of having this conference and taking the challenge of this such magnitude conferences, they are always supportive. They have never said that don't take this and don't take that. In fact, if there is any problem, they look after it, they arrange everything, and they ensure that everything goes smoothly. They have given us a complete free hand, and that actually gives us the confidence that yes, we can take more and more challenges, more and more bigger conferences which we can take up, and ensure that we provide the quality with which people come and expect it from us. Well, apart from the confidence which management has put in, the most important thing is the team. And luckily, we have now developed a team where they are enthusiastic young consultants. I must mention here the tremendous amount of efforts which have been taken by our consultants. The conference of this magnitude, and especially of this logistic of operating workshops from various hospitals and this, that is not easy. There are a lot of things which are required. But these people have done all the hard work. I have been just supervising them, and they actually came with lots of proposals and made sure that every person who comes here is taken care of, is being contacted, is being provided adequate information, and is taken care to the highest quality. And this, I must mention the whole credit to Dr. Ganpule, Dr. Abhishek, Dr. Patel, Dr. Pathak who is here, Dr. Rohan Batra, Dr. Pawan. All these people have taken tremendous efforts, and that actually gives us the confidence that yes, we can still more prepare to take the bigger and bigger conferences and bigger challenges. Well, as I have to speak as a president of USI, I must say that as the USI president, I bring lots of greetings to the Urology Robotic Forum as a president of USI. And this is the one forum which I feel has a lot of future, because if you see the enthusiasm of the people who have been registered, who wanted to attend, is growing. I was told that the last conference, which was pre-COVID, there were about 40-50 delegates who were there. And therefore we thought that this time at the most it will be 100. And therefore we thought that this particular auditorium and this particular site is absolutely perfectly meant for that. But when we started announcing and putting the brochures and circulating the flyers, there were so many people who started coming and registering that at one point we had to say no, that we have to stop because this arrangement would get collapsed. We don't have that much big auditorium, and therefore you saw that people, we have put the chairs, we have made one more room here outside in the classroom, the provision for that. So that shows that the amount of interest which people have in the robotic surgery is growing. The number of robot installs are 100 as of today, or maybe more, they're just more than 100. And I'm told that in next 1 year, there are 20 will be added. So there is an exponential growth of robots which is happening, and therefore there is a lot of enthusiasm from the younger generation to get used to robot, to understand the nitty-gritties of robot, and if they are not in the robotic, they feel left out. And that actually is the responsibility of the organization like USI and the organization like RUF, where the need for them and the aspirations of the younger generations have to be fulfilled. This we must take a note, and as we are now in the USI, we are entering into the subspecialties of the associations, giving more and more freedom, giving more and more independence, so that the subspecialty also grows. And this is the subspecialty, or this is the forum which is a technique based, and therefore I think USI eventually also will have to depend on them, since this is a technique based the association, wherein we need to understand that the need of the people and provide them what they want. As the USI has taken the huge task of organizing various training programs, not only for the residents, but also for the younger people through the youth organization and through the mainstream USI, this aspect we will have to consider, that even the robotic, the training and the information has to be provided to them. In fact, since last 1 year or so, Dr. Chawla told me that in the Euromed program which we are organizing for the training of junior people, that the robotic aspect has been included, and there are provisions made for the training of junior people from the robot. So that much of the USI which is doing, and I'm sure the same responsibility lies on the RUF society, where they have to address to these needs and provide them not only from the competition and not only from the participation point of view, but ensure that young people who want to learn about this, they have to provide the platform from where they can learn the robotic forum, and that is how the robotic surgeons are going to increase. Well, there is a huge scope, and I must thank all of you for coming here in such a big number from different places of all over the country, and we ensure that the hospitality will remain up to the mark. If there are any lacunae, please pardon us. If there was some congestion, there was some inconvenience of going and this, please pardon us. But we have done it from our heart, and I hope you will all appreciate all of that. Thank you very much.
Thank you, sir. Now, I would like to invite Chairman RUF, Dr. Sudhir Raval, for his address.
Good evening, everyone. Dignitaries on dais, Dr. Sabnis, USI President and Chairman of Urology Department of MPUH, Dr. Yuvraj, Secretary RUFCON, and Dr. Ganpule, who is Organizing Secretary for RUFCON, Dr. Rastogi, sorry, I tried to, he is the Director of MPUH, and dignitaries on Zoom, Dr. Mahesh Desai and Mr. Rohit Patel. It's my pleasure to be here. This is third time I have come here. I came here 2 times before. And this is a special occasion that we are having a robotic urology conference, which is 4th one since 2017, and it is a focused forum which actually just doing the only technology based, and there are actually future for all focused sub-society or society or the technology based society. If you see, there are 4 or 5 focused forum of our society on robot. There are surgeons who are focusing on hernia society, there other robotic societies are there in country, and subspecialty focused society, actually only that way you can grow. Imagine if the USI was part of ASI, we would have never grown like this, like USI is done today. And same way the subspecialty of society of USI will evolve with a focused society like for robotic urology forum is there. And this is bound to come. There is no point. There is always a place for these, because you can focus in a small field and you can cover everything. You cannot do like in a big event like this conference has done. We are doing, I think, 3, 4, 6 surgery tomorrow, and then we are focusing on the robot. And in the future, as you see, the robotic field is going to evolve. You are going to have 4 more robots in India itself, which is one of them is an Indian, and as the things they grow, then the indication will change. The indication, there will be more and more indication. This technology will go into the benign aspect also, and other indication will evolve, especially with the learning, getting experience and involvement of the young surgeons. That's what is going to happen in robotic field. Right now, this robot is available only in the big cities and big hospital. This scene also has to change, and it will change because of the hospital which are 100 to 150 or 200 bedded hospital, they cannot afford robot. And there are many hospitals, even the big hospital, they actually do not have the financial viability of robot. This is the scene as on today. But in future, this is definitely going to be cheaper, and the running cost will be less, and the maintenance cost will be less. So this is how it has to evolve. And I hope in next RUFCON in Delhi, which is in April, we can see more surgical data from the other robots, and we probably can operate from the different robots also. With this, I congratulate whole organizing team for making the great program and successful conference, and the hard work and the effort they have put, I thank them for this. And I am sure that next 2 days will be going to be a big learning. Thanks a lot.
Thank you, sir. Now I would like to call upon Dr. Arvind Ganpule, Organizing Secretary RUFCON 2022 for a vote of thanks.
Again, I will be very fast, swift, but as it is customary, I have to thank all people who have helped me or helped our team during this particular for this program. I know that our keynote speaker is waiting for us, so I'll just finish off in maybe 3 to 4 minutes. So good evening, dignitaries on the dais and off the dais. Ladies and gentlemen, thank you very much for being with us this evening. I, on behalf of the entire organizing team of RUFCON, have the privilege of standing in front of you to pass this vote of thanks. Thanksgiving cannot start without thanking the Creator. So I would like to thank the Almighty for being so gracious to make sure that this event sees the light of the day. First and foremost, this event would not have been possible would not have been a success without you all delegates and faculty traveling all the way from different parts of India and coming here. So my sincere regards and thank you to all of you. Thank you very much. An event like this cannot happen overnight. It has been mentioned by a number of times in the past half an hour that we had been halted in our way by the pandemic, as we had planned it in April 2022. But it is just because of the RUF Council and the unstinted support of Professor Rao and Yuvaraja that we again got this particular chance to host this event in 2022. So thank you again, RUF and all the office bearers. I must mention our deep sense of appreciation for our international guests, particularly Dr. Mihir Desai, Dr. Jihad Khauk, who will be joining us tomorrow virtually, day after tomorrow virtually, Dr. Amit Bhattu from University of Pittsburgh. We were a bit disappointed when we came to know that Dr. Omar Karim was tested COVID positive and he could not make here. We wish to thank him anyhow as he had offered his support, and we pray for his quick recovery. It requires a lot of planning and a bird's eye view and detail for a program of such magnitude, and I must thank that I'm being fortunate that I've been backed by the whole team of MPUH. Nothing is possible without the blessings of Guru. So thank you very much, Sabnis sir and Mahesh Desai sir for giving their advice, support and patronizing the event all throughout. A big thank you to the MPUH management. It has already been mentioned. All Board of Trustees, Chairman Mr. Rohit Patel, Mrs. Nandini Mirani, Mr. Pranav Parikh, and of course Medical Director Dr. Rastogi. My sincere thanks to our academic partner who will be seeing on one screen tomorrow, HCG Hospital Ahmedabad, and of course our colleague and dear friend Dr. Hemang Bakshi, who has offered his support for this program. There have been a number of up-downs during the preparation, as it happens in any of the programs. Our team at MPUH has stood steadfast throughout, and I must take a moment here to appreciate everybody. I would like to thank Dr. Abhishek Singh, Dr. Pawan Survase, Dr. Niramya Pathak, Dr. Batra. You must have realized, as mentioned by Dr. Sabnis, that these are the cogwheels on which the show will happen in the next 2 days. Thank you, Mr. Yatindra Sharma, MD of KHS Machinery, for agreeing to be part of this particular program and being so patient and waiting to deliver the keynote address. I would like to take this opportunity to thank Mr. Ketan Rawal, Mrs. Rita Desai for their guidance, help, and all the logistics staff, including Mr. Kalpesh Patel, Prakash Patel, Manoj Makwan, and others from the JPSC department. I would like to thank and give a special mention here, particularly to our industry partners, particularly from Intuitive, Mr. Mandeep Singh, country head of Intuitive, Mrs. Swati Gupta, who is the director, Dr. Bhupendra, and Leela from the marketing. Particular thanks to INTA Celeron, Mr. Satyanarayan Murthy and Mr. Surujit, Alchem Pharma, Mr. Surendra Pal, IPCA Laboratories, J&J, Mr. Jinu Panikar, Teleflex, Metronics, Nephrocare, Cipla, Sun, DRL, Glenmark, AstraZeneca, Lupin. They say that you enter the heart of all people through their stomach. Catering remains the soul of all meetings. Thank you very much, PH Recreational, from PH Recreation, Mr. Prakash Patel and Mr. Mihir Patel from Equinox Poolside Banquets, where we will be having the dinner today. At the end of the day, it's the family that matters. No words would be adequate and appropriate to express my feelings towards them, but thank you very much, my wife, parents, for all of them to be here. Nadiad is a small place, and in old days, people used to refer to them and correlate it with Malgudi. And hence here, I would like to say that if there are any logistic concerns, I would like to apologize. Yeah, I'm coming to it, sir. Finally, I would like to thank all of you, particularly before I end, I would like to thank Mr. Anand Peter, one and only Anand Peter, who has been holding the fort since morning and we would like to actually acknowledge him because he is the man of the day to go tomorrow. Finally, let the bouquets be for my team members and brickbats for me. I understand there can be many unsung heroes and supporters who have helped in a way or other. Unknowingly, if anyone has been left out, my sincere thanks. Thank you.
Now let us stand for the national anthem.
शुभ नामे जागे तब शुभ आशीष मागे गाहे सब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Please be seated.
I would like to now take this opportunity to invite the keynote speaker, Mr. Yatindra Sharma. It's a pleasure to introduce Mr. Yatindra Sharma. He is the Managing Director of KHS Machinery Private Limited. Just to give you a brief as to what is KHS Machinery, it is a joint venture with KHS GmbH Germany. And this is considered to be a world leader in providing turnkey solutions for packaging and processing of beverages and other food applications. Their clienteles include multiple global multinationals such as Coca-Cola, PepsiCo, Henken, Carlsberg, Nestle, Unilever, Parle, and so on and so forth. The company has got operations in Germany, USA, Brazil, China, India, and KHS India is being promoted by Mr. Yatindra Sharma as the Managing Director of KHS India. A few words about our esteemed guest today. He is currently the Managing Director of KHS Machinery Private Limited, which is an ISO company. It is a winner of multiple manufacturing excellence awards. Mr. Yatindra Sharma is associated with the Ahmedabad Management Association, GCCI and CII Western Region. Apart from this, he has got a Nadiad connection because he is an past alumni of the Dharamsiya Desai University, which is a technological university over here. And we are indeed proud to have Mr. Yatindra Sharma with us today. Please, sir.
Dr. Raval, Dr. Yuvraj, Dr. Rastogi, Dr. Muljibhai Desai, Mr. Rohit Patel, all other dignitaries, and my friends from healthcare sector. It is my pleasure to be over here in RUFCON, and it reminds me of a very interesting anecdote which happened between two literally, eminent personalities of English literature. They were on the evening function along with together Mr. Chesterton and Mr. George Bernard Shaw. So Mr. Chesterton gave a speech of more than an hour, and then Mr. G.B. Shaw was invited, and it was said that Mr. G.B. Shaw will give his address. So he gave his home address, and that was over. It is kind of a situation where I would not like to come between you and your dinner. We had already an overrun of more than 1.5 hours. Anyway, I will try to be brief and try to give you a kind of overview, because I have been told to talk about Make in India, whether it is myth or reality. But prior to that, let me compliment our healthcare warriors, what you all are, doctors. And if you go in retrospect, somewhere in 1947, the average life expectancy of an Indian was 42 years. Today, it is 74 years. And there is a huge contribution from your community to make life easier for many people of this country. And all credit goes to the advances which have happened in medical sector, medical profession. And if I talk about the kind of Make in India, I will come later. But let me give you some of the important points which I view as an outsider from your industry. If I look at healthcare profession, when we were into the college, in our times engineering was on forefront, medicines was on second priority, and if we look at our friends who were who have already become doctors, now they are into US, they are into various places. The kind of medical profession was more built on individual expertise, and the kind of support structure which was required to make it more efficacious, more result oriented. At that time it was more of the knowledge and the kind of experience what professional had, and on the basis of that they were able to give relief and they were able to treat their patients very, very efficiently, successfully. I mean, if you talk about role of technology, role of technology was there but very limited. Kind of blood pressure instrument, X-ray, stethoscope. Beyond that, as a young boy, I don't remember any gadgets what our doctors were having. But today, if you look at the kind of convergence of technology which has happened into all professions, the entire medical field has been taken upside down. Diagnostics have become so accurate. Even self-diagnosis is possible for every individual to examine his health condition. Likewise, you can check your blood pressure, you can check your glucose, now you can even check your cardiogram on your watch. All these things are available. If you talk about X-ray, which was a base examination technology for doctors many, many years ago, today it is not only X-ray, it is endoscopy, it is MRI, it is CAT scan, whatnot. So the point is that how this has happened. What is the role of technology? The role of technology has really brought in the diagnostic in your field very, very accurate. And that has given a huge amount of help to doctors to decide on next course of actions and medications and everything, where the surgery which was taken as one of the major tasks by doctors, it has become now a very focused profession, focused activity, than in terms of general ailments which were found. And now even the surgeries are done with least amount of blood loss. I was watching certain videos on, your tumor replacement and all that with robots. The blood losses are less, the operating time is also limited. You can now talk about doing so many things. Now how technology is progressing in your field? Let me give you two examples. Likewise, if you talk about new technology spectrum, it has got Internet of Things, it has got big data, it has got robotics, it has got, kind of additive printing. A lot of things are getting together. Now, if you look at that, the example one which I would like to give, that is the MIT Media Lab and Harvard Medical School. This research paper I read in MIT Technology Review magazine, where they developed a very interesting gadget where the sensor will go in your brain, and then there will be a sensor in your duodenum next to your stomach, and that will control your weight loss. Now how it is programmed, very interestingly. See, whenever we eat, the sense of fullness goes, it has got a lag time. Your stomach is already full, but you don't feel that it is full. And due to that, you end up overeating. And that becomes in kind of weight gain and kind of, your eating habits, they decide. I mean, apart from your physical activity and all that, your eating habits are main determinant of your weight in your body. Now, this entire program has been designed in a manner that if person wants to lose a certain amount of weight, that program is done in a manner that the fullness signal will go to brain immediately, and to that extent the person will not have desire to eat, and automatically he will eat less, and that will result into weight loss. Now it's a very amazing technology which has come in. Now similarly, if you talk about 3D printing, now you will be rather surprised to know that 10 years down the line, instead of human organs which you are talking about your transplant, there will be 3D printed human organs. And this will change the entire game plan, the entire spectrum of the way in which today what we are looking at, today the way in which we are finding solutions, those solutions are going to be different. Now coming to robots. See, robotics is something which has evolved over a period of, likewise we always define technology evolution in Industry 1, Industry 2, 3 and Industry 4.0. So when we talk about Industry 4.0, I mean it started from steam power to electricity, electricity to computing power to Internet of Things, robotics, big data, supercomputers, 3D printing. All these things together are creating an amazing technology spectrum, and that is going to take a lot of things into a different direction. While talking about robots, robots have been in use for a very long time. In medical field, I think the robotics has come maybe for last 20 years all over the world. But if you talk about robots, they have been into automobile industry, they have been into end packaging, pick and place packaging, kind of machine, where you have to pick out the components. So robots are multi-axis, 2-axis, 3-axis. In automobile industry, these robots are performing very high precision tasks of welding, of riveting, and these are on a assembly line where the cars are, turned out, maybe 50 cars in an hour, or maybe 100 cars in an hour, or 300 cars in an hour. So this is the kind of robot, whatever they are. Likewise, robots can also be handled remotely. Likewise, we are also using remote diagnostic. For you, your diagnostic is live. I mean, while you are operating, your diagnostic and actions are going parallel. While in our case, when the machines are down, we connect them on internet maybe 3,000 kilometers away, and then we try to find the solution and we diagnose and set the machine right. So point is that robotics today, if we talk about apart from healthcare industry, you will be rather surprised to know, I will give a very small interesting example, that in oceans, the fishing has come to a level where there is a drainage of sea life all over the world. And Canadian company has developed a robot which can go into a surveillance in sea, and all these trawlers which are not authorized to fish, if they fish, the entire data, record, everything through that robot. There is a boat where there is a robot which talks about multiple actions, where there is a sonar, there is also high definition cameras and internet connection with the central control room with naval guards, and this can be identified through robot and person can be penalized. I mean, that is the kind of advancements what they are happening. Now robots in medical field, it has been shown to you, and I am not going into the details of it, but the point is that, let me tell you one thing, that any technology which is developed, that is to enhance human capability to deliver the results what they have determined. If we feel that technology will supersede your talent, your capability, your decision making, I don't think that is going to happen. We have experience of using such gadgets, technologies, and we are very clear that this will enhance your capability. This will enhance convenience of your patient, because blood loss in a body of any human being, the blood is hardly 5 liters. I mean, that's what I've been told by you guys, so I know, I mean, it is 5 liters. Out of that, if somebody loses 200 ml, it's a huge loss. And if it is resulting maybe 5 ml or 10 ml, I think it's a huge advantage for a patient to recover. So that is the convenience what is being given by robotics. So I think that is very, very important. But if you go into the background of all these high technology gadgets, the cost of procuring such technology is so high that when you try to service your patient, the cost of servicing is very, very high. And that is where I come for giving you an overview on Make in India program and where are we, whether it is a myth or a reality. Because it is very important that any technological advance must give a kind of cost advantage. I mean, let us look at mobile telephony. The technology has given an advantage that you can even make call free on Reliance Jio, or you can make call maybe 5 paise for a minute. So that is the advantage of technology which is available to an user. Unfortunately, for many technologies in India, except Mangalayan, where India has advanced in a big way, if we talk about missile technology, we have advanced in a big way, the rocket building, cryogenic engines, I think we have done a lot of things locally. But when we talk about all this diagnostic equipment, when we talk about the kind of core sector, plant and machinery, and if we talk about Make in India program, let me give you an overview of why Make in India program was decided. It was dream of our Honorable Prime Minister that we should become independent in terms of providing all kind of technology solutions to our economy. And that's why he wanted all these global players to come and participate and make in India. But it was construed as, you know, India is looking at Make in India program of being an export economy. I don't think that was the whole idea. Make in India is to become independent. But when we look at the kind of requirements of Make in India program, the basic requirement is the ground foundation building blocks of Make in India program, that is technology components. Now when we talk about technology components, the technology in anything, whether you talk about your medical device, say it is a glucometer or a pulse oximeter, there is one part is materials. It may be plastic, it may be steel, it may be special, alloy. I mean, all these are materials. But the point is that beyond materials, now the entire construction of such solutions is done with high degree of automation, electrical hardware, software. All these things are put together and then it becomes a real effective solution. Likewise, today we were on to a Zoom call. Now Zoom call decides what? It needs a huge data center, supercomputers, it needs the high definition videography, it needs high definition routers, it needs the Wi-Fi infrastructure. All these things are requiring a high-end electronic hardware, electronic sensory, electronic, kind of what you can say microprocessor construction. Likewise, just to give an idea that we make machines which are worth 10 crores or even 20 crores. When we go to the cost of manufacturing this part of the machine, if we can decide in terms of mechanical and electrical and automation. You will be rather surprised to know that the total cost of the machine what we manufacture, the representation of automation, electronic hardware, all these points is always to the level of 70%. They rule the construction of my equipment. Similarly, when you are handling any robotic surgery setup, or you are handling an automatic, laparoscopic device, or you are handling MRI machine, it has huge amount of this technology components. And today, if you look at that ground scenario, and if you look at that, our capability to produce and, provide to all these solutions, in my view, it is zero. So for me, Make in India program today is a myth. Why? Because it needs a high capacity sensors, it needs high quality cameras, it needs, good quality data centers, it needs a very good quality internet infrastructure, it also needs, electronic chips, semiconductor chips of all kinds of variety. And this is where India is not having even a simple solution which is being manufactured in India. Let us talk about your robotic arm. It moves with a certain speed. It is not an indexing device. You can control the speed. You can make it bit fast. You can make it bit slow. Now what is the basic element behind that? It is a servo motor, special small servo motor. With the current application, it will increase the speed, it will decrease the speed. And today, if we talk about servo motors, there is not a single servo motor manufacturer in India. These are all imported by companies like Siemens, all these companies, Rockwell, they import. And they brand it as Siemens India product and sell it. Today, if you talk about your cath lab, even the lighting arrangement of your cath lab, you cannot procure it locally. Because that high degree lux and reflection-less lighting, because while you are operating, you cannot have lighting with reflection or shadow. Am I right? The lighting has to be absolutely crystal clear. It cannot have shadow or reflection. And if you want to have that kind of lighting, there is not a single player in the country who can provide that kind of lighting solution. So point is that how can we reduce the cost of such technology for use in various fields? The first decision which has been taken by Narendra and his team, that is to go for silicon wafer manufacturing facility, for fabrication shop, where Government of India along with a private sector company, they are going to invest about 80,000 crores to set up this facility. So that will become the base foundation for this kind of technology requirements where a microprocessor chip will be manufactured. Let me give you a very interesting overview. On software side, whether you talk about microprocessor chip design, India is number one. If we talk about the most complicated software which is used on any medical device or any equipment, India is in forefront. But when we talk about getting that hardware in place, we are nowhere. So that is where we have to do a huge amount of homework. So that is the first thing which is coming up. Second, some of the things which have now triggered by scale committee, where interestingly I was part of that. And scale committee has already recommended a production link incentive scheme, which is going to drive many sectors for next 5 years in a big way. And let me hope that the kind of talent which is coming out from India and the kind of educational improvement which is now being taken up by Government of India. I mean, we all criticize our education system, rightly so at a primary and secondary education level. But if we talk about higher education, India has got quality of education in many institutes. Even if you talk about not only premier institutes, but even category 1 institutes, today they are offering very good level of education. So the point is that with all this, I am not pessimistic about our Make in India program. If I talk about on a current date, it is a myth. There is a huge amount of homework to be done. But I think we are getting into right direction. Government is in a listening mode. They are willing to do a lot of things at a time. And with that, I see a definite result which will come up in next 5 years. And let me hope that all equipment what we are buying today for healthcare industry, whether it is a cath lab, whether it is a robotic setup, or whether it is, you know, your MRI machine or a CAT scan machine, we hope to have it cheaper in next 5 years. With that, let me thank you very much and wish you a good night and see you again. Thank you very much.
Well, thank you everybody for the patient listening. Well, this is your host and those signing off for the day. We'll meet you over the dinner.
So there are taxis parked in the hallway. Our representatives will be there to guide you into the car and take you to the venue.
Let it be now.
The venue is just 5 minutes. It is Aquinos poolside restaurant. So we may have to wait for a few minutes down in the hallway.